I'll be talking on this topic which you've asked me to talk about, and I thank the Merck Foundation for asking me to speak on this topic, whether HC should be a standard or a routine IVF procedure, or it should be, as opposed to be conventional. So if I can have the first slide on this topic, it will show that the Merck Foundation African Luminary is being held today, and I've already been given the topics to speak about. Slide is changing. Can you please change the slide? It's not going. I have nothing to disclose, and I will be talking on these outlines. History of IVF is always important, and of ICSI. And then we talk about the key points, whether ICSI is to be done or not to be done, in regards to the non-male factor, the poor responders, and on the explaining fertility, as well as advanced maternal age. Then those key points will be analyzed, and then I will give you a conclusion or take-home message. Historically, IVF really, it's always said that there, apart from the Nobel Prize that was given to Steptoe and Edwards, who pioneered IVF in 1978, the work of Chang and Yamaginachi in 1969 is actually what has led for the foundation for us to do IVF, because they were the first that described the process of sperm capacitation, which enabled us to mimic what happens to the sperm in the fallopian tube. And that is what we simplify as sperm washing. And that technique was used by Steptoe and Edwards, of course, in a natural cycle. But the work of Andrew Charley in 1977 and Gilman, they isolated the LHRH hormones, and that enabled us to be able to use controlled ovarian stimulation using Suprefact and the rest of it. And Ashiro and Blake followed that by the FSH positive Fit Black in 1978 as well, which enabled us to give exogenous FSH and cause multiple ovulation in an individual or even in the mammal. And that is what is used as FSH, Gonal-F, and all the rest of those products, gonadotropic hormones. Then this was followed by the work of Carl Wood in 1980, where they pioneered IVF, rapidly followed in 82 by Howard and Georgina Jones in the United States. You can see that US was behind the rest of the world because they had banned IVF before that period. And this was followed in Lagos, Nigeria in 1984 by Ashiro and Blake, by their first pioneering work in IVF in human, and their success in 86 and 89. Next slide. Yes. This is conventional IVF on the right, on the left screen, which is used by partner Steptoe and Edwards 78. You could see the sperms swimming in, and then there's the acrosome reaction. You inject about 50,000 to 100,000 sperm cells, and they swim, and only the lucky one will be able to penetrate into the oocyte. And this has its advantages and disadvantages. By 1992, Gianpiero Palermo was able to describe the so-called acrosome reaction in which a single sperm cell is injected, and that is the ICSI. And that uses the injection pipette, and you could see. Now let me give you the global statistics of ICSI. The areas in yellow are the countries where IVF and ICSI are practiced. And you could see the whole of North America, the whole of South America, the whole of Europe and Australia, and you could see those parts in Africa. This data was updated, has not been updated to 2022. And if anybody here in Africa is practicing ICSI, please email me at denrelay1@gmail.com so that I can have those data documented. And you could see on the right side of this screen are the countries where you have the ICSI constitutes more than 80% of their IVF. And you see quite a lot of that in South America, in Spain, and some parts of Europe. Next slide. And then some people are actually doing, 90 to 100%. I could say that, in fact, in our own clinic now in Lagos at Medical Center, ICSI is virtually 100%. This is the global statistics. Now, to ICSI or not to ICSI, several works with different focal points have been published where they were comparing whether these two methods of insemination of the oocyte, should it be conventional or should it not? This came from some early publications that were trying to condemn IVF, and then also when ICSI came, also trying to condemn ICSI, showing that whether there were abnormalities or not. And data have now shown that whether you do IVF or ICSI, the presentation of abnormalities is the same as in the normal population. And they were comparing now the results in patients who had ICSI for non-male factors, because the original indication for ICSI was for male factor, and then for poor responders on explaining infertility. Now you could see here in the non-male factors that ICSI, that is intracytoplasmic injection, increased the fertilization rate and good quality embryo formation in patients who did not have male factor. And you could see the statistics here, so that if you see the ICSI fertilization rate was almost 71.3%, and the quality of embryo was 64. And so it was statistically significant that you find out that the ratio was the same. In terms of the good quality embryos from both sides, there was no significant difference. Next slide shows in poor responders. When you compare ICSI in these people, in patients lower than 39 years, that is in the young group, the so-called gold standard, you could see that ICSI was highly significant in when they have subfertile sperm and single oocyte. You could see that it was 85% and 44%. Because when you have single oocyte or subfertile sperm, you don't want to be joking and risking the situation. And in the older patient, it was also significant, but not as significant as in the young people. Next slide. This work was also published in Fertility and Sterility in 2013 by Johnson and his group, in which they looked at unexplained infertility. Can you use ICSI? Next slide will show you that if I can have the next slide, you could see that the weight of the statistics was shifting to the right in favor of ICSI in all the cases. And so, therefore, you find out that in this unexplained infertility, you will want to do ICSI if you have the infrastructure to do it. The next slide looks at the case of advanced maternal age. This was a study by Sundaram in 2018 and also published in Fertility and Sterility, where they are comparing the rates from ICSI conventional among women with advanced maternal age, male factor infertility. It was a meta-analysis, and 7 studies were analyzed. These women were above 38 years old. The finding revealed no difference between conventional IVF and ICSI fertilization rate in this group. You could see also in the risk ratio analysis and 95% confidence interval shown in the graph here, so that when you have advanced maternal age, you can give what you want. Next slide. This slide is the take-home message from this presentation, based on scientific documentation so presented, that conventional IVF is less expensive, it's low-cost IVF. It's less invasive, it's more physiological, there's less exposure of the gametes, and less technique and experience is required, and is suitable when the sperm is normal, and it's the oldest IVF technique. And if you are starting IVF in a center for the first time, you go with conventional IVF. On the other hand, ICSI is good when you have advanced, matured in this system. It increases your fertilization rate, it decreases complete fertilization rate failure, and it increases pregnancy rate in patients with disorder of the zona pellucida. It prevents contamination from DNA from the sperm, and also, and when you are doing PGT, you have to do ICSI, may produce better quality embryos than conventional, and is suitable for male patients with poor sperm. This basically concludes your take-home message, and so you know the reasons for this. And the references have been so presented. Next slide. And I thank once again the organizers for asking me to make this presentation, and I thank you for listening.
Thank you so much, Doc. Prof, I just have one question. In your experience, where are we at when we're talking about sperm IVF when it comes to the men, especially in the Black community? Can you give us your experience in your country? Is there understanding on the field? Can the laymen understand when we talk about IVF and fertilization?
Yes, there is a lot of awareness when it comes to men now. Also, I would tell you that with the development of ICSI and realizing that having low sperm, or even having no sperm where we can go and remove the sperm from the testes by TISA, it has encouraged more men to come forward now for infertility. I think male factor infertility was under-informed and underpopulated. And now that people are now having information and reading in the newspapers that a man with low sperm went to the clinic and they got the wife pregnant using this technique, because the problem with men is the fear of failure. If they now know that there's a solution, they come out and they take the treatment. And I think it is important, it's a very important question that you've asked, and it is important for us as practitioners to educate our population in our own locality that there are solutions for male infertility, and therefore come forward and it can be treated. Thank you.
I was asked to talk about infertility prevention and male infertility awareness. We know that infertility is the failure to conceive after at least 12 months of sexual intercourse without protection. But for WHO, it's a public health problem. In many sessions, we talk about couple infertility our attention was focused to female infertility, female member infertility. In sub-Saharan countries, the fertility is mostly for tubal origin due to infection. And most of the time, we've forgotten to talk about the male partner. That's the reason why for the current presentation, we'll talk about male infertility. If we define male infertility, you can say that the male infertility is related to one or more factors.
Dr. Vasudeva, it was
Abnormal
very
semen
wonderful
quality
presentation.
and also functional parameters of
in
semen.
one slide you mentioned the
Female
well,
and
being
male
patient.
partner share
Is it
equal
there?
responsibility. Semen analysis is the most important investigation to diagnose the male infertility. For WHO,
Thank you,
many
Professor.
manual was published
I
about
am
the
Dr.
examination
Tabo Jami from the
processing
Gambia.
of human semen. To
World
set the
dengue
basic
is not very commonly seen.
characteristic of
We have mosquitoes a lot,
semen,
but malaria is the commonest condition
human
we see.
semen.
You mentioned in the
We
last
see
2
that
decades there has
it
been an
wasn't
old
easy
increase
to
in the number of
establish,
dengue
to
cases.
make the diagnosis
In
of
one
male
slide I saw
infertility.
vaccines being introduced
That's
in
the reason
2015.
why WHO
What could
has
be an
published
explanation for this
many
increase?
editions. From 1980 to 2021, we have 6 editions. It means that there's it is not easy to establish the male infertility properly. And for the semen analysis, we have some parameters that we can take in account to say about the male infertility. We have the volume of the semen, the total number and the concentration of semen, the motility and the morphologically aspect of the sperm that we can take in account to say about the male infertility.
Thank you so
And
much
also, to
for
make the
the brilliant
diagnosis,
presentation. I'm
we
Dr.
have
Desmond
to
from Sierra Leone,
combine
and
the
over some years back,
abnormal
I followed up
parameters
on an outbreak
and
of
to
dengue
evaluate
in Central
the risk
America, where
of
we did
having a male
an outbreak
infertility.
investigation.
If we
And
have
we
only
saw
one
dengue 1,
parameter
dengue
was
2, and
abnormal,
even we saw
we have
cases of
almost
the hemorrhagic
the
dengue.
risk was multiplied by 2. But if we
Back
have
in
parameters,
Africa,
the risk can climb
as my
to
colleague was saying, we have
15
cases of malaria
multiplied by
and
by
also
15.
yellow fever, which is
That's
also
the reason
caused
why
by
to make the diagnosis is not easy.
Not
if
so.
you have to
And but
estimate the male
we are not
infertility.
following dengue.
Now, what was the risk
The
factor of
atmosphere or the conditions within the continent might
We
or
have
might not favor
some demographic
dengue. So
value,
I really want to know
like
over the past years,
age
maybe you have
of
done a
the
lot of
partner,
research or interacted
obesity,
with several other colleagues,
the lifestyle, the diet,
was that in Africa
alcohol
actually
intake and
we are not
smoking,
seeing
and
cases
also
of
the
dengue.
treatments
I've worked,
that the
I think, for
partner
some
have
few
received.
years.
And
I've
Africa
never seen a
the
case
problem of the
Sierra
pollution.
Leone. So a picture that it
And also the pollution of our rivers and the environment.
With all the-
environment. If you see the age of the partner, the increasing of the age go with the decrease in the quality of the sperm. If you see the hormonal production, we see that with the age, the testosterone are decreasing with the age. And also the problem of sexual dysfunction can appear. And the morphology of the testicular can also decrease with the reduction of the number of the cell, the Sertoli cell and the Leydig cell. Another problem is the genetic problem, raising the problem of sperm DNA fragmentation with age and also aneuploidies. Secondly, we have the problem of obesity.
Thank you very much
is
for the
sometimes
presentation,
associated
Prof.
with diabetes.
I'm Dr. Ngonya from Zimbabwe. I
Previously,
noticed that in your presentation
obesity
you
was
mentioned
a problem
that
of
there
developed
has been
countries.
in the past 2 years,
But
2020, 2021, some
nowadays,
form of decrease in
more
terms
and
of
more
in
in
terms
sub-Saharan,
of
but
dengue.
in
I just wanted to find
developing
out, is this
countries,
an absolute
we have the
decrease in
problem
terms of the cases that are
obesity.
notified, or this is a decrease
We
in the
start this
overall
problem
incidence?
among
And
couples
secondly,
who are
what
seeking care
factors
for
would you
infertility.
attribute to the
We see
decrease?
that
Is there a relationship
progression
between
of
COVID?
the
Is there a
BMI
relationship with
climbed
movement
of
restrictions and
40%
so on?
per
And do
year.
we have any particular studies that we have
That's the
done
reason why the
that
problem
might
of
actually
obesity
confirm
is also the
or
problem
sort
of
of like
the developing country nowadays.
sort of like imply
How
that we have
obesity
had
can
a
influence
decrease
the
due to such and
fertility.
such factors? Thank you.
We know that in infertility situation, we have the resistance to leptin. And also the adipose tissue are resistant to insulin. So that the resistance to insulin led to the reduction of the production of hormone, namely testosterone. And also in adipose tissue, we have a high activity of aromatase that transform this testosterone to estrogen. The decreasing of the amount of estrogen made by feedback negative reduce the secretion of testosterone. That's the reason why in this, the situation of obesity, we have the problem of hyperestrogenic and hypoandrogenic situation. Another problem is epigenetic problem we have with obesity, the problem of the alteration of gene expression, some important gene for expression. Another problem is the chronic inflammation with cytokines who are liberated. Cytokines have a deleterious effect to the sperm, but also erectile dysfunction we have also with the problem of obesity. And please, slide. The strategy for the obesity, we have the problem of diet. We can use the diet to reduce the problem of obesity. Exercise. Exercise, we need a moderate exercise. If we have excessive exercise, we can have also the problem with reproduction system. And if we have the problem of morbid obesity, we can go for bariatric surgery. Slide, please. Now we have the problem of infection. If you have the infection of anexial glands, like prostate and others, we have the problem for leukocytes, which liberate many reactive oxygen species that can attack the sperm membrane, also alterate the DNA of sperm. Another problem is the problem of the cytokines. As I have said, we have a deleterious effect on the spermatozoa. In our region, also, we have the problem of infection, namely the sexually transmitted infection with chlamydia trachomatis and gonorrhea, with their long-term consequences like obstruction of spermatic channel with azoospermia. We can prevent those infections by using the barrier method if we have the problem of unknown partner, and also the diagnosis have to be made earlier, and the treatment can prevent the consequences of infection. Lifestyle, the problem of smoking and alcohol intake and the stress, the three are known to have an effect on hypothalamus, pituitary, and the testis axis. It inhibits the functionality of this axis. The problem of the cell phone, the using of the cell phone, we have radiation that is deleterious for the sperm. For the caffeine, in the literature, it isn't very proved that caffeine have a deleterious effect in male infertility. But some say that if you take a large amount of caffeine, it can also exert a negative effect in spermatogenesis. I said about intensive exercise that can lead to the reduction of the secretion of leptin with a bad effect on hypothalamo, pituitary, and the testis axis. To prevent this, relate to avoid these factors. Another factor is, slides please, the problem of chemotherapy. Nowadays, with the use of chemotherapy, we have some young people who are free of their cancer. They like to have baby. But most of the drugs used for to treat those cancer are gonotoxic, namely the alkylating agent. So now, with the evolution of the science, oncofertility can take care of these patients by cryopreserved their sperm. Slide, please. And the problem of environment, that's a very big problem nowadays. Essentially the problem of endocrine disruptors and also the problem of the pollution. We have a bisphenol that we find in the plastics and the paraben in the cosmetic products and the phthalate, what we eat. Those endocrine disruptors have an impact on the hormonal functioning. It can stimulate or inhibit some hormonal effect. The problem of the pollution, especially in the region where we have the mining industry. The rivers are polluted by heavy metal that are consumed by fish, and also for the lack of clean water, many populations go and take this water. All the heavy metals have a germinal cell intoxication. To prevent is to avoid the contact with this product or to reduce this product. Another problem is the problem of genetic etiology of infertility. The numerical abnormalities, like Klinefelter syndrome, the structural abnormalities, and also the mutation of some gene. A study made in 1999 by Merck showed that among the 198 men with idiopathic azoospermia, 34% have the problem of the cystic fibrotic transmembrane conductance regulator mutation that are responsible for the congenital bilateral vas deferens absence. Thanks to the science, now with the pre-implantation genetic testing for aneuploidy or for structural and also for monogenic disorder, we can avoid to transfer the embryos with those abnormalities. And the last is we have the problem of varicocele. That's a dilatation of papilliform venous plexus. 15% of men have this problem. But the problem with that, you have the accumulation of reactive oxygen species and the toxin from adrenal glands. All of those problems have an impact on the sperm. To prevent it is the diagnosis of the varicocele earlier and to go for varicectomy or to go to urology the treatment. In conclusion, we can say that male partners have the same level of responsibility as the female for if the couple infertility. The male infertility evaluation continue to be improved, and the risk factors are now well known, and we have to avoid those risk factors. And we need to reinforce the awareness for male infertility to avoid the consequence of preventable cause. So I can't end this presentation without announcing that we have a Congress of Giraffe in DRC on February 2023. Thank you very much for your attention.
I'll try to see if I can make mine shorter so we can catch up on some of the lost time. My topic is the cryobiology presentation of maternal and paternal inheritance. That's equivalent to embryo cryopreservation. I have nothing to declare. First, next slide. Cryos is a Greek word meaning cold freeze. And this is where embryos are frozen to minus 195.79 degrees using mainly liquid nitrogen. And this stops the biological activity within the cell and puts them in a form of coma. Next slide. A bit of the history of cryobiology. It dates way back to the 17th or 18th century. The first frozen gametes were in animals, and it took another century and a half before frozen stored sperms showed some motility. Then half a decade later, the first human pregnancy was announced by Truson and Moore in Australia, but that pregnancy didn't make it to term. The following year in Netherlands, the first birth from cryopreservation was announced. Next slide. Then in '86, the first pregnancy with frozen thawed oocytes after conventional IVF was done. 4 years later, when vitrification started, successful pregnancy and births after vitrification of embryos was then announced. 6 years later, with ICSI out now, first pregnancy from frozen thawed oocytes that were ICSI'd was announced. And then 3 years later, 1999, pregnancy from frozen stored mature oocyte after in vitro maturation. Next slide. What is the principle of cryopreservation? This is to preserve the cellular viability by arresting them in a state by raising the intra and extracellular viscosity. So you stop all molecular diffusion or chemical processes and prevent the cell from dying. You keep it in coma. Next slide. But this cooling causes ice crystal formation and increased salt concentration, which could lead to cell death. So you add certain cryoprotectant agents to the freezing medium. Those are some examples: DMSO, ethylene glycol, glycerol, or propanediol. They act by disrupting the hydrogen bonds in the water and prevent the freezing or crystallization. Next slide. The two types mainly documented: the slow freezing, which is what had been in vogue for most of the cryopreservation until vitrification came in. And this uses low concentration of cryoprotectants. The freezing is also slow to prevent crystal formation, but with fast warming rates. When you compare vitrification, which is the ultra-rapid freezing, they use higher concentration of cryoprotectants with ultra-rapid rate of freezing into a glass-like state. And then similarly to thaw, ultra-rapid warming. Next slide. Next slide. How do we get the gametes for this? For the eggs, it could be from retrievals, IVF or ICSI, the ovarian tissue banking or ovarian autografting. And then for the male, it could either be from ejaculated or surgically retrieved sperms. Next slide. And at what stage can you freeze? You can freeze day 1 in the unicellular pronuclear stage, or day 2 to 4 in the cleavage stage, or blastocyst stage, day 5 or 6. Next slide. And what are the indications for this? Well, 1, for storage of extra embryos after you've done a fresh transfer, so that you can use them later for other unstimulated cycles. You can also freeze to store when you realize that premature luteinization can lead to endometrial asynchrony, and therefore you want to freeze and do a segmented transfer later. You freeze for patients at high risk of ovarian stimulation if you should transfer and they get pregnant. And this might worsen the state of the patient. So you do it, a transfer in an unstimulated cycle. You can also freeze, as it was stated by an earlier speaker, so that you can complete your PGT process before embryo transfer. Some will freeze because of poor responders needing accumulation of embryos for pooling before a transfer. Next slide. Another indication for freezing is when you are going to go through gonadotoxic treatment like radiotherapy or chemotherapy, so that you can use them at a later stage. These days, people freeze when they're going to undergo gender affirmative treatment. They said it's politically incorrect to go LGBT, so we leave it as such. Storage may be done for the future, just to delay pregnancy, to embark on academics, career, or some people have to go through a military service. They don't know whether when they come back they can perform or produce, so you store before you go. Storage may also be done after you've had everything ready, but you find a very difficult embryo transfer process. What do? You have to store the embryo and then think of how you're going to get that embryo in the next time. And then, I think you ran over. Okay, let's move on. What are some of the benefits? You find that you get a more receptive endometrium in cycles which have not had a stimulation. That is why in some areas now they do a freeze-all, because they get a better endometrial preparation if it's not a stimulated cycle. They find they have comparatively higher implantation rates, less miscarriages, and then you have equivalent of higher pregnancy and live birth rates. And because you have more embryos that you can transfer in subsequent pregnancies, there's an increased cumulative pregnancy rate for these. Next slide. You have a decreased risk of low and very low birth weights, babies, decreased risk of preterm deliveries, and so the perinatal mortality rate also decreases. There's less risk for placenta previa and abruption, and therefore the APH or antepartum hemorrhage rate also is lower. Then it's been found out that the children born after embryo transfer are about 100 grams heavier comparatively. The other advantage is it allows for genetic testing of the embryos when indicated prior to transfer. Next slide. What are some of the disadvantages? Some of the embryos which probably would have implanted may not survive the freezing and thawing process, so you lose some embryos sometimes. And then it takes longer from the start of treatment to completion because you have the break to freeze before you thaw and transfer. And because of the additional cost of freezing and thawing, it adds to the cost of the procedure. The Danish group found that there was some increase in certain childhood cancers after frozen embryo transfer, particularly leukemias and neuroblastomas. However, this was in less than 0.01% of children studied. There's also found to be increased risk of preeclampsia in frozen embryo transfer cases and increased risk of placenta accreta. Next slide. There are certain factors that will control the success of this, and that's the efficiency of your cryopreservation program, whether you're using slow freezing or vitrification, selection criteria of the embryos to be cryopreserved, the methods of freezing and thawing. Then, very important is the synchronization between the embryo and the endometrial development. And then whether you're doing natural cycle or hormonal supplementation during the treatment cycle. And some of the patient characteristics like the age of the woman before transfer. There are a few dilemmas when it comes to embryo cryopreservation. The moral, ethical, and religious issues. There's issue with how you dispose of the extra embryos if you decide not to use them. Is the embryo a future child, or is it a biological material? That brings a lot of confusion sometimes, and people are not sure what to do. The unused embryo could be discarded, it could be donated to another recipient, it could be donated for research, or donated for educational purposes. I'd leave that to you to decide. Next slide. These are a few references. Next slide. Next slide. Thank you very much for your attention.
Thank you very much, Dr. Edem, for an excellent presentation. I'm Dr. Diana Ondieki from Nairobi, Kenya. So I wanted to ask about the issue of having an increased incidence of low birth weight babies and preterm babies after frozen embryo transfer. And less incidence, yet you have higher risk of preeclampsia and placenta accreta and such. So how do you get heavier babies?
It's thought that some of the cryoprotectant agents which are used tend to induce macrosomia in these babies. That is one of the suggested mechanisms that is thought that happens, but it hasn't been evidently proven that this particular cryoprotectant would do that over the other. But that's one of the thoughts for its causation.
Okay, thanks a lot, Dr. Hughes. I just wanted to find out the association between placenta accreta and frozen embryo transfers. Was there any particular explanation behind that increased risk? And is it just with frozen embryo transfers or even other forms of IVF? Thank you.
Yeah, they actually compared the incidence of placenta accreta between fresh embryo transfers and frozen embryo transfers. And it's been found out that you get a higher incidence with the frozen embryo transfers. This has also been put to the cryoprotectants. So, you see, you don't gain all the time, you lose certain things. So I think much as they give us the opportunity to be able to be flexible with when we do a transfer or to increase our cumulative pregnancy rates, there's also a bad side to it, which is increasing the fixation of the placenta at the time of implantation. I believe more research will reveal mechanisms to reduce that in the future. But that's the realization that when you do the statistics across, you get more incidence of placenta accreta after frozen embryo transfer than after fresh transfer. Yeah.
And also the problem of the lack of corpus luteum. The corpus luteum for the preparation, if you use only the preparation with estrogen and progesterone, without corpus luteum, we have the problem, many problem of the corpus luteum, the absence of corpus luteum.
So one is artificial, one is natural.
Thank you. I'm sure everyone is wondering, what is the psychiatrist doing here? We thought it's about infertility. It's good? Okay, great. So, as usual, I've noticed even from yesterday when we started, the discussion is just on the biological component of infertility. The focus is just let the baby get in or get out, whichever way you want to look at it. Even through the conversations yesterday, I only remember one person alluding to the mental health aspect when it comes to infertility. That's where we come in. I know even amongst the medical practitioners, mental health, there's a lot of stigma towards mental health, but this is something that we need to normalize. And when we speak about infertility, there's a major component of mental health, especially in the African culture, because the culture brings out so many aspects which have a very negative impact to your outcome when you're trying to achieve fertility in these women. I think there was a lot of discussion yesterday around the stigma, the expectations, the stress around infertility. So just imagine what that does to the woman. And there you are, the fertility experts, OBGY experts trying to help this woman achieve something, and your focus is just on the biological component. Then we miss out the mental health component, which is a great compounding factor to your presentation. It affects every aspect, from your hormonal levels, to the psychological component, to the sexual component of this woman. So I'm going to touch on about 3 different aspects of mental health when it comes to fertility in general and reproduction. So I'll start with a few statistics. I think I won't focus much on that because I think a lot of it has already been discussed when it comes to statistics, but only to mention that infertility is actually a common presentation, not only in the developing world, but in the developed world as well. And I think a lot of misconception is that the stigma is mostly just in the developing world. But no, it's actually everywhere. Next slide, please. Yeah. So 1 in 5 women are actually experiencing a common mental disorder. So the women just in general are already predisposed to mental health issues compared to the male folks. Though when you bring the aspect of infertility, that makes the presentation even worse. And other than just the psychological and social component, for women, the other aspect of hormonal changes also comes in. I'll take it back again to the African culture. A lot of expectation from women. That as well adds to the stress of women's presentation. The cultural nuances, I won't go further into that because I think we discussed a lot around that yesterday. Next slide. So, again, just to emphasize, a lot of the focus has been on the biological component, but who's looking out for the mental health component of this woman. And let us take into consideration that when we're talking about health, it's not enough to think about the physical health of a woman or any human being to start with. WHO, a lot of us professionals sat and we decided to define what health is. And we finalized and we agreed that when we talk of health, it's both the physical and the mental health component of a presentation. Next. So, of course, when we look at these presentations, first to start with, I'll touch a bit on depression just in general. Because just depression on its own is a major compounding factor that can bring about infertility. Let me give an example of a woman who is stressed, she's depressed, her sexual libido is affected, she's hopeless. Do we feel this is a woman who applied herself to get fertile? No. A lot of time people are focused on, oh no, the woman hasn't given birth. But a lot of medical practitioners are not quick to say, what else is surrounding this presentation? And when we talk about such presentations, even if we manage to get a woman pregnant, her pregnancy, how does that present? Postpartum, how does that present? Postpartum depression. The woman finally gets the child and it's like, but she's not happy, she's not depressed. What is going on? Anxiety sets in. So, of course, infertility and hysterectomies and various presentations can affect the presentation of an individual. But even just a woman who has a traumatic conception or a very eventful delivery time or perinatal period is at increased risk of postpartum depression. Next, please. So I won't get into the details of depression. I believe if we're medical doctors, we all have at least a good idea of that diagnosis. We can go to the next slide. Though I think something that I would like to emphasize is that a lot of times, even as medical practitioners, one thing that we tend to forget that depression is not just a psychological or social issue. It's actually got a biological component. I think the sooner we know it, but we don't think like that when we're approaching our clients. So when you're thinking of all those hormonal changes in this woman, remember those same hormones, those same neurotransmitters, they'll affect this woman's mood. So let's start normalizing having a holistic approach to these women. So the biological component, that's why we have medications for depression. And they work. They really do work. So let's normalize that. And of course, there's also therapy. Let's not undermine psychotherapy. It does wonders. Just talking, we women are special. A lot of talking can help. But even better, if it's professional talking, psychotherapy, it does great. So even as we are seeing this woman, it's not enough to just talk to her, encourage her in your office for 5-10 minutes when you give her the results or the next steps that you're taking towards her fertility journey. Refer her for therapy. Refer her to a psychiatrist. Let them assess her. Other than this presentation, what else? What other comorbidities is she presenting with? Next. So postpartum depression is actually quite common, and it's usually missed. But remember, when we are taking care of the woman, it's not enough to look out for the woman alone. We also need to look out for the newly born child. Because after all the efforts for this woman to produce, you have that baby and we lose that baby because this mother is in her own world at that particular time, various stresses presenting around this delivery, and she kills her own child. Or she's quite negligent with her own child that her child develops various medical presentations. So all the efforts that we would have made to get this woman pregnant goes down the drain. So just to highlight a few risk factors, which I think we're already very aware of, I think my emphasis is just to say, let's look out for these things. These are things that we know, but things that we tend not to give attention to. Next. So, I think on this slide, something that I just want to emphasize is a lot of times as well in our culture or in our practice, I don't know about you, it's been a while since I did any obs and guide or any delivery, I think over 5-6 years ago. Though I think a lot of focus, even when a woman comes, we're very good at scheduling the appointments after delivery, but a lot of it, again, the focus is physical. Physical. Okay, the wound, okay, any bleeding? What about emotionally? How is she doing? How is she managing to take care of this baby that we've worked so hard to bring to life? So a lot of times, again, we take for granted that it's just baby blues. So baby blues is usually associated with fatigue, a few mood changes here and there, but those should be ameliorated like in at least 2 weeks. The woman should be better. But if we find that over 2 weeks, the woman is still not fine, she's still not coping well, there's need to explore more. And let's be deliberate, even to get counseling, to guide, for this woman to get support. Remember again, even for African and Asian communities, for a long time, we had a setup where we had the whole community supporting you and taking care of you once you deliver. But things have really changed now. I deliver today, I'm in the city, my mom is not coming to sit me down or to help me through that journey. She's also got her career and her life. So it's me, my nannies, my husband, if he's really helpful. So meaning the dimensions around delivery as well have changed the more we've modernized. So it's very important to look into that. And that's why even after delivery, there are reviews at least at about a week, at about 2 weeks, at about 6 weeks. So of course, if these symptoms exceed 2 weeks, that already is a red flag and it calls for us to explore more. Next. So this was just me trying to highlight something. Then again, very important, once we pick up any suicidal ideation, it's an emergency. We admit this woman away from her child, or any negative thoughts towards her child. We should never underestimate that. Any negative thoughts towards the child. Because remember again, we worked so hard. She carried this child ideally for about 9 months. Everyone was taking care of her. I don't know, 1,000 antenatal visits. Then there she has the child. Then this woman has very negative thoughts towards her child. That's not natural. And it's something that we should actually explore for. It just takes a minute or two. Just like the way we allocate time for every other assessment, let's allocate even a minute or two during our consultation to just ask on the psychological and mental health component. Next slide, please. Okay, so again, we are experts at the same signs and symptoms. I will not take my time on that. Next. Yeah, I think I've already talked about the interventions. And I think that's why it's important to refer as well, or to send for a consultation, liaison psychiatry, or just request maybe for a psychiatrist or any mental health specialist to just come spend some time with the lady if for some reason you're not able to give that extra 10 or 15 minutes to speak with her. So someone just screens this lady for other possible presentations. Next. And like that, she'll be able to get the treatment that she needs. So I'll then now touch on something that we've been speaking a lot about, which is the infertility stigma. Again, I think my emphasis is, yes, as we are doing all those procedures, as we are trying to get this woman to that place to reproduce, are we considering her mental well-being? It's very stressful. In my practice, the women who I've attended to concerning infertility are very stressed, depression, anxiety. And the whole stress is working against what you're trying to achieve. So, interestingly, this is a woman that we want to reproduce, but she's so stressed that she's got all these negative chemicals running through her body. Her hormones are also messed up. So it's like there's something working strongly against what you are trying to achieve as fertility experts. And if we don't give it the attention that it deserves, to be like, I call it a bottle, then you put a few little holes and slowly it's just there trickling. You keep putting water and it's just trickling out. And I think an emphasis as well, of course I've mentioned a lot around women because I think for a long time, I think a lot of emphasis has been on women, but this is for both men and women. I think for the men, it's even worse. If anything to do with infertility comes up, it literally breaks them. So trying to build that ego back for him to be able to apply himself is usually a lot of work. It takes a lot. And that's why even, I think yesterday, there were conversations to say, let it go the couple direction. Very important. Both of them should be involved in the process. Both of them should be each other's support. So even for women, it's been shown that if the husband is of great support, it tends to be very helpful. Next. Yeah. It tends to be very helpful. Sorry, my slides are a bit... it tends to be very helpful. But this same process of infertility, all these processes that you're talking about, it's such a prolonged process that it's very stressful to the woman. She's very anxious. Will it work this time? And because when you're getting consent and everything, you have to explain to them the percentages, failure rates, they've invested so much money, they're stressed trying to find money for the same procedure that they want to undertake. So there are all these factors. So therapy, psychotherapy, or some psychiatric or mental health support is very important in these presentations. Next. Yeah, so I think when it comes to the rest, next, I think I wanted to emphasize something on education, since we're talking about education. So interestingly, for the well-achieved women career-wise, I think they tend to deal with it better, especially in our cultural context, compared to those women who maybe they're housewives or stay-at-home moms or women. I think the infertility aspects really dawns on them very great. Though interestingly, even for the career women, especially in the African culture, just the fact, and I know sometimes we can be very loose in conversations with them, at least you're doing well with your career, For some reason, sometimes that just becomes a shadow. And their focus, despite all the career achievement, business, financial achievements in their life, all that just becomes blurred. So even for us as fertility experts, as we are talking to these women, let us be sensitive. Let us be very sensitive in what we say, how we say it. Next. Next. Next, I think I've already spoken into that. Yeah, I think just the emphasis of anxiety, depression, hopelessness, and significant stress. And I think let me highlight the religious component. I think for a long time, I think we've had discussions of religion, no religion, involve religion in that or not. So again, a lot of research in the mental health field has shown that religion has its place. Especially in Africa and Asia, I think there are a lot of religious components. So religion has its place. Even when a woman comes, she's talking about that, oh no, I'm also praying. There's no need to discourage that component. Of course, you focus on your medical aspect, but if that's a coping strategy for them and it will help them, if they believe it's their faith and all that interaction, allow them to use that because it could be a coping strategy which will work good into what we're trying to achieve on the biological component. Next. Then next, I think I've spoken into much of this. Yeah, I think this again is highlighting on stigma. Okay, next, thank you. Yes, so the stigma, and sometimes unfortunately it even comes from us, the professionals. Sometimes when we've been doing something for a long time, we take certain things for granted, or it becomes more of mechanic. It's just another woman, it's just another man who's walked into my office, who I'm trying, it's like your goal is to achieve that fertility. But we have to appreciate what is this individual experiencing. First, self-stigma, then again stigma from the community and those around them. Sometimes it's even at the fertility clinic. Yes, woman, what, they even mention the name. Yes, fertility, to the lab, next, sample. What is going on? This thing is very sensitive for this individual. And further, when we talk about sensitivity, remember when a woman or a couple are dealing with infertility, they're able to tell as a couple, right? But that is usually private. But once they come to the health facility, it becomes a public issue. And there's also stress related to it becoming a public issue. And different people take that very differently. Next, so even as fertility experts, let's highly consider that in our approach. Next, I want to rush to the postmenopausal aspects so that I can close with that. So, postmenopausal women. Of course, we've talked a lot around the younger fertility, reproductive age, but even the postmenopausal women, a lot of factors coming in. Every stage of life is important. Just different stressors, factors, considerations, and priorities. Nowadays, we've actually seen a lot of women in their older age wanting to reproduce. For some reason, for a long time, they were like, no, I'm fine. They hit 45, they're like, no, I want a child. Or maybe others, they realize too late, they're already postmenopausal. Sorry, ma'am, it's a bit difficult now. Are we sensitive to those presentations? Then, just a minute. So, again, in the postmenopausal, that the two components. There's the biological component, there's also the psychological component. So please, let's not forget the psychological component. And when we talk of the psychological component, remember, even the biological component feeds into that, the hormonal aspect. Hormonal treatments. Hormonal treatment has been shown to be helpful, but usually in the short term, but we're not very sure, it's very inconclusive when it comes to the long term. But that as well can help. But please, even for the postmenopausal women, let's factor in the mental health aspect and psychological component in their presentation. Thank you.
Good morning. Thank you for that riveting presentation. My name is Dr. Paul Koigi from Nairobi, Kenya. And I would like to raise a question on the basis of two paradigms. Now, you've pointed out that fertility, even when successful, can be associated with adverse psychological affection of the woman's welfare. And on the other hand, on the opposite end of the spectrum, infertility is definitively associated with stigmatization and ostracization of the women that culminates in intimate partner violence a lot of the time, and socioeconomic disempowerment that is disproportionately borne by women. Now, given those two paradigms, now my question is, what can be done from a public health standpoint to address this issue? Because these problems are actually substantially underreported, and on average, it's thought that slightly less than half of the patients who are affected by these problems seek care. So how can we reach out to them and close that gap? Thank you.
Thank you. Very insightful question. Indeed, I think the public health approach has got a major role to play with that. So sensitization, awareness around infertility is key. Because this is a mindset issue. It's a perception, it's a culture issue. So we need to normalize talk around infertility. First, as we normalize talk around infertility, we're going to increase awareness, knowledge around infertility, what causes it. You know, there's so many myths as well around infertility. So when that happens, it's also going to improve the health-seeking tendency for people who present with infertility. So instead of them going to see a papa or a traditional something somewhere, they know that they can actually walk to a health facility and get the help and the support that they need. So I think I've been doing different media sensitization programs and trainings with the Merck Foundation, I think to various regions of the continent, where we are actually educating and sensitizing the media, journalists, on how to report around infertility in a way that it has a positive impact and removing the stigma around infertility. Of course, it's going to take a while because, I'm African and I know what it means in most of our societies not to have a child. People are looking at you and they're like, and the pressure that women experience. It will take a while, but I think it's good that we've started on this journey. And I think very key as well is the men. We need the men on board. I think a lot of focus has been on the women, but it's a two. Prof yesterday was talking about it. It takes two. It takes two. So yeah.
Obedai Vumi Malenge Nkoba. Thanks for the good presentation. You said that the pathologic process starts as soon after intubation. Is it related to the technique or the caliber we use? Are there ways to prevent that? Most for patients with long stay in the ICU service.
I was wondering. Okay.
Thank you very much, Doc. In Africa, you really can't separate the spiritual or religious aspect when it comes to fertility. So my question to you as a mental health specialist, when do you think is the best time for a clinician to consider that I think now is the time that I should let this patient attain other treatment pathways like the spiritual aspect?
Thank you. That one is quite a difficult
Just
one.
one of
I
my
can
most
admit I'm actually also
concerning
religious.
complications here
And,
is that of a
when you
tracheal
talk of
stenosis.
religion is
And I would just like to
complex.
know what is the management protocol
Individualized.
for
Even amongst
tracheal
religions, there are
stenosis if
various
it develops.
understandings,
I mean, I was
levels, or
thinking maybe you
considerations, huh?
do a tracheostomy, but
Though
probably
for
that would
me,
be
I'll speak as a doctor
temporary.
from
Is
my
there any
experience. What I
measurements
think has
or
helped me
ways
is
done
I'll usually
to
tell
handle
first
or
I'll
treat tracheal
inform the client
stenosis?
that,
Maybe
by the way, I'm
dilation,
also
surgical.
religious. Though we need to do this. Continue with your religious aspect. I'm not refusing. Though, allow me to be a medical doctor and we continue on our path as well. So for me and a doctor, that has worked. It tends, of course, there'll be on and offs. You have to continue reassuring them, but it has helped. So again, when people talk of religion or faith, this is again another component that we should pick up about religion, which is protective. When people talk about faith, what is faith about? It gives them hope, right? It's something positive. It makes them optimistic, which is what we want them, less stressed, less anxious, not depressed. So religion actually can be very protective. Of course, there are certain religious practices which are destructive, so we should be able to identify, okay, is this person in a more positive space religious? So a lot of times parallel. They continue with their religion, you continue with your medical component. Yeah. I hope that helps. Though I know those can be quite complex and contextualized.
Thank you for the question, Dr. Salam from Ghana. With regards to the study by Brodsky et al., which you mentioned, the 2017 one, you mentioned that they were looking on the day, second day,
Francisca has touched
5 days, 7 days. My question is, that extent of
the fact that
laryngeal
if you are in
manipulation,
this
wouldn't
field
it cause, isn't it a possible cause of
as a
the
fertility
laryngeal edema
practitioner,
itself? What are alternatives
I
rather
always
than
tell my doctors
manipulating the airway
over
just to
40
see
years
if there's any
experience,
laryngeal edema?
it's
Is
a
there any
chosen
other way
field.
they could have objectively
And when
measured
patients
apart
come
from
to
the,
you,
because
they are
by that
infertile,
point the tube is no longer
you
there,
have
but
to
they are
be
still
sensitive.
manipulating to see is there
And
laryngeal
there are
edema
3 points
or is not
that
not.
I always tell my doctors.
Okay.
The first is that they look at you like the God to solve their problem. And in that role, there is either failure or success. And when you discover, she's mentioned it, for male or female, you should be careful,
And this
because
also
you're going to
my other
discover
part
that
of the
this
question
woman
is there any room for
is not going to ovulate,
pre-extubation
or has no egg,
nebulized epinephrine in
or
your
this
setting?
man
I mean, in our setting,
has
we
low
do that.
sperm
We
or
do
no sperm.
before we extubate. We give
It is
we
a
nebulize
matter
with,
that can
epinephrine,
create
and
a
I've seen other
mental
studies, including a
problem
study by
straight
Sui et al.
away.
in 2022,
That
which also suggests
information
that
we are
it's a
going
good
to
thing.
give to
How
that
about
patient.
yours?
And that patient may either walk out of your clinic or stay in your clinic and take you as the helper, depending on how you release that information. And that is a very important key solution you must have in your pocket as a fertility practitioner. The mental, the psychological
Thank you very much.
state
I
of this
also
patient walking to your clinic,
for this.
the way you receive her or him. And then she said, especially for the man, when you tell a man you have no sperm or your sperm is low, wow. So you have to, what we call, gently lay down the fact. So it has to be a gentle discovery, not just announce it to him like that, bam, oh, we can't help you. A woman comes to your clinic at 48, I want to go through IVF. At 50, yes, I want to use my egg. No, you can't use your egg, you are too old. She's going to walk out of your clinic. You have to empathize and reason and gently lay down the facts to her. Then she can accept it. It is, I'm happy that Merck Foundation is giving this a lot of time, but it's a very important subject that you have to know, because women have been known to commit suicide from this type of thing, going to a fertility clinic. And the last is, I've talked about discovery, the gentle laying down of, and the last one, which is the actual, the support, which I started in Chicago, practicing IVF over almost 40 years ago. The options. Acceptance comes with options. Okay, maybe the eggs are low, but we'll stimulate you, but maybe you need a backup with a donor egg that is similar to yours. Well, or you can do the trial alone, or you can do the backup. That is also important. And finally, and not the least, is that the nightmare of any fertility practitioner in IVF is when you transfer the embryos to the patient, and the patient is waiting for 12, 14 days to get the result. That patient is going erotic. So you have to prepare the patient before you do it. And finally, that if it doesn't work, you do a failure analysis and counseling with options, solution to the problem. I think these are the key points which will supplement what she has done eloquently. Thank you very much, Francisca, for this.
I really liked your presentation on mental health. In fact, it resonates very well with what I'll be talking about, because we oscillate between stress and having a good, joyous baby in our arms, where you then have the love portion of oxytocin to assist you there. Now, with stress, there is this hormone called prolactin that comes to play. So this is really what I'll be discussing, and it does resonate with mental health, but I want most importantly for all of us to recognize, you must rule out endocrine problems before you judge somebody as mentally unwell. So I thank Merck Foundation for seeing this as a very important aspect we need to look at. Next slide, please. Go again. Again, I have no conflict of interest. I have not been funded. all I've done is just put a synopsis of what I could find pertaining to hyperprolactinemia. We know the definition of infertility, I won't repeat it, but what you need to know in Africa, unlike the high-income countries, 1 in every 4 people, couples, are suffering from infertility, which is really high. And it's both looking at the female causes, the male causes, and those that we can't quite define why the couple is meeting together, yet there is no baby. In female factors, we look at ovulation, dysfunction, fallopian tubal disease, which is very common in our setting, uterine causes, and the quality of our oocytes. Next. A little bit of basics. Prolactin is a polypeptide, but more importantly, it's not just produced in the pituitary. Subcutaneous tissue, breast and visceral tissue do have prolactin. It functions as a growth hormone with signaling pathways and can also be part of class 1 cytokine receptor families and located in various other organs, the pancreas, the uterus, the liver, the prostate. I like emphasizing the man because we tend to renegade him out. Yeah, and he does have problems. It comes in a pulsatile secretory phase normally with a peak when you wake up. In fact, most of you are sitting here with prolactin, some little degree of stress. Yeah, when you go for your breakfast, that stress goes down. Physiologically, what does it do? It facilitates breast enlargement during pregnancy and milk production during lactation. Next, please. A little bit of in-depth on molecular science for those of you who are interested. Production of prolactin is stimulated by estrogen, So when do you have maximum estrogen? During pregnancy or after pregnancy? Hello, I want people to wake up. Or I'll pick on some of my students and people are here. Koigi, when is estrogen maximally produced? During pregnancy or after? Yeah? So you need to know, okay? When prolactins are excessively high, this is the hyperprolactinemia. The anterior pituitary gland will stop secreting luteinizing hormone and also FSH. So there's down regulation. Yes? And what does that result in? Ovulatory dysfunction. That's the basic principle, all right? The reduction in gonadotrophins will then also cause irregularities of menses. Are we on the same page? Hello? Yeah, so sometimes when you're following a woman and you're asking her, please track your menstrual cycle. And she starts telling you, I've been having regular periods that were coming at intervals of 28 days, but now I'm beginning to see a change. It's taking 35, it's taking 42, it's taking 50 days. Begin to ask yourself, what's stressing that woman? It could be hyperprolactinemia. So there's a dysfunction. And when it is very severe, you have anovulation and infertility. Now let's look at the converse. The converse is this: I have just given birth to a baby. What happens? My periods take a walk, don't they? Hello? Lactational amenorrheas. Isn't that a form of family planning? That's the mechanism. You don't ovulate because of the prolactin that comes to play when I am breastfeeding. Next slide, please. So when do we start thinking of the pathophysiology? And I'm not going to read all this, that's very boring. But what I want you to take home as the message: prolactin normal levels are 25 nanograms per liter and less. Between 25 and 50, suspect a problem. Definitely above 100. Above what? You're definitely now dealing with hyperprolactinemia. Look for the cause. Next slide. Next slide. Yes, it may be a little bit busy and vague a little bit, but I'm basically summarizing. What happens
When you have dopamine, a decline, inhibitory signals of dopamine are the commonest cause or effect of hyperprolactinemia. And what causes my dopamine to get messed up, including antihypertensive drugs, stress. Are we together so far? On the converse, thyroid releasing hormone. Most of you don't even look for it. Yeah? Increased levels of thyroid releasing hormone will actually affect your levels of prolactin in terms of increasing it. When you have stress, and definitely infertility is extremely stressful, what happens to prolactin? It goes up. And she's clearly told us, for the men, for the women, they can be affected. So these are just a few examples. You'll get these slides, so you'll be able to look at them. All right? Next, please. I put this one specifically for the men, because we tend to focus so much on the woman. But just look at the causes of male infertility. Prolactin can also cause dysfunction of spermatogenesis. The pre-testicular issues, hypogonadotrophic hypogonadism. Are we together so far? So even before you do your ICSIs, you need to find out what's really happening also for the man. Next. Right. Please do not forget this slide. There are medications that can cause you to have hyperprolactinemia, which include what? Antipsychotics. Hello. So here she is trying to treat a lady who's having mental issues. I need to come back and tell her, excuse me, my friend, do I stop? Do I switch? Or should we wait before we deal with the fertility issues? Before you actually get into pregnancy issues. We never seem to remember to work together. So antipsychotics, antidepressants, hormonal preparations. Do women take hormonal preparations? Such as the commonest things we take, ladies, we're here. We talked about it yesterday. Contraceptions. That's the commonest. How is it affecting my hormonal milieu, my internal environment? Antihypertensives. I talked about this yesterday. There is getting pregnancy in young ladies, but we're now career women, so we're looking for pregnancies slightly older. By that time, I have other comorbidities, diabetes, hypertension, cardiovascular. So remember, you can actually have problems with hyperprolactinemia. And finally, gastrointestinal medications. Principally, I've given you everything there, but I just want you to remember, for the majority, it affects your dopamine level. That's the bottom line, okay? Next. So how do you make a diagnosis? And here I've elaborated it from looking at quite a number of papers. Less than 25, I said, is within normal. 25 to 50, think. Definitely above 100, there is pathology. That's the bottom line. And the last one, with genetics, those of us who are into omics studies, you need to rule out some of the syndromes that can exist. Next. So what should your objective of treatment of hyperprolactinemia therefore be? Number one, decrease the levels. So the hypothalamo-pituitary ovarian axis or the hypothalamo-pituitary testicular axis functions normally. 2, decrease the tumor size. In fact, the rule is, if you don't know anything else, if you have over 100 nanograms per liter, it is most probably a macroadenoma. And you want to reduce that. All right? Then, restore gonadal function and pituitary hormone deficiencies, prevent the tumor recurring or progressing, and restoring fertility. So what are the options? There are medications that are dopamine agonists. You may need to do surgery, and more oftenly they use this approach, the transsphenoidal approach. All of you have had COVID tests. So I've always asked, why are you getting to my cribriform fascia? You're going to actually penetrate to my brain. That's the way we've been bored, all of us, yeah? So that's the route, surgery. In some cases, they may use radiotherapy. But remember, radiotherapy may affect the quality of my sperm or the quality of my ova after. All right, next. So fertility restoration, you want normal levels of prolactin and a tumor size that's less than 1 centimeter. Transphenoidal, we've talked about that approach. When ovulation cannot be restored and you've normalized the prolactin, we're looking for pregnancy, then you can use the clomiphene citrate, letrozole, or the GnRH. All right, depending on what you have available. I like the Burundi story. Then in planning before pregnancy, please pay attention to this. If you have mental illness, you must work together and ask, do we switch the medications here? Do we take her off the medications here? Or do we wait to actually achieve a pregnancy? It's a very important criterion when working together. Next.
Thank you
And
very
these are
much
my
for the
references.
presentation.
I like keeping time. Next.
Most of us don't
Next.
Thank you for sharing your important insights. Let's check if we have any question from the attendees.
Thinking, well done. You should invite me there. Yes. Okay. Can't hear.
Thank you for your presentation. I would like to ask 2 questions. They suggest to measure prolactin on day 21. Between day 21 and day 28 of the cycle, and before meal, and the 30 minutes after no stress. I would like to know why 21, before 21 and 28. Another question. There are some women, you find that they have galactorrhea, but the prolactin is normal. And they write that sometimes prolactin is too big to be found in the lab. What can we do if we see the woman has I don't know how to explain. Galactorrhea, but it's normal in the blood. What can we do now?
Great questions. Now we have luteal phase deficiency. Remember we talked about ovulatory dysfunction. Did we? Hello? I'm trying to wake people up in the process. Huh? That's typically what a teacher does. So usually that's the time you'd actually be able to know there is an irregularity. It should constantly be how many days? The luteal phase of a cycle. 14. So when I started telling you my period starts getting longer and protracted, I said 30, 35, 50, going on to 60 days, you definitely know there's a dysfunction. And that is why we look at prolactin in that phase of the cycle. Galactorrhea, normal levels of prolactin. Can women breastfeed? If you have been a mother, even now, all the mothers in this house, if I place the baby to your breast, what's going to happen? What's going to happen? Will there be milk let down if you put the baby to the breast? The answer is capital yes. You can actually start just producing milk. Okay? But you also have to rule out breast malignancies. Because in some women, you'll actually notice there is a breast secretion and you'll be stuck wondering what's happening here. I always will give the benefit of some dose that will reduce that prolactin if I am dealing with an infertile woman. Why? It may reflect as normal, but you also need
Thank
to
you very
understand
much
the
for the
stressant
wonderful
that she may
presentation.
be going through.
Mine is a very simple question.
Okay, so you have to differentiate three
What is
things.
the
Is it
treatment
related
modality
to the
for
galactorrhea?
patients
Is it
with,
related
long
to
PCC
stress?
interval?
Is it related to a prolactinemic micro or macro adenoma? Or are we actually dealing with a pathological breast disease? Three things. Okay? Yep.
Some suggest to I don't know if they add water in the lab if prolactinemia is too big to be found in the lab. What is that? There are some who say that you need, like for HCG, for a test of pregnancy, if it is too high. Sometimes they say we need to, I don't know what they can do in the lab for, it is written.
I know I've seen that, but I'm not a lab specialist, so maybe somebody else who may have some knowledge we can learn.
Actually, what she's referring to is that sometimes highly elevated prolactin may, and the prolactin assay is an extra sensitive, but it's at a low level. So you might have to dilute your specimen to be able to measure, especially when you are seeing galactorrhea. And the comment I wanted to make, which you also answered, is that in a low setting, you have no assay, no access to lab, and you have to help these patients. So you have to depend a lot on those physical features which have been so mentioned. Thank you very much.
Please do not forget your thyroid gland, galactorrhea and the thyroid, and we ignore it. And that brings you to your clinical assessment of patients. Head to.
Thank you for your explanation.
So good morning, everyone. Let me thank Merck Foundation for the invitation and the great hospitality. I always like to attend Merck Luminary. This is my third meeting. And I've been asked to talk on fertility preservation in cancer patient. So in my next 15, I try to finish as quick as possible. I'm going to highlight some of the laboratory aspects of fertility preservation. Sorry, there is a lag. I can do it, thank you. Yeah, the fertility preservation is an upcoming area of science. If you look at the number of publications, you can see a drastic increase in the number of papers. That means this area is gaining popularity, right? The fertility preservation doesn't belong to any specialty, but it requires well-orchestrated collaboration with various specialties. You need to have oncologists, gynecologists, fertility specialists, embryologists, surgeons, psychologists, everyone. So, credit goes to oncologists because there is a great improvement in the survival. It's about 80% disease-free in the pediatric cancer survivors. Definitely, it's because of the excellent treatment modalities offered by the oncologist. But from the fertility perspective, we are concerned about the toxicity of the agents. The earlier speaker has clearly stated about the toxicity of the agents which are used in the cancer therapy. Because if you look at the testis, it's a highly complex structure. It has the sperm-producing cells, it has supporting cells, it has hormone-producing cells. Some are proliferating, some are not proliferating. So these agents act either directly or indirectly on the testicular compartment and can eventually compromise the production of sperm. So this is particularly important in children because, as you see here, the children, the cells are much more sensitive than adults. The lowest dose of the low dose of radiation, which is used in the therapy, can affect not only the germ cells, but also the supporting cells like Sertoli cells, which eventually has the higher risk of gonadal failure later. So this is, in fact, we have also looked at, we did this study in collaboration with Professor Richard Anderson from Edinburgh, who is pioneered in fertility preservation. What we have stated is there is a long-term memory. When the spermatogonial stem cells are exposed to these anti-cancer agents, it is not just the immediate effect, there is the long-term effect. There is a mutagen effect which can pass over to generation. So we need to be very careful about this. This is clinical. If you look at, okay, what you asked me, what's the clinical evidence? Yes, now it has been shown that about 50% of patients who became azoospermic post-chemotherapy, they remain azoospermic. So when the T-cell was done, about 50% of the patient, T-cell was negative. So that means there is a need to look into this issue and help these people to have their own children when they want to have their family. I'm sorry, may I request you to change? There's a lag in changing slide. Yeah, the situation is same even in the ovary, though there are certain, the process happens naturally during menstruation, during ovulation, but when the ovary is exposed to gonadotoxic therapy, those processes gets aggravated. As you see here, there's apoptosis, atresia, increased activation, and eventually there's an increased antral follicle degeneration and leading to the premature ovarian failure. Next slide, please. Yeah, this is also evident. So it is not that only eggs are affected, only follicles are affected, even there is a risk of getting abnormal embryos, and even the progenies, the genetic and epigenetic status are also compromised. Next slide, please. So now you ask me a question, okay, what are the options? What are the fertility preservation options? As you see here, in case of, if the patient is post-pubertal and patient can delay therapy, then you have the option of ART. You can stimulate the patient, get the oocytes, in the partner is available, you can fertilize them and freeze the embryo straightforward. Any ART center can do it. And the situation becomes complex if the patient is prepubertal. The technique which is available is the ovarian tissue cryopreservation, or OTC. And remove the ovarian tissue and you can subject this tissue to cryopreservation. There are different techniques. You can go for slow freezing, or you can freeze them by vitrification, right? So then what happens? How do you restore the fertility? So there are two options again. If you think that there is no malignant cell contamination, because there is all the most successful option is the transplantation. So transplantation, tissue transplantation later when the patient comes back to you for fertility restoration, but always there is a risk of reintroducing malignant cell. If that is an option, then one should go for the in vitro maturation of the follicles, and then when you get mature oocytes, you can use it by ART and help the patient. So these are the suggested of the practice, the techniques during fertility restoration. So as I said earlier, okay, what are the techniques you can use? In fact, which is better? So the slow freezing or vitrification, both are successful. That depends on the type of the tissue, the thickness of the tissue, and there are several factors which I'm not going to explain now. It is a lot of information. So what I want to tell you is that both the slow freezing and vitrification are equally good. You can use any of this technique. And when the complex issue what we are facing currently is the in vitro maturation of the follicles, right? Because it's a very complex process. When you want to culture the ovarian tissue, when you want to mature the follicles, there is a higher risk of experiencing tissue necrosis, because the tissue is quite thick, and the conventional culture is not very supportive. So you need to use some devices call it as bioreactors, so which gives a kind of it's a dynamic system which provides adequate oxygen, the culture medium, the culture condition, so that you can get good follicular maturation and good quality oocytes for subsequent ART. Okay, so that's about in females. Now let's see what are the options available in males. It's straightforward. Semen cryopreservation is a standard technique, and it's suitable for the pubertal males and children who can produce ejaculate. There is a possibility of adding additional ejaculate, but depending upon the oncologist, if the oncologist gives time, you can add more ejaculate, so that increases the chance of utilization later. Not expensive, it is less expensive. And normally in our center, the response rate is about 40%. 40% of the patients who are counseled by fertility preservation and oncologists, they come to us for fertility preservation, semen cryopreservation. But the limiting factors are the urgency to start therapy. If the oncologist is in a hurry and he cannot delay the treatment, then of course, then it is a difficult process. So then one can go for the testicular or epidermal sperm cryopreservation. It's also useful in obstructive pathology. And many patients, men who come to us for fertility preservation, they are weak and they have problem in due to erectile dysfunction, and they're not able to produce sample. So one can refer the patient to urologist or the andrologist for the surgical retrieval of this tissue or sperm from the testes. But always we should know that these are invasive process, and always there is a higher risk of breaching the blood testis barrier and eventual complication. The most complex situation is when you have children. Because as you know, the spermatogenesis is not fully functional. You can't get any mature sperm. So what are the options you can give for children who are at a risk of experiencing infertility due to cancer therapy? Yeah, this is the recommendation by the FRA Task Force for Fertility Preservation. So what this say is that, okay, in case of pubertal, as I said earlier, if the patient, the boy or the pubertal child or children can produce ejaculate, it's straightforward. You can take them for semen cryopreservation. And if the patient is not able to produce sample, or if the age is between 10 to 12, who doesn't know about the masturbation, who doesn't know about the semen collection, it's a very challenging issue. And or if you don't see any sperm, but it's always better to go for intraoperative analysis. When surgery is done, when the tissues are taken, just test the tissue and see whether there is any evidence of mature spermatozoa. If you see mature sperm, then the tissue can be subjected to the adult testicular tissue cryopreservation, conventional testicular tissue cryopreservation. But if you don't see any sperm, then straight away you can take them for immature testicular tissue. There is a different protocol. What I want to tell you is that the protocols for the adult testicular tissue and prepubertal testicular tissues are completely different. So this needs to be optimized. Hence, there is a need of intraoperative analysis when the tissues are retrieved from in this kind of situation. But in prepubertal, we know that definitely there is no sperm. You can straight away take them for do biopsy and straight away take them for immature testicular tissue cryopreservation. But it is not as easy as you see here. There are several challenging issues, because if you look at the testes, the 80% of the tissues, the testicular volume is filled with germ cells in adults. But if you look at a 9-year-old prepubertal boy, it's only about 10 to 15% of the volume is with the germ cell. You do biopsy, end up with no germ cell, then there is no point in cryopreserving them. So these are some of the challenging issues. And also, we should tell patients that this is purely experimental. In fact, I'm going to tell in my subsequent slide where are we now with the prepubertal testicular tissue cryopreservation. Yes, the question is what can be done? How can you restore? How can you help them later? So there are two options. One is that, okay, you can transplant them, and then if you get mature sperm, then you can use it for ICSI. The other option is in vitro spermatogenesis. Try to mimic spermatogenesis in a dish, and the stem cells, they proliferate, and you may get mature sperm with post-meiotic cells. You may get mature sperm, and subsequently you can use it for ART. So these are the preservation protocol. I'm not going to talk about it. There are certain issues. So as I told you earlier, though this technique is purely experimental, we have some good news. In fact, a couple of years back, the studies have shown that there is a possibility to derive spermatozoa from immature testicular tissue. And people are successful with the primate model and hoping that when these boys come back to us after 10 or 15 years, we may have the technique to help them. So it's a good option to cryopreserve their testicular tissue for the possible future use. So in summary, these are the fertility preservation options available. As I told you earlier, most of the techniques are established, except deriving mature sperm from the prepubertal germ cell. And similarly in females, in vitro maturation of the oocyte from the prepubertal ovarian tissue is still experimental. But we are hoping that people are working in this direction and hoping that we'll come out with some good technology to get mature oocytes. So what are the challenges? What are the priorities right now? So optimizing the timing, we don't know what is the right time and how can you hold the tissue, because many places you may not have the facility to freeze the tissue. The tissue needs to be transported to the different center. So what is the impact of the holding temperature? What is the impact of the holding time? These aspects need to be addressed. And what is the impact of the age range? So which age range is suitable? In fact, we did testicular biopsy on 2-year-old boy. So we don't know the outcome. What is the impact of this cryopreservation related to the age of the patient, the age of the tissue? We have absolutely no idea. So these are some of the things. And the quality assurance and testing, because these tissues are subjected to the toxic cryoprotectants. Most of the time we use DMSO. What is the impact of this? Because this is not short-term cryopreservation like we do in ART. We have to store them for 10 years, 15 years. What is the impact of this long-term storage? The impact of cryoprotectants on the germ cells, we don't know. So yeah, this is our center. We have been previous slide. Yeah, we have been working in this direction since last 8 years. We have a consortium of various experts. We have oncologists, and we have medical oncologists, we have surgical oncologists, we have radiation expert, and many other specialties on board. So this is really helping us to run a successful fertility preservation program in our center. So thank you very much for your attention. I'm happy to answer if there are any questions.
Thank you very much, Dr. Satish, for this wonderful presentation. We would like to present, if there is one question from the attendees. If no question, let's move forward. Please let me call upon question.
Just out of curiosity, like for the children or adolescents, when it comes to preserving their reproductive cells, are we facing any possible legal litigation? Yeah, I was just curious about that.
It's a very important question. In fact, there are several challenges because we need to make sure that the patients are aware that this is purely experimental. We are not sure about the outcome. And there are certain process, the legal process, the consenting, the parents should consent. And importantly, the counseling them is a challenge because especially in my country, the concern is to come out of the primary disease. The fertility preservation becomes secondary. And that too, the patients are stressed, there is an immediate diagnosis, and patient need to be prepared for the oncological therapy. That time, if you talk about fertility preservation, most of the time, answer is no. So but what I want to highlight here is that yes, there is a possibility. If the people are very particular about the fertility preservation, there is a possibility to help them out. Thank you.
Thank you very much, Dr. Satish.
The topic is the current guidelines for evaluation and treatment for PCOS. So I'm going to start because they said, okay, try and make it some interaction here. So what is the type of female infertility patient that will make us look good as infertility specialists and consultants? Who is the patient that is more likely to get pregnant faster, simpler? Anovulation, PCOS, right? Okay, so these are the patients that will make us look good. So the topic is about them. So simple topic in a way, but complicated in other ways. So what is PCOS? It is a heterogeneous endocrine disorder. As you know, the patient can have multiple comorbidities and presentations, anywhere from menstrual dysfunction, infertility, hyperandrogenemia, which manifests as hirsutism, acne, alopecia. They also have dyslipidemia. They can have type 2 diabetes and insulin resistance, sleep apnea, and the list goes on and on and on. So PCOS is the most common endocrine disorder in women. Okay, it affects all races and ethnicities, and the reported incidence can be anything between 3 and 10%. So literally, you can have 1 in 10 women affected by the condition. Unfortunately, 70% of women with PCOS might go undiagnosed or not properly diagnosed, and that could be because there is varied presentation from the patient's side, but also not good, you can say, provider acknowledgement or knowledge of the disease. Also, these patients are at 50% risk to develop prediabetes or type 2 diabetes, and they have a high increased chance, 3 to 6%, of developing endometrial cancer, a lot of times premenopausally. The prevalence here, it was reported at different ethnicities. This was a meta-analysis. They looked at 40 studies, and you can see that it varies from African population, where the prevalence is 8%, in the Caucasian 5.5%. If you go to the Middle East, 6%, and depending on the criteria you use to diagnose the disease, it can be up to 16%. So pathophysiology remains still largely unknown. There is definitely a genetic and a familial component. There have been more than 100 genes that have been implicated or studied in PCOS. And we do know that also diet and lifestyle factors might affect the progression of the disease or the expression of the disease. So how do we diagnose it? And over the years, they have different criteria for diagnosing PCOS. Currently, we can focus on what is accepted now, and this is based on the 2018 International PCOS guidelines that were presented at ESHRE. So we need 2 out of the 3 following criteria. Hyperandrogenism is one, oligo or anovulation is the second one, and PCO appearance of the ovaries is the third one. So you need 2 out of the 3 to properly diagnose the patient. Okay, this is not working. Okay, so let's look at the diagnostic assessment. For biochemical hyperandrogenism, we need to be very specific at what we are ordering to show us that the patient indeed has hyperandrogenism, and this is the calculated free testosterone or free androgen index. You can run a lot of other hormones, DHEAS, 17-hydroxy-P, androstenedione, but these are not going to be used for diagnosing the patient, okay? Also, if a woman is taking contraceptives, you need to take her off for 3 months and then run the hormone levels, because the combined oral contraceptives will decrease androgen levels. And of course, when we have unclear signs of hyperandrogenism, so there is not, you can say, acne or hirsutism, then it might be worth running the test.
Thank you very much, Dr. Steve, for that wonderful presentation.
I'm sorry, but this is not working,
COVID
right?
prevalence is going down, but we are going back to the winter, and we
pictures
see what
of
happened last year.
hirsutism in a woman. What we use now is a standardized way to assess
from the audience
hirsutism,
now,
and this is the modified Ferryman-Galway score. And anything more than 4 to 6 on this score will be indicative of hirsutism. The modified Ferryman-Galloway score assesses 9 sites in the body, and of course, based on the degree of hirsutism, you scoring accordingly. Clinical hyperandrogenism, again, we need to bear in mind that those scores have to do also with ethnicity. So if you go to the Middle East or Mediterranean women or Spanish women tend to have more hirsutism than others, you need to factor that in. And also you need to make sure that you don't confuse vellus hair with terminal hair. The one is pigmented and thicker than the vellus hair. And obviously you can only take into account the one that is indicative of true hirsutism. So how about ultrasound? Currently, with the high-resolution ultrasound machines, the guideline for accepting it as being a criterion for diagnosing, it should be in either ovary more than 20 follicles. It used to be 10, 12 follicles. It has to be more than 20 follicles. If your ultrasound machine is not as latest technology, then you can go by volume. Anything more than 10 cc volume in either ovary could be the one diagnostic criterion. You cannot use this in adolescent girls. You know, you have to wait 8 years after menarche to use the ultrasound guideline for diagnosing. And here's a typical PCO appearing ovary, the necklace sign, where you have all the resting follicles in the periphery and a thick stroma in the middle. So ethnic variation, as noted before, we need to keep in mind that presentation of PCOS in different ethnicities could be a little bit different. You have higher BMI and metabolic features in Africa. You have more hirsutism in Mediterranean, Middle East, and Spanish women. You have lower hirsutism and lower BMI in East Asians. And of course, in Australians, you have higher BMI. So you need to bear in mind where you practice and what the presentation might be. So this was a study done in the States, but they looked at African American women, and they found that if you compare with white women with PCOS, the African American women who are more likely to have higher blood pressure, both diastolic and systolic, higher BMI, higher LDL and lower HDL, so in essence, higher cardiovascular risk, you can say. So we need to assess women with PCOS for cardiovascular risk factors or disease. We need to assess them every year or every 6 months. We need to check weight, we need to check blood pressure, and of course should have a fasting lipid profile that will include triglycerides, LDL, HDL, and total cholesterol. Gestational diabetes and type 2 diabetes and prediabetes or insulin resistance are all increased in PCOS patients. The minimum we have to do at presentation is to do either a fasting glucose, a hemoglobin A1C, or a OGTT, and we need to assess the glycemic status every 1 to 3 years. Presentation of insulin resistance can be clinically as acanthosis nigricans, so you can see this condition either in the axillary area or on the back of the neck. For women that are presenting for infertility, we need to offer a 75-gram OGTT. If they get pregnant, they need to have one done before 20th week. And as I said, at baseline, it should be either an OGTT, hemoglobin A1C, or fasting glucose on all PCOS patients. Okay, so endometrial cancer patients with PCOS because of unopposed estrogen and irregular cycles, there is no progesterone effect regularly to counteract the estrogen effect. That over the years will put the patient at risk for endometrial hyperplasia, polyps, hyperplasia with atypia, and endometrial cancer. It is calculated to be a 2 to 6-fold increased risk for endometrial cancer on those patients, and again, they might also present before menopause. So we have to have a very low threshold. Anybody with irregular bleeding, abnormal bleeding, we should be aggressive in evaluating endometrial biopsy or full DNC if need to make sure that the patient does not have any malignant condition. We don't know from like evidence-based clinical evidence-based studies what is the best mode of prevention, but in clinical practice we all use either combined oral contraceptives or cyclic progesterone to prevent the endometrial lining and decrease the risk of hyperplasia and malignancy. Now, going back to emotional well-being, Okay, that was addressed earlier. We tend to forget that these patients have increased prevalence of eating disorder, but also psychiatric disorders. Okay, anything from moderate to severe anxiety and depression that can be seen early on from adolescence. Then as clinicians, we should never forget that we need to be screening. There are simple questionnaires that we can all have in our practice that we can ask questions, and then we'll see if the patient is at risk or potential at risk, and then refer on to the specialist to take care of them. For treatment, though, we need to bear in mind that, for example, antidepressants might increase weight. So on a patient with PCOS who is already obese, that might be something that we need to assess and accordingly address. And of course, we need to understand that these patients have conditions such as obesity, infertility, hirsutism that by themselves will put them at risk to develop depressive symptoms and anxiety symptoms and affect their emotional well-being. I have to say that this new standard of 2018, the International Standard for PCOS, puts a lot of emphasis on mental well-being and a lot of emphasis also on lifestyle modification, diet, and exercise. So lifestyle modification, and then I'll talk also about medical treatment briefly. Lifestyle modification includes diet, exercise, and of course behavior modification. And as far as treatment, it could be medical, surgical, or ART if the patient is looking at conceiving. So in regards to lifestyle modification, we have healthy eating, we have physical activity, diet, exercise, etc. We need to keep in mind that we need to have SMART goal setting. SMART is specific, measurable, achievable, realistic, and timely. We need to be realistic at the end of the day. We cannot expect a patient to lose a lot of weight very fast because that's not going to happen and then she's going to gain it back. But we can look at 6-month time frame, and even a 5% weight loss might get the patient to, for example, possibly have regular cycles or ovulate if we're talking about infertility. But as I said, we need to keep in mind that this is a long-term treatment and keep it realistic and achievable. So specifically, the patient can limit their intake. 1,200 to 1,500 calories per day will lead to weight loss. And if we look at specific exercise, there are guidelines whether you need to maintain your healthy weight or you can achieve modest weight, and there are obviously guidance of how the patient can do that. Pharmacological treatments, depending on what we're trying to obviously achieve. Combined oral contraceptives for regulation of cycles and for hyperandrogenemia. There is not a specific pill that has been proven to be better than others. All tend to help with hirsutism equally. Anti-androgens can only be added if the patient does not respond to combined oral contraceptives or oral contraceptives are contraindicated. We need to always keep in mind that the patient needs also contraception because it can affect, if she gets pregnant, the male fetus if she takes anti-androgens. I will go a bit faster now. So ovulation induction principles when it comes to infertility and PCOS. Number one choice would be letrozole. We know that clomiphene, letrozole, and metformin have been used. These are in most countries off label, but they're still based on clinical practice and data being used regularly. So number one choice is letrozole. Why is that? It's because you're going to get monofollicular growth, and also it's not going to affect your endometrial lining, so it's better, current data show, than clomiphene. We can add clomiphene if we don't have access to letrozole can also be used. If the patient is resistant, we can add metformin. So gonadotropins would only be used if the patient did not respond to letrozole or clomiphene. We need to be very, very careful. We need to start very, very low dose. It's not one gonadotropin that is better than others, but we tend to use FSH. We need to be very patient, so eventually we don't have more than 2 follicles growing, and that is very, very tricky sometimes. So again, it takes some experience, obviously, and knowledge of how to use gonadotropins in this set of patients. Again, gonadotropins, as I said, would be very judiciously used in PCOS patients. Laparoscopic surgery, ovarian drilling, it can only be used if we don't have access to gonadotropins. You need to take into account that obviously you need to have somebody who's experienced laparoscopist, and there are some concerns that it might lead to, if somebody's too aggressive, to low ovarian reserve or low response later on, so you need to be very careful to not be overly aggressive with how you drill. And also, there are some concerns of formation of adhesions around those ovaries after you do the ovarian drilling. But depending on where you practice, that might be the route to take if you don't have access to gonadotropins or if they're too expensive in the country of practice. Bariatric surgery is experimental. You have the one advantage of decreasing the risk for gestational diabetes, macrosomia, but on the other hand, you need to know that you need to tell the patient to wait at least 12 months, stabilize weight, and then try and get pregnant, and then still have a very good prenatal care that will assess the baby for any small for gestational age, development. And also, you need to manage the pre- and post-operative nutritional deficiencies on the patient, the mother. IVF is the last route to take if the patient has failed everything that we discussed before. Few things for IVF and PCOS. They're going to be at risk for ovarian hyperstimulation syndrome, so you have to use an antagonist cycle, okay? And then you have the option of a agonist trigger, so you decrease the chance of OHSS. Other routes is to decrease the HCG trigger if you don't have the option of antagonist protocol. And then freeze all, okay? Of course, we do recommend single embryo transfer on those patients, and they should be, as I said, the ones that make us all look good. So thank you very much again, and if you have any questions, I'll be happy to answer.
Thank you very much, Dr. Panayota, for such a wonderful talk. We would like to check if there is any question.
Just one question, one comment. Thank you for your excellent lecture. But according to recent studies, the incidences of dumping syndrome are very high in the first year after bariatric surgery. So it is recommended to start fertility procedures after 18 months. So initially, they started studying the incidences of dumping syndrome in these women, and initially they had, initially the guidelines stated after bariatric surgery that fertility treatments should be started after 24 months, which has now come down to 18 months. So just a small comment to your talk where you mentioned it was 12 months, it actually should be 18 months because the incidence of dumping syndrome are high up to 18 months post bariatric surgery. So that would provide adequate nutrition to the fetus as well. Thank you very much for an excellent lecture.
In the States, our statement is 12 months, but then again, you need to factor that at 12 months, she's not going to get pregnant right away, most likely. But anyways, thank you very much.
Thank you for what you have presented. I think you touched on a critical issue in terms of lifestyle changes. And the way to present this to patients is that if you want to have a conception, which is now being recommended, that you need to treat yourself the way you would treat your flat or your apartment when you are expecting a guest to come and stay with you. So it needs cleansing. And it's not just lifestyle cleansing, also detoxification from heavy metals. And the American Committee of Opinion have stated that women should also avoid things like fish that contains mercury and a lot of environmental toxins that also may cause PCO. Lastly, the use of gonadotropins in PCO patients is, as you said, with caution. And I would say that if you do not have access to IVF, it's probably better to use very low dose. Because if you give a PCO patient gonadotropins and you end up having many follicles, if you inseminate or if they go through, then you may have multiple pregnancies that you cannot control. Thank you.
And they ovulate 3 oocytes, God forbid, then this is the one that's going to get pregnant with triplets, because she didn't get pregnant because there was no egg released before. So I totally agree with your comment.
Thank you very much. Beautiful presentation. I am a PCO person, and I think it's very important to actually recognize it tends to run even in families. So you need to have that sense of caution. My mom had it, I had it, my daughter has it. So you kind of like have to have that continuum in the back of your mind, even into the next generation. But beautiful presentation, I loved it.
Thank you very much. Absolutely, there's a familial component, and as you said, now what we need to keep in mind is how we diagnose an adolescent with PCOS, because it could be very tricky, because if you do an ultrasound, it's going to have a lot of follicles. So ultrasound, as I said, need to be a criteria only after years from menarche. And if let's say you have an adolescent patient that you think has PCOS, but you cannot really put it into the criteria, then you need to label her at risk and reevaluate 8 years later, where you can make confirmatory diagnosis. But absolutely right that it runs in families, and you need to always, if you treat mom, you need to have this in the back of your mind for the daughters.
Thank you very much.
I'm going to talk today on not fertility. Everybody seems to be here on fertility. And I am going to speak something about cancer. And my end of the talk will have some of the videos which will be useful for a general obstetrician as well, because those are the surgical techniques which are very important for planning everything. So I'm going to talk about the modified radical hysterectomy, which I started doing way back in 1983, and this was presented at the 1994 World Congress, FIGO World Congress, and we have done numerous surgeries after that, and the death by incompetence is what Lancet said about cancer cervix. It is something which is totally the preventable disease, but yet not prevented in all over the world, whether it is India, Asia, Africa, anywhere, mostly in the underdeveloped world. And it needs to be aggressively dealt with, and today WHO has announced in 2018, FIGO represented to the WHO at the World WHO Summit, that something drastically needs to be done. And after that, the 90-70-90 proposal has come from WHO to make sure that we cut down on the cancer cervix entity itself. Now you can see the Globocon 2002 survey to 2020, the incidence of cancer cervixes worldwide is still rising, and in spite of the fact that the vaccine is available, it's not being universally given in most of the countries, more so because of the expense involved in the vaccination program. And I'm happy to tell you today that in the next 3 months, India will be producing the cervical cancer vaccine for only $3, and which is today sold for God knows how much money everywhere. So the vaccination program in India is well known. We have the COVID vaccine, which started in India, and 2.1 billion people were given free vaccination. And we have now proposed to the government of India, and they have accepted it, that it is a good idea, that the 15 million schoolgirls which are there in India, all of them will be vaccinated free to make sure that they do not suffer from cancer cervix. Now, alarmingly, in 2004, WHO predicted a steady increase in cervical worldwide and estimated that by the year 2050, the annual incidence of new cervical cancer would be 1 million. And that too in the African and the Asia-Oceania region, mostly. And the worldwide new cases of cancer cervix are diagnosed, and 132,000 are from India, and globally with 273. So we have a huge burden in India of cancer cervix. Now, the commonest of all malignancies in women after breast, it contributes to 25 to 40% of all female malignancies. And a woman dies every 7 minutes from cancer cervix. So when we are trying to reduce the maternal mortality worldwide, understandably so, every mother that is saved because of maternal mortality must watch out for dying from cancer cervix, which is really, really a frightening analysis of the situation. Now, in the UK, it has been estimated that 1 in 80 of the 8 million British women born between 1951 and 1970 will be saved from premature death by the cervical screening program. And that program is not available worldwide to go ahead and do each and every person's pap smear, and who is there to read those pap smears. All those problems are existing. And the census and survey in England shows that the increase in the incidence of cervical cancer per 1,000 women in the age group 25 to 30 years from 17.1 to 36.2. And in India, 40% of the cancer cervix below the age of 40 years of age, which is a huge burden as far as India is concerned. Now, can I go back to a slide? Yeah. No. Go back, it's going ahead. Why is it going ahead?
Are you also selecting from there?
No, it's not holding on. Anyway, doesn't matter. In FIGO, 2008 put forward the staging of cancer cervix, and it was not updated from 2006, then little bit of updation happened in 2008, and further on the updation did not happen. But during my tenure in 2015 to 2018, we embarked upon restaging and doing up-to-date staging of cancer cervix. And you know, all FIGO stagings of cancer are the baseline fundamental stagings as far as whether it is CA body, vulva, whatever it is. So there, the question was that cervical cancer staging, which is only clinically, which was seen, should it be continued to be clinical? Should we include lymph node status and the pathology findings on tumor size and staging? Should we include imaging and staging in staging, and could we have different staging for different resource settings? And what may be happening in maybe Burundi may not be the same situation in India, because there may not be, are there MRIs available everywhere? Can every patient be subjected to MRI? So all these things needed to be analyzed when internationally FIGO staging had to be taken forward. So significant prognostic factors are not assessed: tumor volume, nodal metastasis, stromal invasion, lower uterine segment involvement, and data collection is incomplete for further research when based only on clinical staging. So people could not correlate with what clinical staging they had vis-a-vis that happenings elsewhere. Now, the pelvic and para-aortic node metastases have worse outcomes. Everybody knows that. But do we include that in the staging? 5-year overall survival for patients without pelvic lymph node metastasis was 92% when surgically done, vis-a-vis 53%. So which means the drastic reduction in survival rate occurred because of the lymph node involvement. And I have, okay. The prognostic value of nodal metastasis, you can see from the graph that it's very obvious that once the nodal metastasis, especially the para-aortic node status and pelvic node status, were significantly associated with progression-free survival. Now, advantages of imaging, there are numerous advantages. We are all aware now it can upstage or downstage the disease, less radiation side effects when planned without hysterectomy than as postoperative adjuvant or radiotherapy, and so on, which can be done with the imaging that now we have at our disposal. Now, the cervical cancer worldwide, despite the impact of screening in a large number of countries, women continue to be at risk. And there, of course, vaccine will play a major role as far as reduction is concerned, which is, it's not moving. Okay. This is just a graphical representation, and you will see Africa, then India, and Latin America. What is the higher incidence compared to that happening in developed countries where there is screening program and availability of. Next slide. This is again the 2012 cancer registry, which is showing the higher incidence in many of the African countries where it has dropped to some degree, but India and regions are still remaining the same. Next slide. And the global mortality per annum, which is still very high with all these countries. Next slide. The estimated age standardization incidence rates worldwide, cervix you try all ages, and you find that around the 40 years of age, you will see a major involvement of cancer cervix. Next slide. And you see the male to female ratios where worldwide the situation as it stands. The status of OECD countries, you see again what is happening as far as the availability of imaging. You see Japan has the highest availability of imaging science, and they can go ahead and do it, as against Mexico, which is hardly any facilities there in the country to compare it to go and see that. Now, if you compare with the Globocon 2002 to 2020 statistics and see the increase that is seen there in 2020, in 20 years' time. So this is not something which is reducing worldwide. Now, current status, as you see, the implemented national HPV vaccination program compared with greater than 80% of high-income countries, 171 only in 44% of women in low median income, and in sub-Saharan Africa country levels median is 16.9 ranging to 0.9 and so on. So we need to have the HPV vaccination on the war footing as far as all the countries where, next slide please, it's not moving, next slide. Now when FIGO went into cervical cancer revision, it was not only FIGO deciding that I want to say this, all these were consulted. Each one of the organizations compared to the sister societies, you can see who full lists down the line, the regional national societies, and the responses were received from the GCIG and other contacted AOFOG, FACS, ICCR, and so on. And there, our FIGO chief that time, the chairman of the oncology committee, Nirja Batla, and all of us which were there in the big committee which was holding it to make sure that the entire staging was changed to what the current staging is seen now. I won't go to the staging here now, but basically one must remember the size of the tumor is very important when you see at the cervix and the infiltration happening in the parametrium. Can I have the next slide? So I won't go into the because shortage of time. The early detection of cancer cervix is the key to better prognosis, colposcopy, cytology, routine screening of HPV and vaccine, an increase in overall incidence from squamous to adenocarcinoma in view of the pre-invasive early detection of. This is something which has happened over the last 10 years, where people have been taking smears from the cervical, outside what looks like the cervix, which should be dealt with, but it's not the endocervical canal, which was used with a brush to take a cytology, and you suddenly found that the squamous carcinoma reduced and the adenocarcinoma started increasing because now the cervical canal, which had the endocervical glands, resulted in malignancy. Next slide. Now the diagnosis is various things were then, punch biopsies and all that. I'm not going to go into the details of that. But basically the cone tapering broad base, loop diathermy, and especially if it is localized, somebody talked about cancer prevention surgery for infertility, that's where the trachelectomy and all those things could come into play. Next slide. And the pre-operative evaluation, now proctoscopy is out. We do not consider it necessary. Cystoscopy is also not done routinely, as it was considered as the investigation which was necessary when diagnosing it. And of course, the USGCT and MRI taking over many of these things. Next slide. FIGO staging, lymph node metastasis, vascular invasion, tumor volume, parametrial invasion, histological types, and tumor differentiation all are prognostic factors which will tell you what is the end result. Next slide. Little bit of pelvic anatomy, not because you don't know it, but people who do gynecological surgery must know the importance of the blood supply to the ureter. Ureter gets blood supply continuously from the vessels which are around, and if you bare the ureter completely from top to bottom, that's where the fistulas occur. And therefore, you must make sure that the blood supply to the ureter is maintained while you are doing the surgery. Next slide. So there you have the blood supply going to the uterus, which is external iliac artery, internal iliac artery, anterior division, and posterior division. I routinely ligate the internal iliac artery when I'm doing a radical Vadam gastrectomy. The field becomes completely bloodless when you are trying to do that. People are always under the impression that if your posterior division is taken, then there will be gluteal pain, all sorts of things will happen, necrosis will happen. Nothing happens. Collateral circulation forms so very quickly in the gluteal region that there is no reason to worry about it. You just ligate the internal iliac artery, and so also during your postpartum hemorrhage cases, just ligate the internal iliac artery. It takes only 2 minutes to do the job, and I will show you how quickly it can be done in 2 minutes. Next slide. And that is the ureter, which gets blood supply from everywhere. Next slide. The nerves are also equally important, because if you do too much of extensive dissection, denervation can cause severe pain subsequently. Next slide. So you have modalities: surgery, radiotherapy, chemotherapy, before and after surgery, immunotherapy, and the age of the patient, available facilities, and extension of growth. Next slide. There's a whole list of procedures that have been from 1889 down to 2007, when the robotic surgery came in for radical surgery of cancer cervix. Next slide. The abdominal approach has poor vaginal dissection, because you have to go upper 1/3. You may not be able to get that properly. Time-consuming ureteric roof dissection is needed. Higher incidence of fistula, higher vault metastasis, and higher mortality and morbidity. More bladder dissection is needed when you are doing per abdomen. Next slide. If you are doing only vaginal, like Shautas, the abdomen not explored, lymph node not removed, less fistula rate, less bladder dysfunction, less than 1% mortality, useful in obese and poor risk patients. Next slide. There was a proposal given by Mitra, who said that let me do Shautas operation and do lymph node dissection intraperitoneal or extraperitoneal, whichever way, so that the lymph nodes are also dealt with by doing Shautas operation. Next slide. Now this is the whole load of chart which is available on FIGO website as well. You will see from various fertility preservation, if desired, what is needed and how you go about, to the various extrafascial hysterectomy, to radical trachelectomy, to cold knife conization, and so on. So you can do all this for fertility preservation. Next slide. Now what I did was that realized that when doing abdominal radical Vadam hysterectomy, vaginal mets occurred in spite of doing every good job. and the resultant histopathology report said no vault metastasis, and they landed up later on, even though the margins were clear for the vagina which was removed. And it's bothered me why this was happening. And one of my senior pathologist friend told me that why don't you cut a strip out before you take the specimen out from below and give it to me and let me see what is happening to the metastasis if it is happening. And he used a special dye, this was in Ireland, and he told me that the specimen that you had removed, the vagina had microemboli of cervical cancer cells. While the strip which was removed, there was nothing in it. We did at 3-4 cases and we realized that while handling the uterus, microembolization occurred, and if you take the vaginal upper 1/3 and go away, that microembolization which is in the vault gave vault metastasis subsequently. So we started doing a combined surgery, vaginal and abdominal, to get that. Next slide. Video, please. Okay, now that is the, can you have the light little less, please? That's the cervical tumor which is there, and you can see that tumor. And now I want to remove the upper, leaving the vagina on top. We need get adequate vagina, the upper 1/3 removed. So I do the dissection from below, hold the vaginal edge from all the sides where I want to take the removal done, then infiltrate the area of the vagina. Now that is holding the margin of the vagina that I want to remove from below. I'm infiltrating the vagina with normal saline, no adrenaline, nothing is needed, and take then incision, a circular incision on the vagina which I want to remove. So the circular incision is then taken. You can see the circular incision being taken, and all that you need to do is then remove the vagina, separate the vagina from the bladder completely. Separate the vagina. This is the sharp dissection being done. So the bladder is separated from the vagina. There is no question of any, because the bladder is dissected from below, the risk of fistula is nil, because you do it under vision. And rectum, all you need to do is put a finger in and then put a speculum inside, and the rectum goes down completely, and you have a full 1/3, upper 1/3 of the vagina margin in front of you. You take the lateral vaginal arteries on either side, and then you close that vagina, which is going to be removed. It goes inside the abdomen, close, and then you close the vagina, which is going to be remaining outside for you. So you have one layer completely closed, and the second layer, which is your outside proximal and distal part, both are sutured and closed. This is one which is going to be taken out with the specimen, the upper 1/3 of the vagina. You close it, so there is no spillage of any malignant cells while you're handling from the cervix into the raw area there. It is closed, and then you put a gauze, roller gauze, one below the bladder, one top part going below the bladder and the vagina, and the other end going between the vagina and the rectum. So that is put inside, and after that is done, you just close the vagina from your end, and that is the clean vagina that you have from the outside. Now, having done that, the pack is still inside, and you close the vagina there. Okay, can we go to the next video? Now, I ligate the internal iliac artery regularly. You go in there, open the peritoneal fold. And now I am going to show you two methods. One, a direct method of internal iliac ligation, and the other, indirect method of internal iliac ligation. I'm hooking these arteries just to show you The ureter has been pushed aside and you are hooking this artery. Just to show you, I'm not going to do anything, just hold it so that you know it properly where it is. Then you go right up to the bifurcation on top. You have the external, and then you see the ureter crossing it, you push it aside, and then you see the both, see the bifurcation there, and there is the internal iliac and external iliac. Now external iliac I have already taped, it was not necessary but I have done that. Internal iliac, you just cut the fascia over the artery so that there is, your mixture forceps can go under the artery well, it will not damage the vein once you have cut the fascia. And I am going to tape that internal iliac also, and that is holding the internal iliac artery. Now you go to the bifurcation and you cut the fascia above, and that is the bifurcation. Okay, and you put the mixture forceps underneath, and you can put a tape around that as well. So now you have taped the external separately, internal separately, and there you have, now you put a linen suture in there at the top where the bifurcation is, and having done that, if you were to go between the outer part of the external iliac, just take the suture material and take it inside and pull, it will land up on the internal iliac artery. Even if you don't know where your internal iliac is, you're scared of going down there to find it, this is a very easy way of going to the internal iliac and just ligate it. You tie it and that's fine, that's sitting on the internal iliac artery, having gone indirectly from behind and then in front, while here, if you have identified well the internal iliac artery, then you can have a direct ligation of that by just taking the suture material there and ligating the internal iliac artery. So this I'm purposely showing, but a lot of you will probably be doing obstetrics, and this is something very simple to do, not to get scared of. Don't have to run helter-skelter to get a cardiovascular surgeon to tie your internal iliac because there's postpartum hemorrhage. This is a very easy job, and it's your job. There is no reason why anybody else should be called to do that. Next slide, please. Can we close the video? Okay, so what are the advantages? You have post-op period, which is superior. Post-op hospital stay is short, less bladder paralysis and urinary fistulas. Suitable when uterus enlarged or tumor very large, because you can see the tumor. Make sure that you have taken the vagina adequately and covering the tumor. Operative time is less, and 5-year survival rate is 92% with above technique, which is a huge advantage and without any problems associated. Next slide. And the post-op complications which are there usually with fistula, neurogenic bladder are not seen because you have done it from below. When you're doing the radical from above, you have to just pull the pack, the anterior part of the pack which is inside and the posterior part, and the whole specimen will come out in front in the abdomen. All you need to go is laterally go, take the uterosacrals as lateral as possible, take the uterines, and that's, uterines also are actually taken care of when you're ligated the internal iliac. But to be on safety side, the veins are there, so you take that and come out, the specimen will be out in no time. Next slide. The difficulties and dangers of radical surgery are many because of the fixity of uterus, hemorrhage, shock, sepsis, bladder injuries. All that can be avoided by just adding a simple, we are all gynecologists, vaginal technique into your abdominal radical hysterectomy. Next slide. Next slide. So now comparing with the laparoscopic radical hysterectomy, people, I say I do laparoscopies, but I do believe that just because you have a gun, it doesn't mean you have to shoot. Laparoscopy has its own place. Open surgery has its own place. Every surgical procedure has its own place. And when the radical hysterectomy came in, they said, oh, what is the need for this all open surgeries, and what are you doing this combined surgeries and whatever. We can do everything radically by doing laparoscopic radical hysterectomy and also robotic surgery. which is very easy, and we can manage it with maybe 7 holes in the end on the abdomen, and yet take it out. And the laparoscopic, the results that you see, the laparoscopic vaginal radical hysterectomy should not be offered to patients with a tumor diameter greater than 2 centimeters. And I'm sure all of you have seen tumors which are more than 2 centimeters most of the places because they come late to you. Next slide. The current evidence shows better results with open surgery. Randomized controlled trial with laparoscopic surgery and open surgery have shown, next slide, I will show you the results there, that survival after minimally invasive versus open radical hysterectomy for early stage cervical cancer, meta-analysis done, 15 articles included, and what does it show? Next slide. It shows that MI is done in 49% of the cases, 57% was robot assisted, recurrence detected in 530, deaths reported in 451, which was much higher than the open surgical technique. So next slide. So now minimally invasive radical hysterectomy associated with shorter overall and disease-free survival than open surgery among women with early stage cervical cancer. Next slide. They said that it was less time consuming, more time consuming, but less number of days in hospital stay and so on. But today it is evident that laparoscopic and robotic surgery do not achieve complete removal of lymph nodes, and therefore the incidence of recurrence is higher. Next slide. Next slide, please. Now, here is the trial final results, which you have seen, that the analysis revealed worse DFS with MIS for patients with tumors greater than 2 centimeters, and outcome for patients with tumor less than 2 centimeters remain unclear. That means there is no greater advantage by doing a laparoscopic or radical surgery. Next slide. The 5-year relative survival rate for the earliest stage of invasive cervical cancer is 92%, and the overall cervical, the stage combined 5-year survival rate is 72%. And these statistics may be improved when applied to women newly diagnosed. The earlier you diagnose, the earlier you do the surgery, the better it is. Next slide. So you have the 5-year survival rate here with the new FIGO staging. You see 95% with 1A1 and 1A2, and going down to 1.5B, 4B, which is a hopeless situation anyway. Next slide. Next slide. So in conclusion, radical surgery is mainstay of treatment of cancer cervix up to stage 2A. Technique of surgery must remove the tumor and lymph nodes adequately to give the best 5-year survival rate to the patient without complications, and recurrence at wall, bladder, and ureteric complications can be avoided by doing modification in the procedure of a routine radical hysterectomy. Next slide. And thank you very much for patient hearing.
Thank you, Professor Porandari, for such a dynamic presentation. We would like you to take some questions, if any.
Thank you, Professor Porandari, for your nice presentation. I have one question. Can I know which type of vaccine is will be available for $3?
Well, at the moment, there are various vaccines available. There are quadrivalent, bivalent, and nanovalent. India is producing the quadrivalent now. And same as Gardasil. And Gardasil in India costs 3,800 rupees. And the new vaccine will be 280 rupees. So you can imagine the difference. It is less than 10% the cost of, we have shown in India that COVID vaccine, how cheap, at $2.50 we could produce in India compared to whatever high rate of COVID vaccine rates that were there. So in the next 3 months, it will be available. Firstly, it will be given to all the girls in India. and then it will be available outside as well. I'm sure Gavi will take it over, and Gavi today sells for $4.50 to underdeveloped African countries from the cost, which is nearly some $300. I don't know what the cost today in America is, and they are selling it for $3.50 to $4. And if we are producing for $3.50, even Gavi takes over, it will be available for $1, $1, and 2 injections 1 month apart, $1 each is something worthwhile. Yes, you wanted to ask some question? Dr. Munna Talak is here? She is not here. She's requested me to come and demonstrate at Latifa Hospital vaginal hysterectomy without descent. Let me tell you something. Doing it without descent is much easier than with descent, because descent requires a lot of repair work and anatomy to be cleared. And that's much more complicated than without. And here there is no question of removing the cervix. We are only removing the vagina. You mark out the vaginal edge, just take a circular incision, separate the bladder, rectum, and just close that vagina, which is going to be taken out from above. And then you close the bottom part of the vagina, which will be like a closure of any vaginal wart after doing a hysterectomy. So there is no need for any prolapse. We are not dealing with holding the cervix at all. All you are now going to do is just take a circular incision in the vagina. You could very well take an incision near the labia and close it. And I mean, question of separating vagina has no relation to the descent of the uterus.
Okay. I've never tried it before. I'm a gynecologist. It looks really interesting for me.
We are hoping that she's asked me to come down maybe in December or February when I'm here, demonstrate in Latifa Hospital maybe 6-7 cases of different techniques of vaginal hysterectomy. It's not only one technique, different techniques of vaginal, and I'll be showing them. You can join in that time. Latifa Hospital, you're based here, right?
No, I'm in Sudan.
No, but you are easy to come to the
Yes, I can come. Yes.
So fine, that's good.
Thank you.
Hello, thank you. Hi, everyone. Thanks to the Merck Foundation for inviting me to give that lecture called, as you said, the pyramid of improvements in an IVF lab. Okay. Okay, perfect. Yeah. So the first question for all the ones that work in the assisted reproduction is, please next. Okay, what's the purpose of an ART cycle? What's the purpose of my job? Well, we can say that we have a successful treatment if we are able to, next, I think you have to change all the time because I cannot do it from here. Next, please. Okay, we can say that we have successful treatments if we are able to achieve pregnancies as the main thing. Next. If we are able to have healthy babies at home, if we can assure that there's no health risk to mother and the newborn. And of course, it has to be cost effective for both the patient and the clinic or hospital. Next. So how can I achieve that? Okay, I guess that it makes sense that if we invest on the best professionals, and also if we invest on the best facilities, and of course, we have to invest also in a good marketing, because we need the patients to know us and we need the patients to come to us. So we can assume that if we do all this work, we can have the best results. But it's not always like that. Please change. Okay. Okay, so what we were focused on the best facilities. Well, if we invest on the best technology and the best training, we should ensure that we can provide really good results. But it's not just that, because when we talk about quality in IVF, we have to take in mind some considerations. The first is that IVF provides a service, not a product. And the service is the satisfaction of patients. That's our main goal. Also, we have to take in mind that IVF is extremely complex and variable. It's patient dependent, so we cannot assure that what works for a patient is going to work for a different patient. Also, IVF is an inefficient treatment. We never have 100% of access. But on the other side, we know that the human embryo can be quite robust, because it's also quite difficult to have just 0% of success. So then how can I achieve that if I have the technology and I have the training? Well, the key point is to have a good criteria. We have to be able to make the good decisions every time. And how we do that? Okay, this is the pyramid of improvements. And this is the tool we need to help us to make better decisions and to decide where to invest to improve. So if we go from the top to the bottom, the first step is the selection, the embryo selection. And why is it so important? Because with a good embryo selection, we're able to improve our pregnancy rate per transfer. So we are going to have a better aim. The next step below the selection is the cryopreservation. If we are able to establish a really good and robust cryopreservation program, we're going to be able to increase our pregnancy rates per ovum pickup. So our cumulative rates are going to improve also. And the last but not the least, in fact, is the most important of all, are the culture conditions. Our embryo culturing system, it's the key point for everything. If we have a very well-established culture conditions in our lab, we're going to increase the pregnancy rates per patient, and we will increase the success rates in all the steps of the cycle. So we are going to decrease also our dropout rate. So we're going to focus in each of them, and I'll try to give some clarity on each of the steps. For the culture conditions, if we have a very good established culture system, we'll have better embryos. For the cryopreservation program, we will have a better efficiency of the cycle. And with a good selection criteria, we'll have a better aim. So let's see and focus on the culture conditions. Well, in IVF quality, there's an effect which is very well known, and it's called the chain link effect, that says that you're as strong as your weakest link. So no IVF technique can universally promote embryo quality. Whatever worsens stays down, and all steps must be controlled. Each and every step of each and every procedure we have in an IVF lab has to be controlled, because the minimum fail in one of them is going to decrease the whole rates. And I'll just give you one example of that. We have on the left side the patient's theoretical potential to get pregnant. Okay, it's going to be around an 80%. And on the right side, we'll see the patient pregnancy real rate after the treatment. So what happened across the multiple steps in an IVF treatment? Okay, we are on the ovum pickup, and I have a very small temperature drop during the ovum pickup. Our theoretical potential to get pregnant decreased from an 80 to a 60%. And then during denudation, because I need to see if the oocytes are mature or not, I have also a very slight decrease on temperature. So again, the patient's theoretical potential to get pregnant decreased another little bit. And then with the ICSI, I have to save money. So I have just put a little oil on the dishes to cover the drops, and the temperature again goes down. So I'm decreasing again the potential to get pregnant of that patient. And just after that, I have no many incubators in my lab, so I have to use all the time the same incubator. So I'm opening and closing the door all the time. So the temperature goes down, and also the CO2 concentration, so the pH of the media is also going worse. So what happened after the after I finish the procedures in that morning, that I've decreased the patient's chances of having success from an 80% to a 10%. And that happened in real life. So how can I control and improve the cultural conditions in my lab? Well, there are three main points for that. We need to have a very well-established quality control in the IVF lab. We have to control also the quality in the procedures, and we have to use correctly the equipment. And it sounds like obvious, but it is not like that when you go to real IVF labs across the world. So what are the main points of a good quality control in an IVF lab? The main idea is that an IVF lab, it's a restricted area, accessible only to authorized personnel. We know that it's really amazing when you can show your IVF lab to visitors that want to come inside, but my suggestion is just put windows and they can see everything from the other side. But the whole environment in an IVF lab has to be so controlled and so constant that any disturbance of people going in and going out is going to affect your rates. So what should have an IVF laboratory? It should have aseptic measures. It should have separated areas for different procedures like PGT or cryopreservation or the other IVF procedures. It should have positive pressure to put out of the lab all the dirtness. It should be provided with an HVAC system, heating, ventilation, and air conditioning to control the air quality. It should, of course, ensure that the constant temperature, CO2, and pH is provided. We have to control also the humidity, and we should have a very good cleaning. I'm going to focus just on the temperature, CO2, and pH, otherwise it would be a very extensive lecture. But if you see only a few degrees below 37 Celsius affects to the cytoskeleton of the oocyte, to the spindle fibers, and to other organelles. And if the temperature goes above 37 Celsius degrees, it will reduce the oocyte competence, and it will reduce also the embryo development. So keep temperatures of the oocyte and the embryo constant during all the time they are inside the laboratory. If we go through all the different steps of an IVF cycle, how can we do that? Okay, so during the ovum pickup, we have to ensure that the OPU tubes are inside the thermoblock heater, and also you have to control the volume of follicular fluid, because if the tubes are too full of fluid, the fluid will be out of the thermoblock, so the temperature is not going to be the same in the whole tube. Also, you have to control the laminar airflow surface temperature and also the time that the dishes are out of the incubator. When inside the incubator, we have to check the temperature every morning. You cannot trust on the display. You have to really measure the temperature inside the incubator and to check if it's the same that the display is telling you. And we have to avoid unnecessary openings. And how can we do that? Well, we can have culture incubators and working incubators, so the culturing system is not being disturbed. What to do outside the incubator? Well, we have to check the temperature in the laminar airflow surfaces. Again, do not trust only on the displays. And we have also to check the temperature in the microscope stages. And of course, we have to keep the disease with the samples outside the incubators as short as possible. And regarding the vitrification and thawing processes, it's very important to have the laminar airflow at room temperature. And for the first step of the thawing, we need to really have the media, the TS media, at 37 degrees. So for that step, the working surface has to be at that temperature. We have to ensure that that media has 37 degrees. So which are the tips for temperature? Well, a thermocouple thermometer is essential for the daily checking temperatures of microscope stages and heated work surfaces. And it's required to have good data log records so you can see if there are any variations in the time in your lab or not. And also airflow from air handling system can have a large impact on the performance of many heated pieces of equipment, such as incubators, heated stages or microscopes, and heated surfaces of laminar flow hoods. So we need to have a constant temperature, and we have to avoid direct airflows on the equipment because it can vary their parameters. Well, if we move to the CO2, it is required to have a good gas analyzer to monitor the actual gas content within an incubator. The measured value is compared to the digital value displayed for each individual gas, and adjustments are made as required. Again, we need that data log records to keep track of what's going on in the lab across the time. And what about the pH? Well, all the commercial culture media typically have 2.0 milligrams per milliliter of bicarbonate, so that ensures that we are in a pH of 7.3, which goes from 7.2 to 7.4. But you have to take in mind that the pH depends on many factors, and one of that can be the atmospheric pressure. So it makes no sense to say, okay, my incubators are settled at 6 points of CO2 because my friend in another country have the same, and you say, well, but the height above the sea level is not the same in your country than in my country. Even inside the same country, different cities can be at different levels, so we have to adjust it accordingly. Okay, so we've seen how to keep good quality control in the lab. Now we have to ensure the same in the procedures. And how can we do that? Well, it's very simple. We need to have standard operating procedures. We have to describe every single step for each procedure, and we have to ensure that everyone in the same lab is working accordingly to that SOPs. We cannot admit that variation between embryologists who says, okay, but my way is this one, and it's the good one. You say, no, please strictly adhere into the SOPs, because those are the ones that give us reliability and that make us know that we all are doing the same things. And if there's any variation, we can see exactly where the problem is. For example, things that we have to take in mind when we make an SOP and when we focus on the different procedures. Well, for example, in the ovum pickup, we have to ensure that OPU tubes and DCs should never be reused, even if the follicular fluid is extremely clean. I've seen that in many labs. They say, okay, there's no blood there, so we can reuse that. No, we shouldn't. We have to know that the dry follicular fluid can increase the osmolarity of the new fluid, so that will increase the number of free radicals, and that will affect the oocyte quality. What about the drop culture? Well, this is one of the best ways to improve embryo morphology and implantation rates, because we can avoid temperature fluctuation during the oocyte and embryo manipulation. And the volume of the culture media and the volume of the oil overlay affects heat retention and heat recovery time. So with the drop culture, we ensure that we have enough oil to cover all the drops. We will waste a minimum amount of culture media, and we facilitate the actions of any embryo autocrine factor because of the small volume. We'll reduce the changes in pH caused by the loss of CO2. We have a barrier to toxic agents that won't be able to go inside our culture media because of the oil, and also allows the individual track of oocytes and embryos. What about the media? Basically, we have two kinds of media. We have the buffer media and the non-buffer media, which is the culture media that needs to be gassed. For the buffer media, the objective is to maintain the pH in the physiological range outside the incubator. So the use is in procedures that we have to do outside the incubator, like the ICSI or denudation or so on. Limitations they'll have. There's a potential toxicity and loss of temperature outside the incubator. With the non-buffer media, the culture media, the objective is to provide nutrients and physiological environment for gametes and embryos inside the incubator. So the use is for gamete and embryo culture and procedures outside the incubator that take less than 5 minutes. And the limitations, of course, are the loss of temperature, CO2, and pH outside the incubator. So what kind of SOPs do I need? Well, I need an SOP for the ovum pickup, another for denudation and ICSI, for tech, embryo assessment, embryo transfer, vitrification and thawing, the andrology techniques, and also the PhD's techniques if you do that in your labs. And the SOPs will provide us, we will have an optimization of techniques, the standardization in the clinic or across the group, and an homogenization of results. Okay, and then what else can I do? Well, it's very important to do a correct use of the equipment. We need to have two different kind of incubators, the working incubators and the cultural incubators. The incubators should only be cleaned when necessary without disabling the gas.
Last 5 minutes, please. Dr.
Yes.
Irene, last 5 minutes.
Okay, thank you. We need to clean the incubators only when necessary because it takes time to go back to the steady state as experienced before the shutdown. The water should be ultra purified water, and the filters are very important because those are the ones that control the possible contamination. Okay, this is the same. Also, we need to have a good air quality, so the laminar airflow has to be always on, so we ensure that we have a clean area for handling. The changing filters is mandatory and very important, and we have to follow the fabricator guidelines. The plasticware should be removed, and it has to be off-gassing of VOCs. And the microscopes. We have three different kind of microscopes, stereo microscopes that are inside the cabinets at 37.5 degrees and with the laminar flow on. We will have the upright microscope also for the semen analysis and sperm preparation, and it can be out of the workbench, out of laminar airflow. And we have the inverted microscope that we always recommend to have in a good anti-vibration table for the micromanipulation and oocyte and embryos evaluation. So then we have the control culture conditions. We go to the cryopreservation that will give us better efficiency. And for that, what we need is to establish a good cryopreservation program. The objectives are optimize the cycle efficiency and offer different medical approaches like accumulating oocytes, accumulating embryos for a PGT, and the improvements will come from from having a very good technique, a very good training, a very good criteria also, which embryos should be vitrified and in which order to be transferred then. And if we go to the better selection, it's when we'll have a better aim. For the better selection, what we need is to be able to choose the best embryo first. So we'll achieve the pregnancy first. And for that, we need to establish very good parameters that we have to assess, like, for example, the number of cells, the symmetry of the cells, also the percentage of fragmentation, also the distribution of the fragments. So we will be able to grade the embryos into optimal quality, suboptimal quality, poor quality, or non-viable. And in the case of morulus, we can take in mind the compaction. And also in the case of blastocyst, if we are in doing a long culture, we will assess the inner cell mass, we will assess the true ectoderm, and also the grade of expansion. So we will have an overall grading in which we will be able to say, okay, this is an A grade embryo, and this is a D grade embryo, and this is a C grade embryo. So we'll be able to choose which one to transfer first and which one to vitrify. So we will have a good thaw embryo transfer result.
Oh, last 1 minute left.
Thank you. So those will be the decisions that we will make. Which embryos should be selected for transfer? How many embryos do the lab recommend for transfer? Please listen to the labs. They have been assessing the embryos, and they know, they can know what are the chances of each embryo to implant. And when should the lab recommend go to long culture instead of the transfer? And also, to improve the vitrification program, we will take in mind which embryos should be selected for freezing, how many should be frozen in the same cryotop. If you are doing single-ended transfer, that makes no sense to vitrify more than one in each cryotop, and how should match the embryos for freezing in case we freeze more than one. And this is the last point. Now that we know how to improve culture conditions, how to improve cryopreservation, and how to improve the selection, we cannot forget about the training. You need very well-trained staff in your labs, And for that, it's a very good idea to have a planner for the junior embryologist or for the technicians, in which you describe the number of procedures they need to observe for each kind of technique, the number of them that they can start doing with a senior, the number of them that they can do alone first, and so on. So in that way, you will keep track of the development of that embryologist, and you can check if it's going well or not. You can assess the results of that embryologist, and he will also feel comfortable if he has a plan, a very well-established plan for his or her training. And after that, you have a certificate of completion, so that person can know that is able to perform all the techniques in your labs and will feel that it has had a really good and well-established training. And that's it. I think that if we are able to follow those guidelines, we are more close to success for our patients. So thank you very much. I hope you've enjoyed that lecture.
Thank you. Thank you very much, Dr. Irene, for a great presentation. We would now like to take a few questions from the attendees.
Thank you, Dr. Irene, for your presentation. I want to tie this together that after all this pyramid and training, every IVF laboratory must have what you call the quality management, where you must do your quality assurance and quality control, and you go through all those steps regularly for each of your cycle, and at the end of that cycle, you want to analyze your results and see how your performance have been and go from cycle to cycle. And that is how you are sure that what you are doing is being improved upon regularly. Thank you. But those are the steps to measure.
Thank you.
Thank you.
I'll try to explain you my focus on how the improvement in genetics may help our patients, infertility patients. At the beginning of the IVF process 44 years ago now, when Louis Brown was born, the main issue for doing treatments or helping our patients in IVF were simple problems, just like a block of the fallopian tubes. What happened to the mother, Leslie, the mother of Louis Brown. Then IVF and its technology has received far less attention along the years as transformative social forces than the information and communication technologies, with which came with the same age. Possibly because of the association with the private and domestic business of making babies. Just need to see the numbers to believe that they are in a non-stop growing curve. But why is this happening? Can you pass the next? And next. Okay. Delay of the childbearing is our main goal now. In European countries, the main age to start to seek for pregnancy is 32 years old. The eldest is the oldest are in Italy and in Spain. With the expanding opportunities for higher education, careers, and economical independence combined with highly effective contraception, more and more young women are delaying childbearing until the 4th decade of life. The problem is that some of these women postponing motherhood because they think assisted reproduction technologies will be effective, irrespective of the age of these women, and can compensate fully for the natural decline in fertility age. But this is not true. You are gynecologists and you know that the decrease in fertility with female aging is mainly due to a decrease in the number of oocytes and the quality. So both issues are going to be equal in the importance of what we will have after this. Women are born with all of the eggs they will ever have, each stored in a microscopic ovarian follicle. This is known as the ovarian reserve. So the number of eggs is somewhere between 1 and 2 million. Normally, the ovaries release the highest quality eggs around our 20s, 25 years old, more or less. And gradually, as women get older, eggs quality declines. From the age of 35 onwards, egg quality starts to decline faster. The problem this presents when trying to conceive is that the older the egg, the more probability to develop problems in cell divisions process. And this is a problem that may lead to genetic abnormalities of the embryos resulting of an egg with aneuploidies. Next, please. A healthy egg, as you know, have 23 chromosomes. At the point of fertilization, when it will match with the other 23 chromosomes from the sperm. So genetic conditions such as Down syndrome are results of having an abnormal number of chromosomes, 40, 45 or 47. There is a high chance that an embryo with too many or few chromosomes will end in a miscarriage. This is why older women have a higher risk of miscarriage and a lower chance of pregnancy. And that is why women with advanced maternal age are recommended in the clinics to consider embryo genetic or embryo screening testing as part of an IVF treatment. So genetic and reproductive medicines represent a clear example of symbiosis where both benefits and enhance each other, especially in these times where motherhood is being delayed. The field of reproductive medicine is booming and no problems arise that did not appear before. Next. Okay, now I have the control, thank you. So by the way, a part of having this delay in aging, when you go to a clinic, to a fertility clinic to have a consultation, despite of the fact of the female age, any couple wishing to conceive or planning a conception can benefit from various genetic tests to minimize the risk of having an affected child, because now we are having less number of children. So we would like them to be as healthy as possible. And we have these tools, or these genetic tools. One of them is the karyotype. The karyotype testing studies the chromosome and their structure. And another kind of test is what we call the genetic carrier testing. We know that in developed countries, single gene disease accounts for 20% of infant mortality and approximately 10% of pediatric hospitalizations. So the aim of preconception screening panels is to increase the reproductive autonomy of the individuals and couples by providing preconception knowledge that could inform them for the available treatment options if they have any mutations and they share the same mutations. The options after this, if we are sharing mutations, will be pre-implantation genetic testing or gamete donation. Of course, after a genetic counseling, which is absolutely very important. So chromosomes or genes are not the same, but we have the ability to study, to focus and test things, focusing on chromosomes and focusing on genes. Both of them provide instructions which control the human body and its characteristics to grow and develop. So we can study the numerical alteration of the karyotype, a structural alteration, or we can study a monogenic disease. We have all these three options. The pre-implantation genetic testing can detect and prevent the transmission to the offspring of these serious diseases caused by genetic or chromosomical alterations in embryos before implantation to ensure our future children will be free of hereditary disease. The procedure remains the same. The difference is related to the specific genetic condition that we are gonna diagnose. There are three types of PGT in this, focusing on these terms. The first one is PGTA. It's going to test aneuploidies And this test is determining if we have a normal number of the chromosomes in an embryo, and formerly was used to be named as PGS or a screening, in which the parents have a normal karyotype. Second one is the PGTM. Is going to study a single gene disorders, just like cystic fibrosis or Huntington disease. And the PGTS is going to look for defects or structural rearrangement, which we be able to see in translocations, inversions of the karyotype of any of the parents. ART without previous history or risk factors can be performed. We can perform PGTA for embryos of women with advanced maternal age, implantation failure, recurrent pregnancy loss, severe male factor, or previous aneuploidies. These are the risk factors that our patients may have to counsel them to go for a PGTA testing of their embryos. The advantage of using an PGTA cycle is that we will make fewer cycles of IVF, because some of the embryos will not be transferred, so we are shortening the timings. Reduce of risk of miscarriages, increasing the chances to having a healthy baby. By analyzing all embryos generated in an IVF treatment, we will choose these of free chromosomal aneuploidies to be selected for transfer. The pregnancy rates per transfer are significantly increased, and the miscarriage rates will be decreased. So in patients around 38, 42 years old is the straight and more efficient way to achieve a pregnancy, dismissing those embryos that are abnormal and reducing miscarriages and unnecessary DNC. And according to PGTM, is suitable for couples which one or both partners are carriers of a known monogenic disease or have serious conditions sharing themselves. While the most common includes maybe cystic fibrosis, sickle cell anemia, PGTM can also be used to identify any condition that are more rare. Usually there is a list of conditions of this PGTM approved, and it's regulated by the country health authority. The next step is the PGT-SR, which is gonna study the abnormalities of the structures of the chromosomes that were held in previous parents. This can be translocations, inversions, and any others of this variety. Do the 3 times of PGT, any of these 3, the process will remain the same. We will go for an IVF process. We will put our embryo in culture. When we go and get to the day 5 or 6 of the embryo, we will take some cells with a biopsy, freeze the embryos, and send the cells, the trophoctodermical cells, for being tested. So after having, in the meantime, we have these cells being tested, which usually takes 10 days or 15 days. Our embryos remain frozen in the clinic. So one of the main important issues to go in this kind of treatment, or to set this kind of treatment in your clinic, will be to have a very good vitrification process. Cannot go for 5 days is genetic testing if our freezing eggs program is not good in terms of survival rates, because we will be dismissing the opportunities for our patients. In particular case of PGTM and PGT-SR, we need to study previously the patients. This is a we call informative test or pre-implantation test. Usually takes between 15 days to 4 months, according of the conditions we're going to be tested. And after that, all the tests are ready to detect the abnormalities in our embryos. On another point of view is the screening, the carrier screening testing, which is actually recommended by the American Congress of Obstetricians and Gynecologists and the American College of Medical Genetics and Genomics. If we think that genetic diseases cannot be cured, but they can be prevented, if we already know that we are carrying them. Every year, healthy carriers of recessive gene mutations become parents, and they discover that their child is affected by a life-altering health condition. This happens due to an inherited genetic disease in which neither parent was aware. In reproductive medicine, our main objective is for our patients to have healthy children. By using this testing, this genetic carrier testing, we can analyze hundreds of genes for different genetic conditions and reduce the risk of a child being born with a serious genetic disease. Carrier genetic screening is available for a limited number of diseases, including cystic fibrosis, X-fragile, sickle cell, Tay-Sachs. Some of these disorders occur more often in certain races or ethnic groups, and this is interesting. For example, sickle cell disease often affects people of African descent. Tay-Sachs disease typically affects people of Eastern or Central Europe, French or Canadian, but anyone can have one of these disorders. They are not restricted to these groups. We have two kind of tested. We can go for a targeted carrier screening. You are tested for disorder based in your ethnicity or family history, or if you have any family history or ethnicity history, but you can go for an expanded carrier screening. Many disorders are screened using a single sample, and this time is done without regard for race or ethnicity. Companies usually offer, they create their own list of disorders that they test for, and the list is called a screening panel. Some panels test for more than 100 different disorders. Screening panels usually focus on severe disorders that affect persons' quality of life from an early age and without treatment. When a mutation is detected in the same gene of both members of the couple in one of these previous testing, we have the option to go for PGTM, as we mentioned before, or we can go for a gamete donation. But we should go for a genetic counseling before to know exactly how is the residual risk of the disease or the condition. About 2-4% of couples at risk are at risk of conceiving a child without autosomal recessive or X-linked genetic disorder. In the recent years, the increasing cost effectiveness of the genetic diagnostic techniques have allowed the creation of these panels for the simultaneous detection of multiple recessive disorders. So comprehension, preconception, genetic screening has the potential to significantly improve couple genetic risk assessment and reproductive planning to avoid detectable inheritable genetic offspring. Now, we are having a few number of children, and we should try them to be as healthy as possible. I will end and try to, I hope you have learned something of this session. Now it's a bit specific. In conclusion, just think about the three issues or the three messages to take home. It's the age fertility decline is a pandemic in any part of the world. Awareness about ovarian reservation testing must be discussed with every patient. They should not think that we will be able to help in this delay and this decline. We are not yet at that point. We cannot rejuvenate the eggs. But genetics technology may help patients with inheritable disease. Genetic counseling should be recommended, and now more units of IVF units have the option to come with geneticians on the team, and now we have, and it's helping a lot in our daily work. And if you're going to perform a carrier genetic testing, be sure that after that, a professional will be giving you advice. Just try not to do it by yourself, because now there is a lot of direct tests to consumer, and maybe we will not be able to understand what's that the result means. And that's all from my part. Thank you for attending.
Thank you very much, Dr. Annabelle, for your wonderful presentation.
I'm going to talk on a subject which is not again in fertility, but something which is very important to the fertility specialists as well as the people who are doing obstetrics. Non-communicable disease is a major issue now, and WHO has seized with that, and they have a special cell now to look after the non-communicable diseases. FIGO has been working on non-communicable diseases for the since 2015, which has been a long time. And I'm going to talk about something which many of you are not aware of, that how non-communicable diseases affect the newborn, the babies, the further generation to come, and what is going to happen to the further progeny. Next slide, please. Okay, so it's a vicious cycle. That means you have pregnancy-induced complications, non-communicable disease, which then affecting the fetus in utero, and it all boils down ultimately to programming in the fetus, which results in complications which are lifelong for the fetus. Next slide. Now, if you look at the intrauterine insults, which is undernutrition, which is very common in most of the underdeveloped countries, the placental dysfunction, hypoxia, and the decreased blood flow, which has effect on the prenatal part, and the catch-up of growth on the postnatal part with the overnutrition, inactivity, obesity, and aging, which is now a common occurrence. Now, prenatal and postnatal resulting in diabetes mellitus with the altered development, histone modification, DNA methylation, and the molecular changes that occur eventually because of this whole vicious cycle that is happening. Now, the issue of nutrition is very important because nutrition has been traditionally neglected as an essential component of the healthcare system, especially for women and children. Nutrition prior to getting pregnant, to nutrition during pregnancy, and subsequently to the baby is extremely important. And you see the nutrition as a central core to the women's health in human capital, pregnancy, breastfeeding, infant and child health, and adolescent health, all relating to, you have adolescent health with a poor school performance. You start beating your children that they're not doing well in school, but it's not their fault. It has happened in utero, which has resulted in a complication that the child is facing subsequently during its life. Stunting, poor cognition, development, acute and chronic diseases, maternal and neonatal morbidity and mortality, and reduced work capacity and family care that eventually results. Okay, now if you look at the sustainable the developmental goals of the, you see the United Nations 1, 2, 3, 4, 5, all these goals which are there, and you will find that poverty, which is number 1, and good health and well-being, number 3, keep on adding to the problems that are facing in the life of an individual, and therefore eventually cause problems in the generation. Now, 2.2 Sustainable Development Goal says that by 2030, end of all forms of malnutrition, including achieving by 2025 the internationally agreed targets on stunting and wasting in children under 5 years of age, and address the nutritional needs of adolescent girls, pregnant, lactating women, and older persons. Basically to end hunger, achieve food security, improve nutrition, and promote sustainable agricultural growth. It's very easily said than done. And when you look at the entire population all world over, how are you going to achieve it by 2030? That is just 8 years' time to say that, well, hunger is gone and people are properly fed. And when sustainable development goals are put in, they have a very tight, stringent target. But we have all seen that the previous Millennium Development Goals, that things have gone well beyond and without any control over what is happening. Now, 3.4 says that reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment, and promote mental health and well-being, ensure healthy lives and promote well-being for all at all ages. So look at what the key to diabetes prevention is. The 6th International Symposium in Diabetes in Pregnancy in March 23rd to 26th in Salzburg in Austria, they said building on the latest science, it starts with healthy pregnancy. And when you look at the low birth weight or gestational diabetes, large for gestational age birth weight because of diabetes, in adult life causing obesity, cardiovascular disease, diabetes, and the intergenerational transfer of risk that is happening from mother to the baby, and then baby going grown up, they're producing babies, that intergenerational transfer happening continuously. And when does the malady really kickstart? And at the female gender, the key to diabetes prevention, which is world over, people are worried about what diabetes prevention should be. And FIGO has been in the forefront in that. In 2016, in Abu Dhabi, the first declaration by the International Diabetic Association and the International Federation of Obstetrics and Gynecology, FIGO, I signed that declaration in Abu Dhabi world over to be accepting a protocol to follow so that the diabetes is brought under control, and especially in the mothers to be. So you have the maternal health impacts on NCD burden, fetal programming, IUGR and macrosomia, which is happening in the uterus itself. The maternal undernutrition, maternal stunting, anemia, malaria, other medical conditions which are very common in the underdeveloped countries. You have Barker's hypothesis with low birth weight. It predicts development of HTN, type 2 diabetes mellitus and the IGT, the maternal overweight, obesity, diabetes, which is again a major issue, excess weight gain during pregnancy, the Peterson's hypothesis of macrosomia, which is all adding together. A solution, of course, is the life course approach that needs to be done to make sure that all these things are not a problem. So the life course approach to prevention is basically starts with mother and infant, to childhood and adolescence, to adulthood, with late intervention impact for vulnerable groups higher. The late intervention will cause earlier intervention, will improve the functional capacity, and therefore you have plasticity and inadequate response to the new challenges that are coming up due to the adversities. The life in the womb, especially you have the maternal infection, maternal environment, maternal medical disorders, and the maternal nutrition. All these four things come together really to cause the origin of health and disease in the baby itself and the newborn that the life in the womb faces. So you look at the maternal infection, whether it is torch, maternal medical disorders, which are maybe hypertension, diabetes, maternal environment, which may be various other situations, and urine or meconium or sustained abuse of panel, and all these things aggravate, and you can imagine the insults that the child has to, the unborn has to bear when all these things are happening. The reduced protein in the diet of pregnant rats had shown that the birth and adulthood, in the birth there was reduced size of offspring at birth, and elevated blood pressure and glucose intolerance in offspring in adulthood. So which means that the protein intake is a very important aspect. And we know that where there is oligohydramnios, we immediately start on protein, amino acids, and so on and so forth, so that the environment improves and the baby benefits from that. So what exactly the fetal origins of the disease hypothesis? The hypothesis states that susceptibility of cardiovascular disease, non-insulin dependent diabetes mellitus, and the insulin resistant syndrome is programmed in utero as a response to fetal undernutrition. So whole programming that is taking place for the baby inside is happening because of the fetal undernutrition that is taking place, and therefore the programming will adversely affect the fetus. So could there be an alternative hypothesis to that of the fetal programming of adult disease that could explain the associations observed? Is this the only hypothesis? Or there may be something else which may be happening which we are not aware of. And there could be genetic influences, the low birth weight infants and the adult insulin resistance. All this result in the alternative hypothesis of genetic influences. The maternal glucose concentration, fetal genetically determined responses, insulin secretion, insulin mediated growth, infant birth weight will all be affected because of that. The prenatal natal nutrition and other factors, fetal programming as I mentioned, the genetic and adult chronic disease, they all have the adulthood nutrition and other risk factors which add on to chronic diseases that ultimately result. Establishing an NCD committee, which was something which FIGO did, and FIGO's vision for tackling NCD, merging nutritional working group, which we had, and a hypoglycemia and pregnancy working group, which we had. The two groups are merged together, and I formed the NCD committee, and the collaboration with FIGO Environment Committee, Safe Motherhood Committee, and Best Practices Committee, so that all together would pull in their resources to see how best we can achieve whatever we can. Not moving. The obesity, smoking, suboptimal nutrition, physical activity, other factors and that, all that has the effect on the intrauterine growth restriction and the adulthood chronic diseases that ultimately result from the role of socio-economic status, because you are in a different situations all the time. Can somebody move it? Next slide. Pregnancy offers a window of opportunity to provide maternal care services. The mother comes to you, and she will come to you because she's pregnant, and this is a golden opportunity to make sure that traditionally maternal perinatal morbidity and mortality indicators which are there address the intergenerational prevention of NCD such as diabetes, hypertension, cardiovascular disease and stroke. All you can deal with is a golden opportunity as pregnant women come to you. Next slide, please. Next slide. So between 2010 and 2030, 73% increase in adult diabetic numbers in developing countries is expected to be. Today, 17.5% patients, pregnant patients in India are hypoglycemic. And that's not a small number. If they are going to produce offspring which have repercussion later on, those children are going to again have diabetes. Their problems with heart disease, nutrition, diabetes, the cardiovascular disease, renal disease, all that is going to aggravate, and there is going to be a huge burden monetarily on a country because of the situation. And the prevalence of non-insulin dependent diabetes and impaired glucose tolerance, fetal and infant growth and impaired glucose tolerance at age 64, and you can see the changes that can be very clearly seen. During the last 25 years, the prevalence of diabetes has multiplied by 3 to 5 times in India, Indonesia, China, Korea, and Thailand. Investigators showed a rising prevalence with increasing age and with increasing body mass index, confirming the relationship between obesity and diabetes. There is definitely correlation between the two. Effect of birth weight and adult weight on the metabolic syndrome. You can see low to medium and high birth weight as the changes that you see as far as the metabolic diseases are concerned. And primary prevention, obesity, PCOS, lifestyle, somebody mentioned about PCOS in the talk. The secondary prevention of GDM diagnosis and care, and tertiary prevention of the prevent long-term complications that can happen from these. The new terminology has been advocated, diabesity, diabetes and obesity together, which is affecting ever younger ages. The concern of an epidemic in cardiac, vascular and renal disease is very real. And the emphasis now must be on addressing both diabetes and obesity in a systematic and complementary way, and not as two conditions in isolation. They are not isolated conditions. They are going together. Next slide. So therapy begins in childhood. Dietary restriction, increase physical activity and exercise, reduce the sedentary behavior, and it is unfortunate that today children are sitting in front of TVs all the time and not going out and playing, and those are the TV watching children who are eating potatoes and landing up with couch potatoes there, and the problems associated further with that. Next slide. Modify the behavior. Anyway, modify the behavior, change of lifestyle for the whole family, and reduce TV viewing and computer games. Restrict them to number of hours that you are going to subject them, allow them to have TV viewing to your children. Next slide. Integration services, you can prevent type 2 diabetes, eat well, be active, and have fun. And encouraging breastfeeding for optimal growth, resistance to infection, neurocognitive development, and prevention of NCD in both the baby as well as the mother is important, and you make sure that that is achieved. Next slide. Solutions and need for action. We are addressing educational, political, and social issues through advocacy, linking the NCD agenda to sexual and reproductive health, and rights agenda to advocate for more resources, providing access to maternal and child health services as well as care for NCDs at the primary care level, and avoid making best the enemy of better, ensuring protocols and recommendations are not merely academic but practical and feasible. Don't just say that you have read those and that's enough. Implementation is extremely important. Can I have the previous slide, please? Previous slide? Next one, sorry, next one. Now, we have FIGO recommended support call for greater attention and focus on the links between maternal health and non-communicable disease as the development agenda, and you can see the entire FIGO group sitting there discussing and coming to a conclusion on hypoglycemia and pregnancy, which is HIP. FIGO offers a pragmatic guide to diagnosis and management care. Next slide. And the universal testing, each and every pregnant woman should be tested. And the easiest way to test is, as soon as she comes in, give her 75 grams and take a blood sample, whether she's fasting or not fasting, it doesn't matter. And see after 2 hours and see what the levels are. Because if you are expecting her to come again after 2 weeks to come fasting, she is not going to turn up. And you will miss out on very important information that you need to. So all countries have an obligation to implement the best GDM testing and management practices they can. Next slide. So FIGO recognizes that management of diabetes and pregnancy should be made in accord with available national resources and infrastructure, even without high quality evidence, as it is preferred to the alternative of no or poor care. So you have to make sure that that is achieved. Next slide. FIGO calls for public health measures to increase awareness and acceptance of preconception counseling and to increase affordability and access to preconception. It is important that you have to have this accessibility. Next slide. And all the IVF people, whenever the patients are coming to you, make sure that they are given the nutrition, they are given folic acid, and they are given everything that is needed so that in pregnancy it becomes very easy to manage. So you need to have the health system with capacity, HCP training and knowledge, guidelines, which are already there on FIGO website, and the protocols, referrals. It's a small little booklet which has been prepared by FIGO. You can download on website. Keep it in front of you, and that is enough information there for you to counsel the patient when the patient comes in front of you. Next slide. To disseminate, share the FIGO guidelines and infographics. There are simple infographics which are available. Advocate, talk to policymakers and government representatives about the need to highlight the hypoglycemia and pregnancy. Collaborate, join with other professional societies to ensure improved testing, diagnosis, and care for women with the hypoglycemia in pregnancy. Next slide. And that is the need of the hour. Thank you very much.
Thank you very much, Professor, for your amazing presentation.
Any questions? Yes.
Only one question?
Thank you very much for that wonderful, wonderful presentation. IVF, I'm not worried about preconceptual care, but for the routine women, the interpregnancy interval, or even trying to attract them to come for preconceptual care, any insights on that? Because most women come when the baby is actually kicking already in them.
Absolutely, absolutely. And that is why I address this to the fertility people here, because they are the ones who are going to produce children by fertility, and they have the opportunity to tell the patients at that point of time that you make sure that you take these things are folic acid, all nutritional things that need to be taken, and that would avoid so much of problem which is happening otherwise. There is no way we can we can, but there is no way we can implement telling the general population that you take all this before coming and planned pregnancy. Nobody will listen to us because they have their own agendas. But here is a situation where they are coming specially for treatment and they want pregnancy, make sure that they are given the necessary medication.
Also, Professor, because of that emphasis, it is important for we doctors to let the public know that once you are thinking of conception, of having a baby, you must be aware of the following things, and to prevent it, take folic acid and do the following other things. I think it's very important.
Absolutely right, absolutely right. But that requires your government support, your TV advertisement to tell everybody that when they're watching, they must see that they need to do all this if they're planning pregnancy. Because you can't go to every house and say that, well, you're trying to get pregnant, you take this. It's not possible. But viewership, media has a tremendous role in viewership in telling everybody, if you're planning pregnancy, see your doctor or take this simple medication. At least that much can be done.
Thank you, Professor, for your wonderful presentation. Moving forward.
I think I have a challenging task in holding your attention post-lunch. Okay. So, yeah. This is the title of my presentation, Strategies to De-stress Gametes and Embryos in IVF Lab. So before I take you through the mitigating approaches, I would like to briefly tell you about what is stress from the gametes and embryos perspective and how they respond to any kind of stress, and what are the laboratory factors which are responsible for causing stress. Okay, stress is a very generic term. In IVF, whether we are embryologists or fertility clinicians or patients, we tend to experience stress at different time points. I'm not going to talk about this because I'm not expert in this stress. Okay, so I restrict myself only to the endogenous stress which are experienced by the gonads, and the downstream, the sperm, oocytes, and embryos. As we all know, the causes of endogenous stress is multifactorial. There are n number of factors are responsible for causing stress. So these stressors, either they act directly or indirectly, and then create the environment which is stressful for the gametes and embryos. In IVF, we deal with very unique cell types. The sperm, oocytes, and embryos. And these cells are very unique because they are different. They are very unique because they are different in their size, shape, their ploidy status, their chromatin organization, and also their ability to sense and respond to any kind of stress. For example, if you look at sperm, as you know, the sperm is the smallest cell in the body. It's a very unique architecture. And it is believed that the sperm is quite resistant to any kind of stress. because of its unique chromatin or a lot of the protamines, highly compact protamines. And also if you look at the mitochondria here, it's far away. Yeah, as I said, the sperm has a very unique chromatin architecture. And because of this, it is believed that it is quite resistant to any kind of stress. And also if you look at the nucleus, is far away from mitochondria, which is in the mid-phase. So mitochondria normally release ROS, reactive oxygen species. They act on the DNA and then break the DNA and create stress. So why it should happen? But now it is believed that the abnormal protein folding, which happens during spermiogenesis, is responsible for this stress process. So the abnormal the abnormal protein folding makes the sperm quite vulnerable to experience stress. Next slide, please. Similarly, the oocytes are also at a risk of experiencing stress in the follicular environment. There are several factors. But interestingly, the immature oocytes, we call it GV oocytes, they are quite resistant. I mean, they don't respond to any kind of stress. Even if they are exposed to adverse environment within the follicles, they keep progressing. They progress from GV to GVBD, GVBD to metaphase 1, and then metaphase 2 is the mature oocyte. But what happens in case of oocyte, if the oocytes are exposed to adverse condition, then they stop their progression at the M1 phase. So this could be one of the reasons for seeing heterogeneity when we do oocyte pickup. It's not that always we get mature oocytes. Some of them are metaphase 2, some are metaphase 1, some are GV oocytes. So this could be one of the reasons because they can sense and stop the progression at M1 phase. So once the fertilization happens, as we all know, the embryos undergo a lot of changes. A single cell embryo divides, progresses, and becomes a multicellular structure after about 120 hours. It's a very complex process. A lot of changes takes place. The first few divisions until 4 cells are fully controlled by the oocytes. Then the embryo will take over and the progression starts from beyond 4 cell stage. It is controlled by the embryos. So during this process, a lot of changes takes place. The genome activation, the maternal transcript undergo degradation, the methylation process changes. But with all these things, what happens? Embryos cannot sense anything. Even if the embryos in the lab are exposed to adverse conditions, they are not at a position to sense and respond to stress. That is why even if the lab conditions are not optimum, they keep progressing. We see beautiful embryos on day 3. We transfer them, end up with no pregnancy. So, next slide, please. So this is because, as I said, the ability of the embryo to sense and respond starts at compaction. When they progress from morula to blastocyst stage, the embryo realizes that, okay, it has exposed to some kind of adverse condition, and if there are abnormalities, the abnormal cells are gone, are eliminated by a process called apoptosis. So what happens? If the cells are gone by apoptosis, then the outcome is positive. Embryo is healthy, but it doesn't happen always. Sometimes excessive apoptosis makes the less cells in the embryo. Similarly, if the stress is more, the damage is more, the persistence of the damage can lead to abnormal outcome. There could be implantation failure, or there could be miscarriage. There's also a risk of birth defects. Next slide, please. Let's see what happens in the lab. Again, there are n number of factors in the lab are responsible for causing stress in the gametes and embryos. That could be thermal, osmotic, be chemical, or oxidative stress. Sometimes they act singly or they act in combination and makes the embryo susceptible, or they can damage the embryo. Next slide, please. For example, if you look at sperm, the spermatozoa are well protected within the seminal plasma. Seminal plasma is a very good buffer. It protects the sperm. It is rich in antioxidant. By the time you remove spermatozoa from the seminal plasma, their protection is gone. What we do, we subject them to culture medium, we centrifuge them, pipette them, so they experience a lot of stress and eventually produce ROS, and the fragmentation of the DNA can happen. Next slide. This is our own study, it's not new, but what I want to tell you is that the poor quality ejaculate or spermatozoa are at higher risk of experiencing damage during the lab intervention. For example, if you cryopreserve, previous slide, if you cryopreserve morphologically abnormal sperm, it has the higher ability or susceptibility to undergo DNA fragmentation due to the stress experienced during the process of cryopreservation and warming. Next slide. So apart from, okay, cryopreservation, yes, we know that the freeze-thaw process can damage. But even exposing sperm cell to PVP, PVP is substance, those who are working in the lab, you know what is PVP. Without PVP, you cannot manipulate sperm during ICSI, but exposing spermatozoa to PVP, supposed to be an inert substance, can also induce fragmentation in the spermatozoa. Next slide. So as I said, in embryos, they experience multiple stressors in the lab. Next slide, please. There are several factors. For example, if I can highlight some of them, the ammonium. Ammonium, what is the source of ammonium? Ammonium is nothing but the product from the culture medium. The degradation of the amino acids in the culture medium can produce ammonia. And this ammonia can build up in the culture medium and can cause, and is detrimental to the embryos. So we have to be extremely careful with this. When the protein source use, the small volume culture, we don't know what is the right volume for the embryos to grow. Some people, they culture in 50 microliters, some culture in 10 microliters. Now there's a trend to go for ultra micro droplet, growing the embryos in 2 microliters, 3 microliters. It's fine, it may have some benefit, but if the preparation is not done, if the dish is not prepared in a right way, any kind of evaporation can change the osmolality of the medium, and when you keep the embryos in it, it is highly detrimental. Next slide. And now the oxygen tension. People talk about low oxygen. When in the physiological condition, when the embryos are grown at a low oxygen, as we know, the oxygen level in the fallopian tube is 5%, whereas in uterus it is only 2%, hypoxic. Then why should we grow the embryos at 20% ambient oxygen? It is believed that high oxygen tension can be detrimental to the embryos, and the trend is to go for low oxygen and to create a low oxygen environment for the embryo culture. Next slide. Yeah, next slide, please. It's our own study. So these are some of the factors which are known to be detrimental for the embryos in the lab. So what are the reasons for this iatrogenic stress? Why does it happen? These are the factors responsible for causing stress in the lab, but most of these factors are interrelated. For example, you have inadequate infrastructure and inadequate staff, and suddenly you have too many patients undergoing ART. You don't have adequate incubator, no embryo, hardly one embryologist, so naturally this will compromise, this will create stress on the gametes and embryos. Poor or no quality control. Earlier, we had a very nice lecture earlier. What is the importance of quality control in the lab? If there is no quality control, no SOPs, lack of scientific knowledge, the embryologist has no idea about the need of the gametes and embryos, use of untested technology and materials in the lab, and most importantly, the negligence. What happens if I do this shortcut? So these are the important factors responsible for creating stress in gametes and embryos in the lab. Next slide, please. It has been clearly shown that the lab environment is a major factor responsible for the embryo phenotype. It could be the lab environment or culture system or manipulation or more detrimental compared to the other factors are responsible for the embryo phenotype. Next slide, please. Okay, so we discussed about stress and what are the causes. Now we should know the strategies to de-stress. How can we de-stress them in the lab? Next slide, please. There's a very nice paper published in RBMO a couple of years back, which is nothing but the Cairo consensus, which tells about the KPI, the key performance indicator. What does it say? It says that keeping optimal conditions of external factors. What are those factors? It says that there is only one thing that is truly important in an IVF lab is everything. That means each and every factor in the lab is important. You cannot ignore, neglect any factor to create a safe environment for your gametes and embryos. Next slide, please. In fact, there are several other approaches. In fact, we have also used some kind of antioxidant supplementation to the culture medium during manipulation, during cryopreservation, or during sperm preparation. Also try to protect gametes and embryos to some extent. Next slide, please. So we also use nanoparticles as a technology. In nanotechnology, we also tried using tagging the antioxidants to nanoparticles and treating the sperm and oocytes and embryos during manipulation. Again, showed some promising results. Next slide. So another important approach to mitigating strategy is the gametes and embryo specific protocols. This is very important because in IVF lab, what happens most of the time, our protocols are generic. Whatever the supplier says, the same protocols are being followed. It should not be like that. It should be the gamete specific. It should be embryo specific, like our clinician colleagues, how they do it. The patient specific stimulation protocol, the same way it should be handled in the lab. It should be gamete and embryo specific so that we know what exactly the gametes and embryos needs. Accordingly, we have to manipulate our protocol. So avoid unnecessary steps, intervention in the lab. ICSI, ICSI, of course, it is required. It's an important technique in the management of male factor. But how much information, how much it is helpful in non-male factor infertility. In fact, we have a study, unfortunately I don't have the data to show you. We didn't do a great job. When everything is fine, ultimately the embryo quality remains same. So if all good, why not IVF? EMC, assisted hatching, zona thinning has not shown any clinical benefit. These are only the fancy gadgets in the lab, but not shown any clinical benefit. The oocyte and embryo freezing, it is very important to know the quality, the stage of the embryo, the quality of the embryo. Accordingly, we should be freezing them. Next slide, please. So what I want to highlight to here is that the embryos are different with respect to their ability of cryo threshold. Early embryos, for oocytes and early embryos have more water. So dehydrating them is a complex process. At later, by the time they become blastocysts, they are quite resistant. The threshold increases. So what I want to tell you here is that the compaction or the morula stage is the most sensitive in human embryo development. That's the time all this embryo connection starts, establishment of the connect. There are several proteins, the cell-to-cell connection, differentiation, and it's the most sensitive phase of embryo development, and embryos should not be disturbed during the process. No cryopreservation at morula stage, no transfer at morula. You hardly see any report saying day 4 transfer or morula stage cryopreservation, because we know that it's a very sensitive phase. We may not see any impact, immediate impact. We may get good blastocyst, good pregnancy, but the impact may be seen later in the offspring, late effects. So this is our own study. In fact, we wanted to see what happens when the embryos, the morula at different level, early morula, fully compacted morula are frozen and thawed, what happens? And we found that when you freeze morula, there's a higher incidence of DNA fragmentation later when it becomes blastocyst. Says that, which is quite alarming. So avoid freezing the morula so that you can have the genetically intact blastocyst later. Next slide. So far I discussed about the laboratory factor. The last factor is the embryologist. because the embryologist controls everything in the lab. We control everything. If the embryologist is not competent enough, then he is the major stressor in the lab. Next slide. So it's a nice review I came across which says that the embryologist is not just a person who is performing ICSI. The modern embryologist should be a good, apart from technical aspect, he or she should be a good manager, good researcher, good collaborator, good scholar, communicator, mentor. With all these qualities, the embryologist is not a stressor. Next slide. He is a stress buster. Thank you very much for your attention. I am happy to answer if there are any questions.
Thank you, Professor Adik, for your engaging presentation.
Well, earlier I presented on the patients that will make us all look good. So now I'm going to present on the ones that that frustrate all of us and make us look bad, yeah? Okay, so we're going from one to the other. So I'll try and make it fast also so we can hopefully catch up with time. So what is the definition of a poor responder? Okay, first of all. On this paper by Nicholas Polizos, published in 2011, where they looked at systematic review of randomized trials for the treatment of poor responders. Amazingly, what they came up at the end of the day was that there are 47 randomized controlled trials they looked at, and among them there were 41 definitions for a poor responder. So that can tell you there is not much agreement on what we call a poor responder. But the Bologna-Escher criteria are 2 of the 3 features should be present to have a poor responder. The one is advanced age, more than 40, a previous low response with conventional stimulation, meaning a patient that gave us 3 or less oocytes, or an abnormal ovarian reserve test, either an AMH less than 1.1 or an AFC of less than 5 to 7 follicles, or if the patient had 2 stimulations prior to with very low response. So why is a low response also a low prognosis patient? Why the one brings about the other? Because if we look at numbers, right, with an average fertilization rate, average plus plastulation rate, if you start with 4 to 5 oocytes, you might get a day 5 embryo to transfer. So obviously you start with a low number, you have a very low chance for pregnancy overall. We do know that the higher the number of eggs, and it plateaus at around 15, the better the chance for a baby at the end of the day. And if you look at those graphs, it stays the same no matter, like the graph goes up the same way no matter what the age group of the patient is. So yes, 15 is the magic number for somebody maybe that is younger, but we have a similar graph even on the 40 and above patient, that the more oocytes you're going to retrieve, the higher the chance for a pregnancy you have. What is the incidence for a poor responder? To have a poor responder, anything from 9 to 24%. You have such a great number of range of reported incidence because we don't all agree with what is a poor responder. But we also know that even on the younger group, like younger, relatively younger, 30 to 39 years of age, 1/3 of those patients will be poor responders. So this is a huge percentage in our practices that we're faced with this problem. Why is the antral follicle count important in defining somebody as being a poor responder? Because we know that there is clear relationship between antral follicle count and live birth rate in IVF. If you look at the right side, you have live birth rate on one axis, and then you have number of AFC, and at all age groups, the more oocytes, the more AFC you have, the more oocytes you'll get, the higher the pregnancy rate will be. Similarly, AMH predicts chance for pregnancy similar with the antral follicle count. Higher the AMH, more oocytes at the end, more embryos, better chance to choose one good embryo and establish a pregnancy. So most definitions, as we said, are not clear, and the confusion is between a poor response and also an unexpected poor response that blends, okay? So if we go to the Bologna criteria, we cannot necessarily say who is an unexpected poor responder versus the one that we expected. And because of this heterogeneity, we cannot treat the patients the same way, or we cannot foresee what's going to happen and adjust our practice the same way. So we have also two distinct concepts. We have age and we have number. So it's really bad to have an older patient with low numbers, but it might not be as bad to have a younger patient with low numbers. Why? Because the younger patient, even if she gives you less oocytes, the quality is going to be better, so you're going to get a euploid embryo at the end of the day. But on a older patient, if you get a low number of oocytes, you probably will not get an euploid embryo, so no chance for pregnancy. So because of that distinction, the Poseidon group came about, and basically they looked at what is most important. And they defined that the age-related embryoblastosis and aneuploidy rate makes a big difference, because that can change the prognosis of the patient at the end of the day. And also the ovarian sensitivity to the exogenous gonadotropins will make a difference. You might give FSH to somebody, but she doesn't respond well, although her AFC and her AMH is good. So this is an unexpected low response versus the patient, you didn't anticipate this to happen. So then the Poseidon group came with 4 groups of low prognosis patients. The ones that are young with good ovarian reserve, and you have an unexpected low response. The ones that are old with good ovarian reserve, and again you have an unexpected low response. And then you have the ones that are either young or old that have poor ovarian reserve, and of course it's expected to have a low response. So why is age so important? Okay, because the percentage of euploidy on blastocysts is going to be very different. So if you look at this data here, on egg donors, which are all young, no matter how many embryos you have, the percentage of euploidy pretty much stays around 70%. Less than 35 years of age, average is going to be approximately 60-65%, 35 to 39 is going to be 50%, 40 to 42 is going to be 30%, above 42 maybe 20%. So really the percentage of euploidy, irrespective of how many embryos you have at the end of the day, is defined by the age of the patient. And why stratifying by number of oocytes is also important, because the higher the number of oocytes, irrespective again of age, will give you a higher pregnancy rate. So Poseidon's marker of successful outcome is basically the ability to retrieve the number of oocytes necessary to give you at the end of the day 1 euploid embryo, because that by itself will give you a great chance for pregnancy, a 60-70% chance for implantation and ongoing pregnancy. So here we can see that irrespective of age, if you have a euploid embryo and you put it back into the uterus, you will have a success of 60-70%. That's implantation rate, yeah? But obviously, if you haven't screened and you just put back an embryo, you don't know if it's euploid or unemployed, as expected, the implantation rate will significantly reduce as the age of the patient goes up. So how many oocytes are needed for 1 euploid embryo, okay? And this, again, you can look at this, and you can see that if you take on average percentage of what is going to be mature at retrieval, how many going to fertilize 75%, cleavage 90%, blastulation 40%. If you do all this math, then you also need to factor in that the percentage of euploidy rate in the younger patient is 60%, middle age is 50%, on the older patient is 30%. So if you put all of this together, you know that you need 8 oocytes in the younger patient to get 1 euploid blastocyst. You need 10 oocytes for a euploid blastocyst at the middle range of the patients. And when the patient is 40 to 42, you will need 17 oocytes to have 1 euploid blastocyst at the end of the day. So that's a lot of numbers. I mean, that's a lot of oocytes, given that the patient who's 40, 42 is going to be giving you few oocytes every retrieval you do. So let's look at the 4 subgroups now of the Poseidon group. This is the patient who is young with poor ovarian reserve. You start stimulation, but she's not responding. She has an unexpected low response. Usually, this is because of a genetic polymorphism on the FSH-LH receptor. And how you can address that is if you add LH or HMG, and obviously the other route you could take is increase the FSH level and reach that threshold that the patient is going to respond. If you have the old patient with good ovarian reserve, and you get an unexpected low response, genetic polymorphisms can be the underlying cause, so you can increase the dose or you can add LH preferably, to this stimulation to get the patient to respond. Now, if you have a young patient with poor ovarian reserve, it's not expected she's going to give you low oocytes, but there, what can you do? You can max at 300 IUs for stimulation, but you can also consider adding androgens, and we'll come to the data on that. And then you can accumulate more embryos and then have a higher number at the end of the day to transfer. And similarly, for the old patient with poor ovarian reserve, you can accumulate embryos, and duostim is something we're going to talk about. You can also use androgens or growth hormone, and we'll come to the data. So, Poseidon group 1 and 2, this is data that is published. It's better to add recombinant LH. Merck has Luveris or has Pergoveris, and that would be the route to take to get a good response on somebody who has good reserve, but you started with FSH only and your response is not what you expect it to be, because most likely it's a polymorphism on the receptor level. So add LH, and you're going to see the patient's response pick up, and it's proven that it's better for the patient, obviously. On the Poseidon group of 3 and 4 patients, these are patients that have low reserve. So it's not unexpected they're going to give you low number. There you need to do either duostim and or other adjuvants that you can put to the recipe. I will skip really fast through the duostim, and I will go to agonist versus antagonist. Is one protocol better than the other? No, this has been published, so you can go either way. Milder forms of stimulation makes no difference. 300 IUs is where we normally max, because you're not going to get a difference or a higher pregnancy rate if you go higher. How about growth hormone? Very limited data, although it shows that it increases your ongoing pregnancy rate, but it's very expensive. Few data, is not recommended for everyday clinical practice. Similar androgens, although there is good data, now there is ongoing study from Polisos. It's not published yet, but he's a good friend of mine, that shows that this is probably not making much of a difference. So testosterone, although it had given some good results initially, is probably not going to make a difference. DHEA was highly publicized initially, but the latest meta-analysis shows that it does not make any difference, so no role for DHEA in poor responders. Aromatase inhibitors, adding to like oral medication with 150 of FSH or HMG or Pergoveris, similar pregnancy rates, okay? And of course, adding LH, recombinant LH will improve your rates, pregnancy rates on patients that are older. And in conclusion, I'm sorry, I'm running through slides here to catch up. Growth hormone transdermal testosterone improve clinical pregnancy rate, but there are a small number of studies. In everyday clinical practice, I don't think there is any role, and I think we would mostly, all of us agree. LH supplementation increases live birth rates in older patients, and that's something we should keep in mind. We should never use just FSH on older patients. Clinical pregnancy rates are not different with low dose versus conventional. It's not different if you use oral plus HMG. And mild ovarian stimulation is cost effective, though the live birth rates is very low, whether you do this, that, or the other. So this is the more frustrating subgroup of patients that we have to treat. And again, thank you for your attention. I'm sorry I rushed through. Yeah, okay. I don't know if there's time for questions.
I think we'll save the question if Prof. Okay. Dr. Okash.
Thank you for a very well summarized presentation. My question is, I have seen literatures on stem cell therapy as part of a treatment for poor ovarian reserve, which is also almost the case with poor responders. And I do know that there are some centers in the mainly in, I think, in Turkey, where they provide commercially available stem cell therapy. What is your experience? What are the state of affairs currently?
Responders. I think we're still going to have the same problem. Yes, you might increase the number, but unemployment rate remains the same, meaning you're going to still, although you might get more, again, you cannot correct the bad quality. And I know of commercial, centers, like even in Greece, I know there are some centers that offer it. No randomized control trials, nothing that we can really talk about it. So I cannot say that this is an accepted practice. But could there be future? Yes, but again, it doesn't correct unemployment rate. It might increase the numbers, possibly. So you might get more numbers from an older patient, but that doesn't mean that you're going to get good quality eggs. So.
I think the jury is still out on that data.
Exactly. There is no many data.
Thank you, Professor Kopis.
I'm Janet Evans. I'm speaking to you from a very chilly morning in Cardiff. That's why I'm all wrapped up. And I wonder if I could see my slides on the thing. If not, I can go into PowerPoint. That's lovely, thank you. So let's get on with it. I've been asked to talk about whether semen analysis is enough for diagnosing male infertility. Next slide, please. Can I have the next slide, please? Thank you. With any medical condition, we're all taught as medical students to take a history, do an examination, then undertake investigations, make a diagnosis, which then in our field leads to treatment options and planning of treatment with our patients. Different conditions will have different timeframes and priorities. Next slide, please. So what is semen analysis? It's a diagnostic test, and for us, it's often an essential first-line component of male infertility investigations. It looks at the sperm count and the concentration of sperms. It looks at the motility. It looks to see whether sperms are swimming in a straight line. Do they look like they know where they're going? Or are they going around in circles? Or are they just sort of shaking a bit on the spot? Or are they lying there immotile and possibly dead? We also look at morphology, which is basically looking down a microscope at a sperm and saying, do I think you look normal? And that's quite a subjective test, and it's up to the embryologist. We very often also do a MAR test for anti-sperm antibodies. And all these things we look at, and then we look at the WHO criteria for the normal range, and we say, does this patient fit that normal range or not? And if not, then we have male factor infertility. Next slide, please. Next one. Can I have the next slide? Thank you. But is this enough? Well, we all know of situations where the semen analysis looks normal. We say there's no male factor. We recommend IVF, but there's unexpected failed fertilization, either due to failed sperm binding to the egg or failed sperm entry, and that's due to problems with capacitation or with acrosome reaction. And I can talk a bit more about that later if we have time, but I'm going to pass over that at the moment. The other thing that the sperm has to do, apart from get in the egg, is deliver its DNA and also deliver a protein called PLC zeta, which then triggers the next stage of meiosis and mitosis, creating an embryo. So the incidence of failed fertilization in IVF with normal men, normal semen analysis, is around 5%. So we then have to ask the question, should we be investigating further to predict this? Next slide, please. Can the next one, please? Thank you. Clearly, semen analysis may not be enough in all cases. So we then need to think about, okay, what other tests are possible? And who should we do them on? Should we do them on everybody? But that's 95% of couples not needing them. If not everyone, who should we target? And if we target those with the abnormal semen analysis, then why bother? Because we do ICSI anyway. And that will overcome most of these problems. Clearly, some tests are good management, good clinical management, and we often will find problems from the history. Not many of us as gynecologists will examine men, and it tends to be more something that you might do in an adolescent endocrinology clinic rather than a fertility clinic. So let's look at these tests that are available. Next slide, please. Next one. Have the next slide, please. Have the next, thank you. But before we look at these tests and consider them, we also need to think about, from the patient's point of view, the cost of these additional tests, the practicality of them, are they actually available commercially? The time that is wasted and taken by investigating further, and don't forget our female patients are getting older while we're fiddling around making a diagnosis. We've got to think about the cost versus the benefit if we apply it to everybody, and then think about what sort of treatment were we going for anyway. If we were thinking about expectant treatment, I think we've gone back a slide. If we were talking about expectant treatment, then it's probably not relevant. If we're thinking about IVF, IVF is going to give us the answer. If we're talking about ICSI, then there's no point in doing any of these tests. I think we need to go forward 2 slides now because we went back one. Next one. Next one. Okay, and we also, as clinicians, need to bear in mind that what our couples want is a baby, not a diagnosis. So their priority is to move quickly on to treatment, appropriate treatment, and their resources may also be limited financially and time-wise. And so they will want to direct those resources towards treatment, not diagnostic tests, which may only be helpful in 5% of couples. So let's go to the next one. So let's look at these tests. Well, we can do examination of the scrotum and testicular measurements, but as I've said, that tends to be an adolescent endocrinology thing rather than a fertility thing. We could scan the scrotum or do a transrectal scan, but we need to have the right probes, and often we don't. Scrotal ultrasound is useful for picking up tumors, but it's not going to be so useful for us. Transrectal ultrasound might show dilatation of ducts, but semen analysis in that situation, if there's a blocked duct, is going to show azoospermia. So that's a bit irrelevant. We can do hormone testing, and certainly there is a place for LH, FSH, and testosterone testing in men with azoospermia to discover the cause of that. And I'll come to that a bit more later. We could do post-ejaculation urinalysis, which is useful for retrograde ejaculation, but has tended to be overtaken by doing a PISA to get a clean sample. We can do genetic tests like chromosomes, etc., but these are very expensive and really only appropriate in azoospermia. And we could do testicular biopsy, but my advice to you with doing testicular biopsies is if you're going to do it once, and if you find some sperms, have consent and facilities to store, because that patient's not going to thank you if you say, well, we found some sperms, but we couldn't store them, so we'll have to do it again. Next slide, please. There are also specialized sperm function tests, such as sperm donor binding ratios, zona-pellucidar-induced acrosome reaction tests. But if you actually look in the literature at these, you will find that these are things that were reported 10, 20 years ago and haven't been looked at again since, and have probably been merely a research tool rather than anything more commercially significant. Sperm DNA fragmentation tests are interesting and are often done, especially in older men or in men where you suspect there are a lot of reactive oxygen species. But the treatment for that would be ICSI or vitamin treatment, and we can always give vitamins anyway, and it's cheap and cheerful, and patients are often happy to take them. Next test thing, please. So these tests are only likely to be used where the semen analysis is abnormal. They can't really be justified in every couple with a normal semen analysis, and they're going to be unhelpful in detecting the 5% unexpected failed fertilization. If we have an abnormal semen analysis, then we're going to be looking at ICSI management, not donor in the majority of cases. So why not just do ICSI when the semen analysis is abnormal and stop wasting patients' time and money? Next slide, please. There will be men with azoospermia, and they will need further investigations because they're going to want to know why they've got azoospermia. And the diagnostic categories are shown in this table, although this table is not complete. So if you think about the hypothalamic pituitary testicular axis, at the top you've got the hypothalamus, and you can have hypogonadotrophic hypogonadism. If you do FSH, LH, and testosterone, that's going to give you that diagnosis because the gonadotrophins will be low, and so will the testosterone. And if they've got anosmia, then you've got game, set, and match with Kalman's syndrome, which is a genetic condition. In the middle, you've got pituitary, and problems there are most likely to be due to prolactinomers. You can have a high prolactin, and that might be affecting gonadotrophin and testosterone levels. At the bottom, you've got the testes, which may have failed. And in that situation, like ovarian failure, you'll have high gonadotrophins and low testosterone. And those are the ones that are a difficult group to treat, because if you don't find any sperms on a teaser, then they're left with having to either live with the situation or go for donor or adoption. At the end of it, now can we go back one? Because I've just got another couple of things to say on that one. At the end of that axis, there is then the vas. And if the vas is blocked, then gonadotrophins and testosterone are going to be normal. And sperm production is going to be continuing, but sperms are just not getting out. So you can diagnose that, and patients will be very happy, because all you've got to do is pop a little needle in the epididymis and find a whole load of sperms. But again, make sure you can freeze them with consent. And the last one that isn't on that little list is steroid abuse. If you do gonadotrophins and they are low, but there is normal testosterone, then clearly that is not coming from the testes, it's coming from somewhere else. And you need to talk to them very carefully about what's going on in the gym, because they may well be injecting themselves with androgens, and the wife's not going to be very happy. In summary, is semen analysis enough? It depends on the objective. It will tick most of the boxes in highlighting an abnormal result and direct the couple away from IVF towards ICSI management. It will tell you if you've got a normal sperm count, if you've got a man with a male factor infertility due to poor morphology, low numbers, low motility, and direct them towards ICSI. And it will give you the couples with azoospermia who can go on to further treatment. In azoospermia, do the endocrinology and retrieve sperms from the epididymis or go for donor. When failed fertilization occurs, this is currently unpredictable, and the only way to diagnose it is to take a trial of IVF, then find you've got failed fertilization, explain to the couple, and then treat them with ICSI next time. But next slide, counsel the patients about failed fertilization rates of 5% with a normal semen analysis and IVF, so they are aware of the possibility and unpredictability of the outcome. And this is my final point, but very important, document that you have counseled them about this so that you avoid litigation, which might be around the corner. Next slide, please. Next slide, please. I think there's one more. We have the next slide, please. References on, there you go. So sometimes people like to go away and look these things up. Some of them are quite old, though. As I say, you know, these are the tests that have been lost to posterity. And thank you very much for allowing me to give this talk today, and I wish you all the best with the rest of the day. Thank you.
Today I'll be talking about DNA fragmentation as a diagnostic tool for male infertility, the pros and cons. Thank you for asking me to talk about this. So my question is truly, is DNA fragmentation a tool for male with infertility? I have no conflict of interest to declare, apart from being active in a few international organizations. The three educational objectives today are to detail what DNA fragmentation really means, to discuss some guidelines and evidence published, and to address the pros and cons of using this particular test. Furthermore, I think from a clinical practice perspective, because this is mainly about what should we do with our patients, meeting, my role is to raise awareness of the condition, to discuss causes and ways to reduce DNA fragmentation, to explore potential candidates for sperm DNA fragmentation testing, and reveal limitations of this particular investigation. And if you Google sperm DNA fragmentation, you will see an increasing number of publications for the last 15 years and some 3,300 results. And in the grand scale of things, this is only a fraction, because if you just write down DNA fragmentation, you'll see 10-fold more publications than related to sperm in particular. So this is the very first document that I'd like to suggest you read, and it's an article published in 2020, 2 years ago, in the World Journal of Men's Health by renowned people like Ashok Agarwal, looking at sperm DNA fragmentation, a new guideline for clinicians. And these are pictures from this publication. It's good to see that basically DNA fragmentation is a destruction of the DNA at certain levels, as you can see as pointed by the arrow there. And when we ask ourselves what type of breakages can occur, this paper details them very well with mismatched bases. And you can see here the 4 letters of our genetic code are mismatched, and these are replication errors. The next one, missing base pair induced by reactive oxygen species, base modifications, so the base itself is not healthy anymore, induced by UV lights, alkylating agents, and so on and so forth, up to the level where the DNA strand is completely either one side or both sides completely broken. And to understand the basics, I think it's very important to acknowledge that DNA fragmentation is a normal occurrence in spermatogenesis. Okay, our DNA, it gets fragmented in any cell, but particularly in spermatogenesis, and the degree of fragmentation increases with the age of the male. And what are the main risk factors? When we see those patients in our services, when do we think, oh, this person might have a semen sample with sperm that have an increased DNA fragmentation percentage? So males that are a bit more advanced in age, as my previous speaker eloquently detailed, men that have varicocele, men that smoke, men with previous genital tract infections and current undiagnosed genital tract infections, and of course males after, or of course during, but you will not treat those during, but men after chemo and radiotherapy life-saving treatment. So here from the same papers, we can see that single DNA fragmentation strand breakages can occur after a free radical exposure, and complete breakage after ionizing radiation and genotoxic chemicals, and of course radiomimetic medication. Succinctly, the paper from Agarwal details in a very beautiful manner the risk factors at one side, which we've just mentioned, on varicocele and cryptorchidis, infection, maturity, lifestyle and foods, of course, smoking and alcohol, environmental toxin and ionizing radiation, causing oxidative stress, which now starts creating defective DNA strands and results in damaged sperm. And in terms of testing, probably this is the most challenging part of our daily clinical practice, and it's related to the availability of these tests. And I have no doubt there'll be not too many centers in your own countries that will have access to sperm DNA fragmentation testing. So there are two types of tests, direct and indirect. And the direct measures the extent of the DNA damage with a tonal assay that looks at both single and double DNA breaks. It's not standardized. And the ISTN, single and double breaks together, it's easy test. The indirect one measures the DNA protein denaturation as opposed to DNA damage. And there's the COMET one, you might have heard. The more fragmented the DNA is, the more tail forms after. The halo test, or the sperm chromatin dispersion test, in which a good, well-packed DNA forms a nice halo, and totally fragmented DNA does not form a halo. And then the one that probably most of you have heard is the sperm chromatin structure assay, or SCSA. This is standardized but expensive and requires expertise. So maybe a conclusion here is that there is no universally accepted test in terms of laboratory. So if we are to accept that, yes, maybe DNA fragmentation is something we should offer our patients, we need to ask ourselves first, is this a diagnostic test? In other words, can this test differentiate between men that cannot get a woman pregnant and men that actually can and they are fertile? But just to draw your attention that to date, studies have compared males with proven fertility and infertile men in rare occasions, very few studies. Usually the comparison is between DNA fragmentation in infertile males and males with normal semen parameters. But a man with normal semen parameters that has not obtained a pregnancy before is not really a fertile male. So let me just take you through the evidence that currently exists. If you look at this paper from R. Manzini that asked the question, is conception impaired by high sperm DNA fragmentation? He quotes three papers, 1999, 2000, and 2010. The first one compare male with abnormal DNA fragmentation and males with normal semen parameters, and they're obviously not relevant. So I'm just focusing on the last paper, Giverkman in 2010. This is a paper from Sweden where they looked at 127 males that had unexplained infertility with different degrees of fragmentation, and a good group formed by partners of pregnant females that were attending the antenatal clinic services. So you can see here three groups. Group A, B, and C have different degrees of fragmentation. A, 10% fragmentation, B, somewhere between 10 and 20, around 15%, and group C, more or equal to 20% fragmentation. And they showed that if in infertile males that compared to men that have proven fertility, the DNA fragmentation was higher. So that was the very first suggestion that maybe in infertile males, the severity of the DNA fragmentation will impair natural conception. The researchers then proceeded to explore what should the treatment be if a male has DNA fragmentation. And it was suggested that patients with DNA fragmentation may benefit from methods of sperm extraction directly from the testicle. Okay, so now we're telling a man, you have some DNA fragmentation, please have a cut in your testicle so we can extract sperm. And the justification would have been that sperm cells would have not been exposed to high levels of reactive oxygen species. That obviously happens as the sperm is produced, and it also stays in the vas deferens. And may I just bring to your attention this paper published by the group in Spain, excuse me, on it's a meta-analysis of 5 in total studies looking at reproductive outcomes of testicular versus ejaculated sperm for interstatus ejaculated sperm used with intracytoplasmic sperm injection in men with high levels of DNA. So firstly, look at the numbers. They're quite small numbers, 62 patients versus 62 patients, and in one single trial, 81 versus 81. When added together, it suggests that it's better to use testicular sperm as opposed to ejaculated sperm. Yet when you compare, and I know this is a bit small, you can't see extremely well, but fertilization in oligospermic and normozoospermic, there was no difference. So just to go back a bit, in the men that had high DNA fragmentation, this was not a uniform group. There were men that had normal sperm parameters and men that had low sperm parameters. So this is a non-homogeneous group. We cannot draw a conclusion that just because you have low DNA fragmentation or high DNA fragmentation, you should immediately have testicular biopsy. And you'll see other guidelines that are following. So if maybe such suggestion of one, DNA fragmentation is important in predicting if a natural conception occurs or not, and two, maybe one should consider testicular biopsy in all males that have high DNA fragmentation, we need to ask ourselves, can't we actually prevent DNA fragmentation? And I think simple lifestyle changes and interventions are crucial. Firstly, advise patients to stop smoking, abstain from recreational drugs, take a healthy diet, treat genital infection with antibiotics, and consider treating the varicocele. So, for example, studies where these interventions have been applied and then a follow-up semen analysis with a follow-up DNA fragmentation analysis with a follow-up of natural pregnancy, these studies don't exist yet. To continue, I might ask the question, when is, in fact, this test recommended at all, sperm DNA fragmentation? It appears to be some consensus that men with unexplained infertility and normal semen parameters could benefit from sperm DNA fragmentation, recurrent pregnancy loss cases, and recurrent implantation failure. And let me just give you the guidelines succinctly. This is the guideline from the European Association of Urologists. And you can see the bottom three recommendations. Sperm DNA fragmentation testing should be performed in couples with recurrent pregnancy loss, either after natural conception or ART, and in men with unexplained infertility and normal semen parameters. And this is a strong recommendation. They, of course, being the urology group, suggest that one should have a varicocelectomy done in men with high DNA fragmentation or in men who have suffered from failed ART, recurrent pregnancy loss, or recurrent implantation failure, but it's a weak recommendation. So if somebody has a large varicocele and also they have these conditions, maybe consider having varicocelectomy. But very importantly, and quite a strong recommendation, that testicular biopsy and ICSI is not recommended routinely in normozoospermic men, men that have normal semen analysis but have high DNA fragmentation. It's not recommended to have testicular biopsy and ICSI. The next guideline is one from the American Urologist Association and the SRM, and very similar. Sperm DNA fragmentation analysis is not recommended in the initial evaluation of the fertile couple, and for couples with recurrent pregnancy loss, men should be evaluated with karyotype and sperm DNA fragmentation, but a moderate recommendation, so very similar. So we need to acknowledge that these tests have limitations in terms of instrumentation availability, trained personnel, and of course the enormous cost of these tests that are done. Furthermore, there's no universally accepted standardized test. It's a more reflection of male health than a tool for male infertility, and the assessment includes dead and live sperm, thus not 100% representative. So, ladies and gentlemen, we discussed who should be tested, and guidelines suggest that male with normal semen analysis and unexplained infertility in situations of recurrent pregnancy loss and recurrent implantation failure. And if the test is done, a DFI over 15% is significant and needs further treatment. And of course, we need to prevent by advising lifestyle changes. So the take-home message is the male is only one of the contributors to conception. The competent oocyte from a young female can compare fragmented sperm DNA, and SDF testing could help identify males that need varicocelectomy, could reinforce the message of lifestyle changes, and could provide an explanation for recurrent pregnancy loss. With that, I would like to say that there are many unanswered questions like, is high DNA fragmentation a modern phenomenon only? Remember, a male makes millions of sperm on a daily basis, so some will be faulty. There are high risks with IVF and in particular ICSI, so are they truly needed? Should we jump and do a testicular biopsy? I don't think so. And does Mother Nature not know best anymore? I'd like to say thank you again for you to listening and happy to take any questions.
Thank you so much, Dr. Edgar, for this wonderful presentation.
Pleasure to be able to communicate and to speak at the African and Asian Luminary. I have been at a number of these meetings, are always exciting. They get better each year. And as I could speak again to echo what President Mercado of the IFFS has stated, we are very impressed with the progress that Russia and Merck Foundation have made in terms of increasing the access to care, in particular in sub-Saharan Africa. We laud this. It is an advance and a success that the world needs to hear about and continue to hear about. Our first relationships in a formal basis with Russia and her group was in the 2016 World Congress of IFFS in Delhi, and that's continued since then. So my topic today, as you've heard, okay, unless it can advance, okay, is self-explanatory. Fertile couples, it develops, are learning that they're at risk for heritable cancer, and they choose IVF and pre-implantation testing for selections of unaffected embryos. That is to say, this is a new indication and one that we who play a role in vitro fertilization need to encompass, because these people need our help. I have no, can we advance the next slide, or there we go. I have no conflicts, and we can move on to the topic. So there's increased recognition of the genetic basis of cancer susceptibility. Once we imagine that a wide variety of extraneous exposures cause cancer, for example, viral diseases. We now recognize over the last decade in particular that cancer in adults is usually genetic, and it's because you have inherited and born with a germline mutation. There is increased genetic screening, and so many people are learning that they do have a mutation that increases the likelihood that they will develop cancer. There's an increased realization that the same gene can cause cancer in multiple organs, and that's because we were born with the germline mutation, and it existed throughout the body in all organs. And finally, the key thing that, for a reason why we're offering this topic today, is there's increased appreciation that any parent with cancer susceptibility places each of their offspring, male and female, at 50% risk of inheriting this cancer susceptibility gene. And therefore, in vitro fertilization units need to be involved. So the feasibility of genetic screening and testing has also greatly increased in recent years. The technology is readily available for detection of DNA mutations in all genetic disorders, and certainly including cancer susceptibility genes. It's applicable to many cancers and not those that are simply ethnicity-based and typically could have been done by a screening that was available prior to a pan-ethnic screening. The sequencing methodology is robust and remarkably inexpensive compared to what it was in the past. We could sequence the entire human genome for about $1,000. Now, a little bit more about cancer susceptibility genes. So again, let's repeat that these are usually autosomal dominant. An example would be BRCA1 and 2, the most common cause for breast cancer, due to a germline mutation. The germline mutation needs to be emphasized as present in every cell in the body at birth. There is a very high rate of clinical cancer, but it's not inevitable because there needs to be a second or multiple somatic mutations that are tissue specific and are required for the manifestation of clinical cancer. Here's an example of what we've just covered in the past. Let's take to the left. The frequency of breast cancer in the general population is about 7%. If you have BRCA1 or BRCA2, it goes up to 87% by age 70. The same gene in another organ, namely the ovary, shows an increase from 0.7% of the general population to 63%. And importantly, look to the right further as you move, and you can see that BRCA1 and 2 also play a role in male cancers, namely prostate, and in male and female in terms of pancreatic disorders. So there are multiple organ systems that are house cancer as a result of these cancer susceptibility genes. Now, it's also important, given what I've said, to remember that since cancer susceptibility genes are present at birth and they're throughout the body, it's hardly a surprise that multiple genes can be associated with breast cancer. So you can see about a dozen here, 11 to be exact, BRCA1 and BRCA2, plus many other organ systems. And all of these are causes of breast cancer. And in fact, they're simply the most common causes of breast cancer. Move over to the right, and you can see what happens if we take a single organ system, for example, TP53, and you can see that not only is this an explanation for breast cancer, but also for a number of other organ systems, some of which, such as melanoma, would be a surprise and not anticipated for that. Next slide, please. So in addition, it's hardly surprising, given what I've just said, with multiple mutations causing cancer in all organ systems, that this is a frequent cause for individuals wanting to have a diagnosis, and in fact, for there to be a diagnosis of the embryo. So the group in which Dr. Rashetsky and I are involved has done about 30,000 PGT cycles for monogenic disorder, that's PGT-M. And here are some of these disorders, simply the most common ones. And some of these are quite familiar to you. Hereditary leiomyomatosis, for example, there's cancers can cause when associated with renal tumors, BRCA1 and BRCA2, the familial adenomatosis, for example, and other disorders that exist. So the ones in red are typically the most common adult onset disorders, and they're the ones that we will especially need to put in our IVF armamentarium. Next slide. So here's our recent experience and past experience. This laboratory has been involved since 1999 for PGT for monogenic disorders, a long stretch, and that accounts for its 30,000 PGT cases for 705 different conditions. So it's a simple matter simply to add the monogenic conditions for adult onset, as you can see in the line beginning including. So we have included, so to speak, 874 cancer predisposition PGTs, 900 neurodegenerative conditions, and also more recently about 100 cardiac conditions for that. Next slide. So given what we've seen in terms of cancer diagnosis and gene panels, it's hardly a surprise that if you want to know the basis of whether an embryo has or does not have a cancer susceptibility gene, this would increase. And so this shows you the frequency of many disorders that exist and have contributed to the histograph showing the red bars going up. So for many years, we were doing perhaps 20 to 40 cases per year. And you can see the great increase since 2017 as an example. The pandemic did not slow this down. And in 2021, a total of over 160, almost 180 PGT cases to diagnose the embryo status with respect to cancer susceptibility genes. So this is where we stand right now. So given that, why do we have that? Next slide. And that's because since the cancer susceptibility genes are autosomal dominant, that anyone who has that gene has a 50% likelihood of transmitting that to any son or daughter. The parent is going to be older past the age of reproductive fitness, but the children, son or daughter, typically will not have passed that. So they would be in their 30s, even in their 20s, and each has a 50% risk. There's a 25% risk, in fact, that every grandchild has the cancer susceptibility genes. So in addition, it's very important to point out that both male and female offspring, and similarly such in grandchildren, may be at risk, for example, for BRCA1. And so we've talked about breast cancer in ovaries, but remember the males in this kindred are at increased risk for pancreatic cancer as well as for pancreatic cancer. So again, just to remind you, the slide, you see this before, but look at the increase in the frequency if you have the cancer susceptibility gene compared to if you are in the general population, a huge increase. Now, what happens as a result of that? What sort of management has changed? Next slide, please. So suppose that you have learned that your parent, male or female, has a cancer susceptibility genes. In that particular situation, and there's a 50% risk, you have really two choices if you wish to monitor the pregnancy. Number one, you can do traditional amniocentesis or chorionic villus sampling in the second or in the first trimester after natural conception, and the embryo can be tested. On the other hand, there's a 50% likelihood of a clinical pregnancy termination being needed or being considered. And so this is a much higher risk than you would get if you simply did amniocentesis for the detection of a chromosomal abnormality. That risk is about 1 or 2%, not very high, but 50% is a horse of a different color. So the other option is to do in vitro fertilization, which naturally generates a cohort of embryos for pre-implantation genetic testing and embryo selection. And in fact, that is exactly what most couples in this situation are doing. That's the reason we're doing now at this time about 200 cases per year for PGT. Now, if we're going, next slide, please. If we're going to offer this PGT aneuploidy based upon the selection of embryos, there are a couple of pitfalls that need to be taken into account. The first pitfall is that if you want the highest rate of success, and these usually are fertile couples, so we can easily obtain high rates of pregnancy succession here. That needs to be combined with pre-implantation genetic testing for aneuploidy, for chromosomal abnormalities. So you're testing both for that as well as for the cancer susceptibility gene in question. No additional biopsy is needed because you've amplified DNA and you've got plenty of DNA around to do a number of tests for this particular purposes. The second pitfall is that this is the analysis for the exclusion of a cancer susceptibility gene is much more complicated than what we have encountered for many single gene disorders that are childhood in onset, such as sickle cell anemia, where in sickle cell anemia, there's only a single mutation that accounts for most of the cases in sub-Saharan Africa. But in cancer susceptibility genes, I'll show you that the frequency is much different. And finally, we have methods to make sure that the accuracy is verified. I will not go into that because of the limitation of time, but nonetheless, we'll illustrate it. So here is what happens if you add pre-implantation genetic testing for aneuploidy, chromosomal abnormalities, in green to that which you have already done in terms of just looking for the single gene cancer susceptibility genes. So the latter is in red, and an additional 20% success rate occurs when you simply add, with no added risk to the embryo, of a diagnosis for chromosomal abnormality. Similarly, the spontaneous abortion rate, miscarriage, drops from a level around 12% to about 4%. So we have won in several different situations or so. Next slide, please. What about molecular heterogeneity? Molecular heterogeneity is much more common in adult onset single gene disorders like cancer susceptibility genes. And in fact, most of these do show molecular heterogeneity. And so therefore, you need good sequencing or good gene panels to decide and identify the breadth and the depth of DNA interrogation. So it's not as simple as, say, looking at sickle cell anemia. So in this particular situation, let's just illustrate it. This is BRCA1 and 2. Go to the top and you can see that 67 of 156 cases that we've done recently showed the most common mutation. 187 is the codon, and there's a deletion of 2 nucleotides, AG, in that situation. But you look at what else is occurring and go down to the blue line, unique mutations. There's an equal number in which the mutation occurs only in a single family, at least single family that we have tested. So this is a much more complicated situation. BRCA2, you can see the same thing, deletions of thymine, and that is present in 46 of 106 cases. And the unique mutations, on the other hand, are more frequent than that. They occur in about 60% of the population. Next slide. So how easy is it then in sub-Saharan Africa in particular to utilize this technology? We certainly realize that not every country has a genetic laboratory that's available for that, but it's simple to develop a relationship anywhere in the world with laboratories that do these genetic testing using an in vitro fertilization unit that can provide information on the family and can perform the embryo biopsy and send the sample to the genetic laboratory. The genetic laboratory has a responsibility of testing each embryo and returning a diagnosis back to the IVF unit wherever in the world they're located. Next slide. To give you some specific details about what you would expect for any of the laboratories that would be offering this service and collaborating, this is what we do ourselves, but it's certainly not unique. We need to know the genetic diagnosis and verify that we're able to offer pre-implantation genetic testing for embryo selection from this group. And this communication can occur in all sorts of ways, emails, fax, or any provider portal that may be available in the original IVF unit. If the IVF laboratory does not have, and they may not have, the necessary material to provide the diagnosis, tubes, racks, lysis buffers, and packaging material, that can be provided by the laboratory and should. There's a simple solution, not complicated, to send the embryo biopsy sample to another continent. It's simply to send it by cold pack, and we, in particular, believe that DHL is very useful here. Next slide. So the summary, what have we talked about? We've talked about cancer susceptibility genes are present in germline at birth and in all cells, but clinical cancer occurs only if a second mutation exists. The cancer susceptibility genes are of adult onset. They're usually autosomal dominant, transmitted with a 50% likelihood to every offspring, son or daughter. The offspring of a person with cancer susceptibility gene in this situation, wishing to determine whether they will transmit it to their own offspring, increasingly choose an IVF cycle, and even if they're clinically fertile, to test for the presence or absence of an embryo that would confer that on their offspring. And finally, PGTM is accurate with a high pregnancy rate. Next slide. The final slide shows some of the references that can be utilized. Dr. Evans showed you that. These are some of the ones that we have available and have contributed in the pre-implantation genetic testing international society. Next slide. And final slide is a thank you. And these are the email addresses for myself as the medical director of this unit, and Dr. Rashitsky, who is the longtime laboratory director and the president of the group. So each of these, simply email us and we will have an answer for you. And again, I'd like to thank Rasha and her team on behalf of International Federation of Fertility Societies. And it's clear that you have an exciting meeting going on. I've heard talks proceeding up to this one. And I hope we'll be able to meet in person at future venues. Thank you very much.
Thank you so much, Dr. Simpson, for this amazing presentation.
But now we move quickly into the panel discussion. So we'll start this section with a panel discussion in just a few points. Each panelist will have 5 minutes to answer 2 questions or 3. And then after 5 minutes, we have the bell. Once you hear the bell rings, please, it's an indication that we'll be asking the next panelist for their own points. Without wasting time, I would like to call upon the first panelist, Dr. Nicholas Mazuguni. Dr. Nicholas Mazuguni. Okay, he's a consulting gynecologist and fertility specialist in a Merck Foundation alumni from Tanzania. The second on the list is Dr. David Vesia. Dr. David, sorry if I mispronounced. He's consultant obstetrician gynecologist and a fertility specialist, women's health and fertility specialized clinic in a Merck Foundation alumni. You wonder, okay. The next person we'll call Dr. Thomas Mercury Gabriel. He's an associate professor in obstetrics and gynecology, RE subspecialist and CEO of Center for Fertility and Reproductive Medicine, Ethiopia. We move to Dr. Gilbert Nabatanga. He's an obstetrician gynecologist, fertility specialist in Merck Foundation alumni, Burundi. We have Dr. Feru Soru Okach. He's an associate professor of obstetrics, ICS, and gynecology, REI subspecialist, medical director of the SPHNNC Center for Reproductive Medicine and CEO of ETO Fertility and IVF Center. He's also a Merck Foundation alumni. He's from Ethiopia. We have next on the line Dr. Omaru Mana, a specialist obstetrician, gynecologist, and fertility specialist, public referral, General Hospital, Niger. We have Dr. Onyxia Chiguvari. He's head of managed care. Onyxia. I'm so sorry. She's head of managed care at First Mutual Health Company, Harare, and a Merck Foundation alumna. Again, I'm sorry. So we'll move on. Please give a big hand clap to our 7 panelists. So the first question goes to Dr. Nicholas Muzuguni. Dr. Muzuguni, how, according to you, has the Merck Foundation training helped you in starting the IVF center? Where's Muzuguni? Sorry. So this thing is all about getting to know each other. Sorry, Dr. Muzuguni, how has the Merck Foundation training helped you in starting the IVF center? And how is the new center and services provided helping or affecting the lives of your patients? Thank you.
Thank you very much. Good afternoon, everyone.
Good
It's
afternoon.
good time to talk after lunch, and I think panel discussion is the best. As one of the beneficiaries of Merck Foundation Make More Than a Mother program, I was very fortunate to be one of the first people who was trained by Merck in 2016. And we, together with my other 3 colleagues, we got trained in India, Bangalore. And the main focus of that training was purely on clinical care, but again on clinical embryology. And there are a couple of things that I would say they have come as an impact from this training. And next slide, please. So looking at what is happening now in my country, we've been working with the Ministry of Health in terms of addressing the fertility challenges, especially in areas where you have limited resources, human resources capacity. So working with Ministry of Health as well has been achieved, and at the moment we are working with the government of Tanzania to see how best we can establish the first public IVF at the National Hospital. And again, with these advocacies activities that we've been doing, just last year, our first female president, Her Excellency Samia Suluhu Hassan, she announced, she gave a very bold move during the independence celebration, that for the first time the government will be committed to make sure that these services are now available in our country. So advocacy has been one of the main activities that I've been doing ever since I graduated, and I've seen the results from this. The other impact that I've seen is the clinical care. As soon as I graduated, as soon as I finished my training, we managed to establish a first indigenous fertility clinic in our country. And we have been saving at least 5,000 couples every year with an estimated of 300 cycles of IVF every year. And we have seen quite a remarkable change in terms of understanding among our population. We have plans as an institution of establishing at least 3 more centers by 2025, and we have a plan for this. We have various collaborators that we've been working with, and we think that it will be possible. Currently, we are working on the establishment of a regional training center, and again, for fertility. And we're doing this because we believe that if trainings can happen within our very own country, for our very own people, then it is very easy to incorporate all other things like clinical care, research, and training at the same time. Capacity building is one of the things that we've been doing, and we have been conducting trainings for almost 3-4 years now, ever since I finished my training. And the trainings have been purely focusing on very simple things that you expect clinicians to miss. Things like proper evaluation of patient. You see, every time a patient walks in, like if it's a male factor fertility, people go straight away for semen analysis, and we think that is not correct, to be honest. So proper training on clinicians on how to evaluate patient and to refer these patients timely for treatment, we have seen that it has brought a massive, massive, massive change in our practice and in our society. We have been insisting that things like IUI should be performed at least at every clinic that they do fertility treatment. And we think this is a very simple technique that doesn't require a massive infrastructure, and we believe that it can bring about a big change. We have been organizing trainings and workshop at least every 6 months, and apparently we host at least every 3-4 months, we host at least 3 to 4 clinicians who are joining at our clinic for apprenticeship, and we call that cloning. And
thank you, Nicholas, for that presentation. I just want to highlight what Nicholas has done today, and it brings home the discussion from the senior partners yesterday. He is an example of one person who has not just been able to reproduce what was trained and has been able to clone himself. And in Tanzania, they are now multiplying the number of cycles and the number of healthcare. And what I want to say is that in the process of cloning, there should also be quality in cloning, and there should be evaluation. And I recommend this to everyone, that with Merck Foundation helping to sow one seed, that one seed should be able to reproduce himself all over. Thank you very much.
Thank you, Prof. So we now move on to Dr. David. Dr. David, we'd like to hear your thoughts. Just want to make sure. We'd like to hear your thoughts on the following points. What is the single biggest challenge in availing fertility services in your country? And how has the training offered by Merck Foundation helped you? And what is your approach to overcoming the challenges? Thank you.
Thank you very much. I would like to, first of all, appreciate Merck Foundation and the leadership of Dr. Rasha. Really, you've done a great job. Thank you so much. And thank you for giving this opportunity to try to address the challenges and benefits that we obtain from Merck Foundation. Really, as you know, in an African setting, really challenges appear the same, but the most important really we also face, we see that really like any other African countries, you find that assisted reproductive health technology services are really very scarce in our countries. Really, we are given training, but when you go back to our home countries, very rare to see these services available and even putting hands on. Be it on the side of patients, it's really still a challenge like any other African country where Rwanda is. And also, you come back to the skills. Very few skills that really we are lacking skills in our countries. And when it means skills, also management plays a big role. Thanks to Merck Foundation that really is doing capacity building in terms of skills development in our countries. We also find that we are lacking laboratory equipment. You find that really we need to equip our lab. So you find that really setting up labs for IVF is really expensive, and it's really a challenge like everywhere. There's also lack of awareness within our communities. So, and also the challenge that we are facing is the insurances. Like we heard from yesterday, even in today, insurances, they don't want to cover the medical part of infertility. So it's our role, thanks to Merck Foundation, whereby the media group is coming in even to start to advocate for insurance to cover them. So when it comes to benefits, what really we've benefited from Merck Foundation, really, yeah, it's measurable. Though we still face that fact of application of technology, I mean, the financial part to apply, but really, we appreciate, we benefited a lot. For example, on myself, when I came, this first time I came to Merck Foundation, really I was working in a government hospital, Runamit Hospital, but I didn't know, I didn't have that passionate, that knowledge, more exposure to handle infertility patients. I used to treat as a gynecologist infertility patient like any other patient, but no much, use of standard protocol. Even the outcome, I couldn't realize the outcome. I could just manage them like without using standard protocol. But thanks to Merck Foundation, I came to realize that really infertility patients need a lot of care right away, from counseling, from use of those protocols. And really, I came to get feedback, the success, and patients giving testimony. In the near future, I shall be doing research, and we inform Merck Foundation. Really, the statistical part of it is yet to come. So I also, after realizing how much Merck Foundation has done for us and gave me passionate, I decided to go. Can we go to last slide, please? The last slide of this. Yeah, really, I got touched by Merck Foundation when I went to India. Actually, I thank Merck Foundation. When we come to Dubai here, we learn a lot. This knowledge we get, not only sitting here, but what we find here, we apply. There's a lot to take back home and to learn. When I went to India, I met our mentors, our lecturers. That mom is called Milan Hospital. She taught us how it is possible. How it is possible, how she started. I also said, I will now save. I said to save. I went extra mile after working for public hospital and IVF, but I saw I should set up. So I set up my clinic here, and I think, thanks Nicholas, you're also one of the pioneers. We are crowning, but I think we shall go into your step. Thank you a lot. I'm also setting up this. I think near future will be shining around the region. And now we can manage patients, we shall go and do more extra time, and we move to the community. They know that they are not alone, actually. When I put up such a shelter, these women, they will know that they are not alone. You understand? And they will be coming. We shall be going to the community. We approach the community, and those who find us here, Professor, I think we are also starting to crown, but we shall go there. Thank you a lot. Thank you very much. Thank you.
Thank you, David. You've done very well. And what I can only tell you is that several years ago, I was like you. That is important. And you have to do some things, and now with people like us around, your problems are less. I'm now trying to encourage everyone here to be part of the regional and global associations so that you can attend meetings like this one and other meetings, and you get mentorship. And you all have my emails. You don't have IVF center now. You can start, like Nicola said, IUI. Your successes will spoil you, and also make sure of one thing. Write up, document what you do, and publish it. And you can get WHO grant. And I have good news for you. As I said yesterday, WHO has now developed the protocol for low-cost IVF. And once we profile it for about 6 months, it will be available. And so for somebody like you now that I know, which is the problem in Africa, we don't know each other. And Mark has done this for us. So I can just say, I know that there's David Meswinge in Rwanda. Let's send some product to him so you can use it. So this is a network for us to lift everybody up. Thank you.
Thank you. Thank you, Dr. David. So we now move to Dr. Thomas Gabriel. Dr. Thomas? Okay, so Dr. Thomas, we have 3 questions for you. The first one is, how do you feel IVF services in the public sector can be made more accessible and cost-effective to the general public? The next question is, please share your experience as a fertility specialist working in the public sector. And finally, we just want to know how Merck Foundation have supported you in establishing IVF in a public clinic. Thank you. You can use this.
Good afternoon. It's a pleasure to be here. Next slide, please. So regarding the establishment of public IVF center, I think my colleague Dr. Feroz in his testimonial in the morning has extensively detailed how our center came to be. So I would like to emphasize mainly on how to run a public IVF center. And I have been the CEO of this public IVF center, which is the first of its kind in Ethiopia for the last 4 years. And we had many challenges, especially running the center. And one of the most important things that we faced is a challenge of money, funding. Initially, it was funded by an NGO and the government, half of it by the government, half of it by the NGO. But then, to continue the service, we had to generate our own money. So how we tried to circumvent that problem is we divided the clinic into 2 wings, a regular wing and a private wing. And with the money we generate from the private wing, we were able to fund the regular service and also to incentivize the staff. So in the last 2 years, we had a private wing in the public IVF center, and we generated almost close to $500,000, which we were able to buy the consumables, the media, and everything else for the regular patients. And so it's very important that you secure funding in public IVF center. Another very important challenge is the checks and balances that are put in a government facility is usually very daunting. It's very hard to communicate with administrators, with policymakers, try to convince them that fertility is actually an important problem, because they are facing many other problems as a developing country. And as a specialist of the field, we have the prerogative and also the responsibility to show that this is actually a public health problem and it demands attention. And that's what we have been trying to do, and we are now in the process of ratifying the first law of its kind in infertility. We are planning to liberalize egg donation, sperm donation, and surrogacy, and we're trying to be an advocate in the field. Next slide, please. So overall, it has been a very good and satisfying experience. As for your third question, the role of Merck Foundation, which is found in the last slide, I think. Next slide, please. Merck Foundation has been there since the beginning. As Dr. Feroz has said, we had no embryologists, no trained clinicians when we began 4 years ago. And the first clinicians and embryologists were trained by Merck, 3 months with 3 months training. And they were supervised by staff from Michigan University and our colleague from Ghana, Dr. Kantu. And we were able to do 3 batches with them, and then we flew solo. And for the last 3 years, we have been doing it with our own embryologists, we've been doing it with our own specialists, and we've been having very good success, reaching as high as 47.5% in the last year. So, thank you. We also have a good REI program, a reproductive endocrinology and fertility program that have been running for the last 3 years. We have produced 3 infertility specialists, and we are also currently starting a clinical embryology MSc program, a 2-year program, and we have already graduated 1 batch, but we are going to continue enrolling, and we hope that embryologists from other countries, regional countries, also come and join us and be involved in this training program as well. And I would like to use this opportunity to personally thank Ms. Rasha, Dr. Rasha, and Merck Foundation for helping us since the beginning. You have been very kind in lending us your hand whenever we call. Thank you.
Thank you, Dr. Thomas. The next panelist to discuss his experience will be Dr. Okash. Dr. Okash, we have 2 questions for you. The first one is, kindly discuss, based on your experience, the scope and challenges of IVF care in the public versus the private clinics. The second is, what new facilities have you added to your hospital after your specialized training that was supported by the Merck Foundation, and how have your patients benefited from these? Thank you.
Thank you very much. It's not very common for a panelist to present using a slide. It's not that convenient. Anyway, whatever is there, you are invited to get a pick. I think I would start with the first question. What have we benefited from the Merck Foundation's fellowship program? I think I have alluded to this particular issue earlier, and Dr. Thomas has also probably got the better of it. But I just want to emphasize where we've been 5 years ago, and just give you a highlight of where we are now. Some 5 years ago, there was a single expat subspecialist for IVF who had a private clinic handling very small number of cases. That was all, and there was hardly any talk about ART. And as I said earlier, with the fellowship in REI that myself and my friend enrolled to, that was the first nucleus for the start of IVF in the country, I should say. And then, as I said, with the collaboration with the University of Michigan, we had all the trainings, but the hands-on training was missing, and Merck Foundation came at the right time, and we were able to take advantage of that fellowship, and then we had our hands-on training in India, and by then we were able to get our first public IVF center up and running, as was reported earlier, with the support of, again, University of Michigan, a colleague from Canada, from Ghana. We started doing IVF in batches, and we could shortly kick in the whole process and stand by ourselves. As I said earlier, Merck Foundation was at the center of every move that we have made since. As I have mentioned earlier, personally, it was my lifetime dream to be a part of provision of a complete, comprehensive service to infertile couple. It has been always my frustration throughout my career, fairly long career in obstetrics and gynecology, that I was not able to provide a complete care. And I have always aspired to have my own IVF center. It was, I should say, my younghood dream. So I was able to get involved in the REI, and then work in the public IVF, which gave me the opportunity, as you can imagine, working in the public IVF center, as I should mention here, gives you one important advantage. You have a better training opportunities than probably what you would get in private center. So the training opportunity and the eye-opening took me one step further. Again, with the help of the Merck Foundation, with my friends, colleagues, I was able to establish my own first IVF center. That you can have a picture in the third slide, or fourth slide, I think. There you go. So I think about the challenges Dr. Thomas has explained about the challenges of running a public IVF, money, and the challenges of management independence, I should say, would be at the core of the challenges of running a public IVF. When you're a public, it means a government system is always bureaucratic, I believe, as it is in most places. And IVF centers require extreme agility and independence. And that has been a problem. But as he has rightly said, we have managed to circumvent that by mixing the private wing to the regular service. But by the way, just to give you an idea, maybe this is an experience that everybody should take into account. Even though we call it a private wing, it is a very low cost IVF. I mean, because it is subsidized, because it is in the public center that we're providing. Even though patients do pay, the amount of payment that they make is so minuscule. I mean, so ridiculously small. If I tell you how much, it is like less than $500 for an IVF. What I'm talking about is a private IVF. So when we say private wing, we're not talking about like typical private center. So mixing those private wing services to the public services has helped us a lot in availing the service to the greater public, but at the same time address some of the issues. Thank you very much.
Thank you very much.
Panelists, we have Dr. Umaru. Okay. Dr. Umaru, your question is similar to that of Dr. Okash. We would like for you to tell us your experience about the challenges of running an IVF clinic in the private versus the public facilities. Thank you.
Thank you. Good morning, everyone. Because being clear, I will be explained in French because I come from French countries. Merci, bonsoir à tout le monde. Et je remercierai aussi la Fondation Merck pour nous avoir invités. C'est un honneur pour nous. La question, le challenge pour mettre en place un service de fertilité au public et le privé. Je commencerai par dire que on est au sud du Sahara, c'est un peu l'inverse. Parce que tout simplement, les priorités en matière de santé, c'est d'abord la mortalité, le VIH, le paludisme. Et quand vous venez parler de fertilité, ce n'est pas évident. Tout de même, la nature est faite pour que l'être humain se perpétue. Parce que mettre au monde, procréer, c'est ça aussi, c'est la façon pour l'homme de se perpétuer. Donc c'est un droit. Mais qui va garantir ce droit quand on va parler de droit?
I will stop myself. So I will try to do everything for now. Hello, everyone. I would like to start by thanking Merck Foundation for all their effort and for gathering us again here, talking about the challenges related to the subject in the sub-Saharan Africa. So the priorities are different because the priorities are talking about mortalities of HIV, of paludism, and then as the percentages of the fertility exams are between 15 and 10% in the country, it's not a priority for now. Please, doctor.
Donc, quand mettre au monde devient un droit, il faudrait qu'il y ait des lois qui le disent, qui encadrent, et c'est essentiel. Et
so it's a right for each woman to give birth, and then the right for the human being for regeneration.
Voilà. Quand on va parler de droit, il faut garantir ça dans une loi. Et pour permettre, parce que pour suivre le slogan de Merck, pour que le plus grand public puisse accéder à ces soins, alors il faut l'installer au public. Si on ne prend rien que ces deux critères, avoir accès et avoir la garantie par une loi, rien que sur ces deux critères, quand je veux appliquer en Afrique subsaharienne, vous voyez qu'il se dégage 3 zones différentes.
Okay. So because of this right, so to be able to have this right, we need to have a legal framework from a side. From the other side, we need to try to give access to the large public. So I have done my slide where we can see 3 different categories of countries that I could explain for now.
Voilà.
I have changed the slide.
Yeah. Voilà, vous voyez que ce qui est en bas et ce qui est en haut en vert, la couleur rose, c'est les pays du Maghreb. Et en bas, vous avez les pays anglophones comme le Nigeria, le Ghana, ou bien la Tunisie, le Maroc. Ces pays, c'est des pays qui ont une loi, mais qui n'est pas appliquée. Mais quand même, le privé a pu se développer. Il a pris le pas pour pouvoir donner accès aux plus nantis. Ça, c'est le premier lot. Le deuxième lot, c'est intermédiaire, en orange, où vous avez l'Afrique de l'Ouest francophone de façon générale. Et dans ces pays, la loi n'existe pratiquement pas, et ni le public ni le privé. Le privé, quand il y en a, c'est peut-être une seule structure, et donc c'est de façon très sélective. Ensuite, vous avez un peu en cendre, vous avez des pays de l'Afrique de l'Est où ces pays ont une particularité. C'est des pays qui ont pu accéder à des structures ni publiques ni privées, parce que c'est des fondations quelquefois des premières dames ou de structures universitaires qui sont soutenues. Donc, il existe la possibilité pour que le plus grand public ait accès, comme on le dit, low-cost IVF. Voilà.
So I'll try to summarize these 3 categories. In green, it's North African countries who they have a legal framework, but only the private sector is developed. The intermediate category is the orange one, where we can see Francophone or French-speaking countries of the West Africa, where we can see that in these countries we don't have a legal framework. And then for the third category, where we have the an access to infrastructure which is like supported by the first ladies or foundation, not really private or public sector, and then in general a large population have access to these structures.
Voilà. La dia suivante. Alors, on va aller vite. Mais quel est le défi? Le problème, c'est que vous allez voir, comme le commentaire est en anglais, je crois que les gens peuvent se débrouiller. Ce n'est pas forcément une priorité de santé. Et même quand il est dans l'hôpital, l'hôpital a d'autres priorités. Ensuite, les textes ne suivent pas, parce qu'il faut qu'il y ait un texte. Sinon, la fertilité, ce n'est pas comme l'informatique. Il faudra encadrer par la loi. Il faut savoir quelles sont les structures qui sont habilitées à le faire, et qui est habilité à avoir accès à ça. Et il faut fixer les prix. Donc, c'est des structures qui doivent être réglementées. Ensuite, il faut aussi la fertilité, il faut des standards en termes de laboratoire, des guides de bonnes pratiques. Comment il faut faire pour améliorer. Ça, on en a vu ce matin. Ce qui est particulier dans des structures publiques, c'est que vous avez des administrateurs qui ne sont pas forcément de la santé et qui ne comprennent pas vos besoins. Et dans ce cas, vous allez avoir des soins qui sont coûteux pour lesquels les lignes budgétaires ne permettent pas dans un hôpital de prendre en charge. Donc ça, ce n'est pas évident que les administrateurs puissent vous aider à développer vos structures et les soins. Ensuite, contrairement au privé, l'autre, dans le privé, c'est un secteur lucratif parce que dans des pays voisins où on ne connaît même pas le nombre de structures privées établies, aucune loi, et quelquefois on a des difficultés à les cerner. Mais la particularité, le professeur l'a dit, le professeur Oladapo, c'est que vous êtes administrateur, vous êtes le clinicien et vous savez de quoi vous avez besoin. Ceci facilite à ce que vous puissiez mettre en place une structure de fertilité. Ça, c'est un grand problème. Mais l'autre problème, c'est que le coût est élevé, ça ne donne pas accès au grand public et les gens n'ont pas la possibilité de savoir. Quelquefois, les couples qui partent dans ces structures sont victimes, ils sont escroqués. C'est pour ça qu'il faudrait absolument qu'il y ait une loi qui garantisse tout. Ensuite, qu'est-ce qu'il faut faire? Comment développer? Moi, je pense que Merck a trouvé la solution parce que ce n'est pas une priorité de santé. Mais quand on a accès, en faisant des premières dames, les ambassadrices de Merck Foundation, on a vraiment trouvé la solution, mais on n'a pas su bien appliquer. Dans des pays comme le Burundi, j'ai vu la présentation du docteur Gilbert. En passant par la première dame, ils ont pu avoir tout et dans les normes, les standards. Peut-être il manquait seulement la loi. Il faudra que ça soit encadré par la loi. Pour que qui soit habilité à le faire, qui peut le faire. Ensuite, créer les textes, c'est important. Mais il faudra aller à l'assurance. Vous savez, dans nos pays, si on ne dit pas que l'assurance, l'infertilité est une maladie comme toute autre, alors les assurances ne vont jamais prendre. Et enfin, pour terminer, il faut qu'il y ait un partenariat. Si les intrants de fertilité, ce n'est pas fabriqué en Afrique. Alors on ne pourra pas accéder tant qu'on ne nous donne pas les passerelles pour comment accéder à faible coût à ça. Ça, on en a besoin et on a besoin de docteur Racha pour qu'il nous aide à voir comment, même quand nous avons les moyens de commander, pour qu'on puisse accéder aux intrants. Merci beaucoup.
I will speak from the back. You can speak. You can complete it. 1 minute.
Okay, I'm here.
Yes, 1 minute, please. Can you just
Okay.
summarize?
In 1 minute, what I have done,
Yeah.
what he has done.
Yes.
No, he what is not in the slide. So I will explain what is not in the slide. What the doctor has said. He has said that Merck Foundation has found a solution by involving the first ladies as ambassadors. And then doctor has given the example of the Burundi, where he said that they are applying what they have to apply in a very well-mannered, apart from the legal framework, which is not really here for now. And then the doctor has emphasized on the fact that with the solution provided by Merck Foundation and then involving the first ladies, we need to do effort to work on the aspect which are not taken care of right now.
Thank you very much. Thank you. Yeah, so we'd like to emphasize the time, please. We are running out of time, so thank you for your understanding. We have now Dr. Onisia Onasai. Okay. Please, Doc, can you share your experience on how IVF and Merck Foundation, training in IVF have helped you as an infertility specialist? And your second question is, what new facilities have you added after your specialized IVF training, which was supported by the Merck Foundation? Thank you.
Thank you. Afternoon, everyone. My name is Dr. Onesai Chiguare. I'm from Zimbabwe, and I am a medical doctor in business. So I will explain the business part. So my presentation is titled Through the Looking Glass of My Journey with Merck Foundation. So I attained a postgraduate diploma in sexual and reproductive medicine, and I am currently pursuing a master's in sexual and reproductive medicine. So in 2020, under the sponsorship of Merck Foundation and the support of the First Lady of Zimbabwe, I embarked on what has become a 2-year journey to attainment of a master's in sexual and reproductive medicine. I am grateful to Merck Foundation and the First Lady of Zimbabwe for availing me this opportunity. Next slide, please. So has the Merck Foundation training equipped me as an infertility specialist? Yes. It has given me a deeper understanding about the management of infertility at primary care level. It has also given me a critical awareness of issues that affect the care of patients undertaking treatments in sexual and reproductive medicine. I also now have an advanced knowledge facilitating complex decision-making in unpredictable and complex situations. I also have mastered, as well as resultant autonomous working in an extended area of sexual and reproductive medicine practice. And then regulatory limitations in Zimbabwe require further qualification in obstetrics and gynecology, as well as a fellowship in reproductive endocrinology and infertility as a requirement for full licensing and practice. So our Medical and Dental Practitioners Council of Zimbabwe is quite stringent in terms of our qualifications in order for us to practice. So next slide, please. So what are the new services or facilities that I've added to my hospital after the specialized training? So I did mention at the start that I am a medical doctor in business. So I actually work in the corporate world at a medical insurance in Zimbabwe. I did actually work in the government sector for a long while, where I did implement an outpatient fertility clinic. But because in Zimbabwe, IVF, infertility treatment is quite expensive, there isn't much of that in government. And so what I wanted to do was to penetrate the private sector where there are a lot of funds, where people can actually invest in IVF and infertility treatment centers because they have the money. In Zimbabwe, infertility treatment is really for the people who have got money. And so I wanted to penetrate that sector to ensure that insurance, medical insurance in Zimbabwe actually start paying for infertility treatments, as well as invest in opening up health services that then look into infertility treatment. So I'm actually also in the process of attaining a master's in business administration so that I can actually learn how to do business. So in terms of what are the new services, I did implement an outpatient infertility clinic, which has good clinical governance. So the standard operating procedures that we're talking about, I did help develop those, and they are currently being used in the government hospital that I then left to serve in the private sector. So I also have done teaching and education. Sorry, may I please? Teaching and education of the primary care staff, so the junior doctors, the nurses who were under me. I also have raised awareness on infertility through poster display and leaflet handouts. And I've actually become a mentor where I'm able to proffer recommendations and treatment plans to my peers. Last slide, please, I'm sorry. And then how have my patients benefited from my training? So there has been improved support and engagement, which has made a difference in their lives, as through management of their fertility problems and subsequent conception and delivery, stigma, discrimination, and abuse have become a thing of the past for them. I've also helped them explore, understand, and adapt their ideas, values, and beliefs to impact their health-seeking behavior, thus helping them make a successful transition to a functional state, which is the mental well-being as well that we did talk about earlier. So to me, this is what this scholarship is all about, contributing significantly to making a change and an improvement in the health of a community. So thank you, Merck Foundation.
Thank you, Doc. So we have the last but not the least, our own Dr. Gilbert Mbintanga. Thank you. Dr. Gilbert, I know you share your experience previously, but just for the benefit of this panel discussion, we would like for you to share with us, if I may say again, how has the Merck Foundation training helped you in setting up your IVF, your public IVF, and how has the new center and services, provided helped your patients? Thank you.
Thank you very much. Good afternoon, everybody. We all know that we are here because of one problem, infertility in our respective countries. So to solve that problem, our country needs high specialized fertility specialists, embryologists, engineers for equipment maintenance. So according to my experience, I find that, especially in my country, Burundi, Merck Foundation Modern Mother Movement came as a key solution for those people who don't have children. It came for giving hope to the hopeless families. So I am asked the one question to share with you how I benefit Merck Foundation Modern Mother Movement when I was trained in India. I want to share that one by using these 4 levels. The 4 level is reaction. Second, learning. Another one, behave. And the last one, the result. From the first point, the reaction. When that movement was launched in the Burundi, it was in 2019. Many doctors know that we are going to be trained, and you can see them on the picture. We attended the program at the same time, and I was really motivated by that program. We take a flight to India. We met very interesting teachers. They teach us many things, theory, practice, and so on. After learning those things, we have to change. We have to change our behavior. Our behavior can change, and it can make a difference on the field. After changing the behavior, you can see on this picture, they are not showing the slide. You can see the next slide, please. You can see on this picture, this is the implementation of what we learned from India. How to set up a fertility center. That is when the equipment have reached in Burundi, and we start to think about how to set up. Now, the setting up was finished. We are planning to start. The next slide, please. This is the center. You can see it was really not easy to set up, but now, thanks to Merck Foundation partnership, now we are here. Everything is in place. We are planning to start by doing the simple techniques, ICSI and IVF, and I hope all of you are going to support us. Thank you very much.